I'm Cheryl Larson with the Midwest Business Group on Health. We are so excited to have you here today. We're going to get started on time and end on time. That's always our goal, and most of the time we reach it. This is an important topic for us today, one that we've worked very hard because chronic disease is one of the number one things that employers are focusing their efforts on. And in fact, you're going to see some of our brand new, hot off the press, Pulse of the Purchaser Employer Member Survey results today. If you're a member, you'll have access to all the results. And I wanted to start by, I get to switch my own slides today. That's me. Little bit about MBGH. We are one of the oldest and largest employer coalitions in the country. We represent self-insured public-private employers. We also have partner members. These employers are spending well over $15 billion annually. We've got about 4 to 5 million employees and lives. Well, it's one or the other, it's lives. And we are a community of your peers. So if you're sitting next to a member, ask them how they're working with other employers that are members. And if you're not a member, Mark, did you just walk out of, Mark is right here. He's our membership person. Thank you. Before we get started, I wanted to very quickly say we are asking all of our speakers to answer a question when they get started. We're asking them to share their personal trifecta for the perfect fall day. So you'll be hearing those, as I said, throughout the day. I realize that my personal trifecta, because we had dinner last night with the speakers and we asked the same question, is really boring. There were some great examples, pumpkin lattes, really good ones. Mine was, I like to open up all my windows and kind of air the house out when the weather gets cooler. I also love to pull the weeds and get my gardens, my perennial gardens ready. And then the third thing is with cooler weather, I'm going to try and tackle some of the poison ivy that's taken over my 3 acres. So that is mine. Not exciting, but it's my personal fall day. In a few minutes, we're going to ask you a similar question, and it's a polling slide. Let me go to the next slide. Here are some of our upcoming events. We've done a lot of programs this year. So good to see so many of you again that were at those. On October 1st, we've got a webinar on the case for non-GLP-1s, so anti-obesity medications, which is an important of a comprehensive element of a comprehensive employer's weight management strategy. On October 9th, we're going to be talking through one of our employer roundtables, calculating your lives and dollars lost to medical errors. Really exciting story from Rosemary Sam. Rosemary, are you in the audience yet? She's with Univar Solutions and how she found this very high cost claim through that tool. 21st, fireside chat on navigating cell and gene therapies, not only looking at the financial and the coverage models, but also where employers and practitioners are at and what their insights are, followed by November 6th for another fireside chat, a bird's eye view of cell and gene therapies from pharmaceutical manufacturers, consultants, and employers. Please make a note of these. We'd love to have you join us. We also already have January and March's program ready for 2026. We're going to be looking at the juxtaposition of digital innovation and personalization, a new era of employee well-being and engagement. That's a full-day hybrid program. That means it's in person in this room as well as virtual. March 11th, mental strength at work, from patchwork solutions to purposeful strategies. You can register at this URL. This is the first time with a large crowd we are announcing our 2026 46th annual conference. And here is the new logo, Employer Blueprint for Action. And I think the part that I'm most excited about it is that it's not a tagline, but those 4 words beneath. We need to unite as employers. We need to demand transparency and what we want in our contracts. We need to disrupt the marketplace and innovate. And finally, we have to repeat, because it's not going to happen the first time. We have to keep working at it. So make a note, May 4th is the employer pre-conference, employer only, and then the conference is May 5th through 6th. If you're here in person, please silence your phone or whatever you might have that would make noise. Please ask questions. We'll have people walking around with microphones. If you're participating virtually, use the chat function so you can ask those questions. You can communicate with other attendees. Let us know if you're having any technical issues and participate in the table discussions. We do have a short evaluation at the end of the day. And I am not joking when we say we do a virtual meeting of all staff about everything that went right and wrong at these events, and we walk through those evaluation results and pay attention to them. Here's your Wi-Fi password. I believe there's a card on your table as well. HR certification for those of you that are interested. If you have questions, ask Allison at registration, but here's your information. And thank you to our sponsors. We could not be in this just beautiful, beautiful facility if it wasn't for the support of the sponsors in this room. And if it wasn't for the support of our all of our members who help us shine throughout the industry. Here are some of our other sponsors: dinner, our purchasing arm, and our exhibitor sponsors. So some sponsors are in the back of this room and some are in the room right next to us where food will be served. We have a prize drawing. We always have a prize drawing. And you can see there's some really great gifts here. So make sure to participate in that. So how do you do that? You have a card, you were given a card, or it's at the table. You're going to have at least 10 out of the 15 sponsors. What are they going to do? Are they going to put a check mark or initials? Check mark, okay, that you visited them. And so once you have those 10, you're going to take it up to registration. And then for those that are virtually online, use the chat and Q&A functions to interact with other participants and ask questions of speakers. Those who interact twice are eligible for the prize drawing. How many of you have downloaded the mobile app, or if you need to download it? Excellent. If you haven't done it yet, go ahead and use the QR codes for Android or Apple. If you click on the icon in the upper right corner, you can find out if you're already signed in or not, if you've already been to a program. Verify you are at today's event, tackling the chronic condition trifecta. If you're having problems, you can click on more at the bottom. And Dawn, raise your hand. Dawn or Paula can help you download that if you're having any problems. We want to make sure everybody participates because we've got some polling that we're doing today. That's where your agenda, the PowerPoint presentations, and everything else is. Okay, give you just a minute to do that. For those of you who already have it downloaded, just a quick reminder, we're doing things a little bit differently. There are 3 words. We need 3 words to describe yourself, and it's going to turn into a word cloud. And with the word cloud, the more words that have been submitted that are the same, that word gets larger. So we'll look at some of the fun and interesting things you guys share. Enter 1 word per box. Additional boxes will pop up after each entry. I don't know what that means. So we're just going to 3 words. Send click, and then we'll share that with you. And again, a quick reminder, speaker bios, agenda slides, and more are in the mobile app. Curious about this odd question? What's the story? Organized, optimistic, engaging. I like that. Innovative, unflappable. Probably not going to get 2 or more of that one, but I sure do like it. Intuitive, love it. Great stories. A new one, positive. Wow, really needed in today's world. So your personal, oh, now I get it, personal trifecta. You're a curious person. That makes a lot of sense now. Friendly. Okay, unless another one pops up, we're going to move on. Thank you very much for playing our game. And now we have a word from our first sponsor, Lilly.
You'll get better when you're not blamed for a condition you can't control. You'll get better when your pain isn't minimized dismissed, forgotten. We will never stop trying to get better. Because when medicine gets better, all of us can get better.
So, hot off the press, mentioned this earlier, our annual employer survey, Pulse of the Purchaser. Want to share just a few things. For the last several years, we have asked employers, where do you fall? Are you, in terms of being innovative and doing unique things, are you an early adopter, follow the leader, catalyst for change? Do you do status quo, or do you wait and see? The numbers have just skyrocketed in recent years. And right now, early adopter, 35% of you feel you're early adopters, followed by 23% who are follow the leader. And that's okay. That's why many of our members are members of MBGH, because they want to learn from other employers, with 19% serving as catalysts for change. You can see in the upper right corner, the population sizes. This is representative of MBGH. The majority of our members are, I would say, around 48% are mid, between 1,000 and 10,000. And then the next category is 10,000 to 25,000, and then 25,000 or 50,000 and more. We asked about cost priorities and strategies, and attracting and retaining employees is the #1 priority for our employer members. And so are health and well-being benefits that play a crucial role. Some of the challenges are the rising healthcare costs that will lead to cost shifting to employees, rising healthcare costs that will impact competitiveness. And then add to that list on the far right, employers view health system consolidation and lack of transparency as additional significant threats. What about perspectives on significant threats to affordability? #1, drug prices. #2, high cost claims. #3, hospital prices. And 4, high cost cell and gene therapies. And as you know, MBGH not only has educational programs about this, we have a number of projects that we're working on about these things to educate, share best practices from other employers, and talk about how we can influence the market. I love the quote here: the current environment is a dumpster fire with unlimited fuel as long as employers and plans put up with the status quo. Last night, I talked to several people about what's going on in the marketplace. The stories curl my toes. We've been trying for years to get a hold of this dragon, dumpster fire, whatever you want to call it. We need to keep working on it, and we will. Perspectives on obesity. We tried to pull out some survey results that were specific to today's topic. I think this is relevant. 83% of you are providing lifestyle programs. 76 cover bariatric surgery. 49 cover branded GLP-1s for specific populations, either BMI or diabetes over obesity, et cetera. And then 48% are covering non-GLP-1 anti-obesity medications. If you hear the term AOM, that's what we mean. We're working heavily in this area right now. In fact, today we're launching an AOM employer action brief. In a few months, we're going to be launching a GLP-1 employer action brief, talking about best practices, why employers make decisions to cover or not cover, and what the real impact of these medications are having. Also, what's in the pipeline. Our corporate medical director, Jan, are you in here? Jan, Dr. Jan Berger, raise your hand higher. Yeah. She came up to me and she said, we don't have the patient perspective here today. And then she said, I'm a patient and you're a patient, and we have experiences in this area. And so that story is very important. If any of you have stories to share, please see she or I. And it may be a patient that actually comes, but we're patients too, right? What about perspectives on obesity? So you can see on the left, it says of the employers currently covering GLP-1s, many are considering additional tactics to mitigate costs. And you can see in the middle, the trends in terms of coverage, limiting access to specific populations. We just saw that. Coverage of compounded, 30% of you are currently doing it. We're always a little concerned, unless you trust the vendor that you're going to, about those compounded drugs, where they come from, et cetera. 12% of you are ensuring access to GLP-1 based on beneficiary lifestyle changes. So that might be a requirement. Partnering with a point solution vendor to manage your access to GLP-1s. There are some great solutions, point solution providers out there that are taking care of all of those issues that could happen about getting the right medication to the right patient at the right time. You'll see those that are currently doing it in the red and that are considering doing it in 1 to 3 years. And I think that's very important. So real quickly, I'm switching gears. We have an organization that many of the employer coalitions in the country belong to. It's the National Alliance of Healthcare Purchaser Coalitions, and they have 10 free passes for employers. If you're interested, see any employer, or see any staff person or Allison at registration. You have to pay for your travel, but it's a 2.5 day event that is very good, and I think you'll benefit from it. Let us know. And now a word from our sponsor, Flight Health.
The healthcare ecosystem continues on an unhealthy trajectory. Shrinking access to PCPs, cost of new life-changing drugs, GLP-1s, increasing healthcare utilization, and the growing burden of chronic conditions all threaten the ability to deliver healthcare efficiently to the people that need it the most. The most significant contributor to this healthcare crisis is obesity. And Flight Health exists because more than 75% of Americans are living with obesity and overweight. Flight Health built its clinical model to treat top chronic conditions like prediabetes, diabetes, hypertension, behavioral health, and others, because we know that obesity is the key driver for many chronic conditions. Flight Health has optimized its ability to partner with healthcare systems, carriers, and pharmacy benefit managers, because we know that 1/3 of Americans have 3 or more of these top 5 chronic conditions, so provider collaboration is paramount. We combine lifestyle management with a flexible approach to GLP-1 and non-GLP-1 administration, whereby 60% of our patients receive lower-cost non-GLP-1 alternatives, helping save millions for our clients in the first year alone. Each of our clinical care team members undergoes rigorous training on our proprietary clinical approach to obesity management. We also leverage in-house dietitians, wellness coaches, and care coordinators who help our patients optimize their use of our app to provide the traditional lifestyle modification tools like food and activity tracking, lessons, and progress tabs, with the ability to schedule appointments with our clinical care team.
I love these vignettes, I call them, because it gives me an opportunity to understand that vendor in about a minute and decide if I want to go visit them, if they're a good fit for me. We encourage you to visit all of the people here because then you can get a lot done in a short period of time. I want to thank all our sponsors again. So I would love to introduce our first speaker, who, by the way, is going to share some personal stories. I have some personal stories in this space, and she's going to be here until lunchtime. So if you want to talk to her, make sure to do that before then. Dr. Veronica Johnson is an obesity medicine physician and assistant professor in the Department of Medicine, Division of General Internal Medicine, Northwestern University Feinberg School of Medicine. A lot of medicines there. Her research interests include healthcare disparities in obesity management, treatment of obesity in pediatrics, adolescents, and adults, and integration of obesity in primary care. Dr. Johnson will share some foundational information about this trifecta of conditions and how obesity is at the center of it. Let's welcome Dr. Johnson. Thank you so much. Do you have water? Do you need water?
No, I'm good. Good morning. It's a pleasure to be here today. I actually was first introduced to this organization in the spring, and I was at the forum and got to talk specifically about obesity and these medications. So I'm happy to be back and talk specifically about obesity and the trifecta of obesity, cardiovascular disease, and type 2 diabetes. But it does start with obesity treatment. All right. So this is a quote from one of my colleagues and mentor. Overeating does not cause obesity. Obesity causes overeating. And undereating does not fix obesity. Fixing obesity leads to undereating. There are a lot of different causes for obesity. It's not just a lifestyle condition. On the slide, you can see all the different factors that are involved in why one patient struggles with their weight over another. There are individual factors, most importantly, genetics playing a role, but there's also environmental factors that make it more challenging for our employers and patients to struggle to manage their weight. And as mentioned previously, this disease of overweight and obesity is not going away. So currently about 42% of US adults have obesity based off their BMI. And it's expected by 2030 that this prevalence is going to increase to nearly 50%. And that does not take into account those with overweight based off their BMI. And on the slide here, you can see where the prevalence of this disease is more evident. You can see it in where we are in the Midwest, and then most especially in the southern regions. Obesity is far more complicated than just a body mass index, which is just a proportion of your weight to your height. It's simply put as excess body fat, but this definition on the screen is made by the Obesity Medicine Association, which really encompasses what obesity is. Simply put, excess body fat can have an impact on every aspect of one's health. So metabolically, biomechanically, and psychologically as well. And so we'll go into the neurobehavioral aspect of obesity because that is actually the most important organ that really regulates our weight. It starts in the brain. So this is probably a little bit more complicated slide than you'd like, but basically I want to show that there are signals that are made outside of the brain, and those different signals are hormones. And those hormones have receptors within the brain that downregulate how we look and regulate our weight, whether that be how much we eat or how we look at food, our food noise, and other factors. So what happens is we know that obesity is not just due to overeating. We have individuals that are predisposed to having obesity. And when they have these signals that are abnormal, that basically affects their hunger. So they're feeling more hungry. They have decreased satiety. So they're not feeling as satiated after they eat. And then they also have these more thoughts around food, like food noise. And eventually, those all go to expand the amount of body fat that we have, that adipose tissue. And then adipose tissue, when we have increased amount of adipose tissue, has a down regulatory effect in our body. And so that excess body fat can basically cause all these other detrimental effects to really important organs in our body. And you can see here on the right that excess body fat can show in your intestines. They can show in your liver, where you can have excess fat disposition in your liver. It can affect how you metabolize blood sugar and lead to hyperglycemia or type 2 diabetes. And it also can affect your heart and lead to cardiovascular disease. And again, these are the specific hormones, probably a lot more than you probably need to know today, but just to know that these specific hormones that are produced by adipose tissue or excess body fat can have this down regulatory effect and affect all these different other health conditions. So basically, again, obesity is the root of all of this. We know that there are 200 different disease states, over 200 different disease states affected by, if you have obesity, you're at increased risk of having these disease states. And you can see a sample of some of these more common conditions. I highlighted cardiovascular disease because that is part of the trifecta. And I also highlighted type 2 diabetes because that is also part of the trifecta. So again, obesity affects everything. And if we treat obesity, we are helping our patients, we are helping our employers, decreasing their risk of having other weight-related conditions. There's a term called cardiodiabesity, which is basically an overlap relationship between having cardiovascular disease, diabetes, and obesity. This term is actually not very well known in medical literature, but it was actually introduced by Evernorth Research Institute, which is affiliated with Cigna. And so they defined cardiodiabetes by these two specific phases. They defined early stage cardiodiabetes by having cardiovascular disease, which includes having stage 1 hypertension and high cholesterol with prediabetes and overweight. So if you had any one of those conditions, you would have early stage cardiodiabetes. But those who had cardiodiabetes had either cardiovascular disease, including more advanced hypertension or stage 2 hypertension, vascular dementia. They either have type 2 diabetes or more advanced chronic kidney disease, and then again, having obesity based off their BMI being over 30. So I have a polling question for you all. Based off of the criteria for cardiodiabetes that I just discussed, how many US adults have at least one comorbid condition for early stage cardiodiabetes? Is it 1.5 million, 1.8 million, 2.5 million, or 3.7 million? Oh no. Sorry. I didn't mean to show the answer, but yeah, take some time to come up with an answer. Hopefully not many saw the answer.
You can change it because it'll change.
Oh, okay. Oh, that's how that works. Oh, I apologize.
It is. Oh, the poll got hung up on.
So I guess I gave the answer. Oops. We're good? Okay. Well, the majority of you got their answer correct. It's 3.7 million. And this is based off of data specifically from Evernorth Research Institute. So I will say, if I was to define cardiodiabetes, I would probably include other cardiovascular diseases like heart failure or like atrial fibrillation or even coronary artery disease. That is not really in this diagnosis. So I think that there's probably a lot more people than 3.7 million patients who actually have one comorbid condition that could be cardio or early stage cardiodiabetes. And again, this is data from 2019 to 2021. It's based off of claims. We know that this disease state is increasing, so we're 5 years behind with this data, at least. You can see the distribution of cardiodiabetes based off of age, gender, region, and social determinants of health index. So those who are between the ages of 50 to 64, there's a higher prevalence of having at least one comorbid condition with cardiodiabetes. It's more prevalent in females, more prevalent in the South, as mentioned before, and higher risk around those who have more social determinants of health, like low social economic status, low education. But why is this important? I think this was also discussed previously briefly, but cardiodiabetes is the leading cause of death in the US, and it's causing a big strain on our healthcare system. So Evernorth Research Institute estimates that there'll be over or close to $719 billion annually spent on treating cardiodiabetes. And with the use of higher priced medications, this figure is expected to increase. People with at least one cardiodiabetes related condition are at risk for developing others because this is a progressive disease. And again, because of the growing prevalence of those with diabetes and obesity, there's expected to be a growing amount of people with the trifecta of cardiodiabetes. So how do clinicians decrease the progression to cardiodiabetes? I think it starts with addressing this trifecta, and it begins with obesity. So this is kind of how I approach obesity treatment or overweight treatment in my clinic. I look at things beyond body mass index because we know that that is just a screening tool, and there's a lot of flaws around just diagnosing obesity with just a body mass index. So beyond that, we want to confirm that a patient actually has excess adipose tissue, excess body fat. And we can do that by measuring a waist circumference. And I know on the slide here it's a little smaller, but the waist circumference in those who have excess body fat, it's usually over 35 inches for women and over 40 inches for men. We can also calculate what they call a waist to hip ratio. And if that's over 0.5 ratio, that can also designate excess body fat. So we're not just using BMI, we're using these body size measurements to confirm the diagnosis of obesity based off having these excess body fat. And having these extra measurements, having these measurements of body size are really important in some of their patients who have less severe obesity. So if they have like a BMI between like 27 to 35, they may not have obesity or have excess body fat. And so we have these extra measurements to actually confirm if they have the disease. But beyond having these anthropometric measurements, we also look at how the patient is presenting clinically. Is the patient having signs and symptoms consistent with having obesity? What's their blood sugar like? What's their blood pressure like? Are they feeling that the excess weight that they're having or the excess body fat that they're having is having a detrimental impact in their overall activities of daily living? And so that's how we look at it in a clinical setting, is looking at whether the patient has excess body fat, taking that anthropometric measurement, and then looking at it clinically. And so from that, we can diagnose clinical obesity. And this was from the Lancet Commission that was published some criteria back in earlier this year to define what clinical obesity is. And there's been a lot of controversy in the medical community about this specific criteria. So we're still working it out, but I think it's important to recognize that we're not diagnosing, or we should not diagnose obesity solely based off the body mass index. And you can see here that obesity or having obesity can present clinically and virtually affect every organ system in the body. And we'll talk more about that, especially in the trifecta, the cardiovascular disease indications, and then type 2 diabetes. So how do we treat obesity? I think it's important to recognize that there's a lot of different options to manage this disease outside of just lifestyle interventions in themselves. We have pharmacotherapy, we also have surgery, and you can see on the bottom what the average expected weight loss with each of these modalities is. What's important is there's an arrow on the bottom. So all our patients should have access to all the available treatment options, because some patients may not respond as specifically to lifestyle interventions. They may need medications, they may need surgery. And at any time in their disease state, because this is a relapsing progressive disease, we might need to offer all the other options to these patients. And we also, in my clinic, look at achieving at least 10% body weight. But we know that if patients even lose 5% of their body weight, we'll see improvement in their blood pressure and their blood sugar. But if we're looking at this trifecta and trying to decrease risk of having diabetes, or if our patients or employers have type 2 diabetes, we really, really need to achieve at least 15% body weight. And those who have cardiovascular disease, to decrease cardiovascular mortality, we are looking at achieving at least 15% body weight. But you can see the benefits that you can see from a health perspective when you lose at least 5 to 10% body weight, or even 10 to 15% body weight. So I have a case. This is a case of one of my personal patients. I've been following him for the last 2-3 years. probably don't need to read all of this, but I'll summarize it very simply. So this is a patient who had class 1 obesity, and he presented with several risk factors for cardiovascular disease, with hypertension, high cholesterol. He also had pre-diabetes, so again, at risk for progressing to type 2 diabetes. He noticed that despite doing all the lifestyle interventions, he was not able to lose his weight. And it was steadily increasing weight, even with the diagnosis of obstructive sleep apnea and using CPAP. That can happen, you can gain weight. And so you can look and see all the medications he was doing. He's doing not the recommended amount of physical activity, but he was doing some physical activity. And so he was really struggling. He came to me, and you can see he had a BMI of 34. I unfortunately did not measure his waist circumference at that time, so I can't tell you, but I can say based off of having that BMI and then also knowing all the comorbid conditions he had, that it would be really beneficial for this patient to lose at least 5 to 10% of his weight. Notably, he was drinking a significant amount of alcohol. So we were going to address that as well, because that can definitely contribute to making it more difficult to manage weight. But here's his labs, notable for an A1C of 5.7, so pre-diabetes. His triglycerides were significantly elevated. Ideally, we'd like the triglycerides to be less than 150, and his was 498. This was fasting. And so we came up with a plan. We were like, okay, what are we going to do? So again, focusing on lifestyle interventions, but then thinking about what other adjunctive therapies, since he had failed lifestyle interventions when he came to see me. So we talked about nutrition. I got him with a dietitian. We did focus on trying to reduce his alcohol intake. Talked about walking more, but I didn't mention this, but he had interstitial lung disease. So that was really affecting his functional capacity as far as doing more activity. So he was just trying to do as much as he can. He was maximizing his sleep, using his CPAP for sleep apnea, but ultimately we decided to start him on semaglutide 0.25 to use as an adjunct to those lifestyle interventions. So I'm going to talk a little bit more now about those pharmacotherapy options. I will revisit my case later and what happened. But these are all the FDA-approved anti-obesity medications. As you can see, there are the CNS drugs that are the non-GLP-1 drugs. Commonly, we hear a lot about phentermine, but there's also a drug called Qsymia that has a combination of phentermine to pyruvate. There's bupropion with naltrexone or Contrave. Setmelanotide is for a more rare form of obesity treatment. We don't use that a lot in clinical practice. On the right side, some other medications that we don't really use a lot in clinical practice include orlistat. There's a hydrogel capsule called Plenity, which is actually found over the counter now. The miscellaneous is not very effective, but it is an option. And then we have these endocrine agents, which include this GLP-1 receptor agonist or dual agonists, including GLP-1 and GIP receptor agonists. And you can see the first GLP-1 receptor agonist for type 2 diabetes management was liraglutide, or one of the first. That's a daily injection. And then we have semaglutide and now the dual agonist tirzepatide. So does anyone know what these GLP-1s are, what they do? I feel like we hear a lot about it, but we're just like, what is it? What are these? So GLP-1 is glucagon-like peptide 1. It is a hormone that all of us produce in our body. It's produced in the small intestine. It's produced in the pancreas. It's produced in some neurons within our brain. And what happens is after we eat, this GLP-1 is released in the small and large intestines. And it basically makes us feel full. It slows down how fast our stomach empties. And it also regulates our blood sugar. But in all of us who are not using these drugs, this GLP-1 activity is rapidly degraded. So it's only really active for about 1 to 2 minutes because GLP-1 is naturally degraded by another substance called DPP-4. And so when we have what we call these GLP-1 drugs or GLP-1 receptor agonists, these drugs mimic what GLP-1 naturally does in our body, but it allows that activity to last a little bit longer. So the GLP-1 receptor activity is not as rapidly degraded in the same fashion as a GLP-1 that's naturally occurring in our body. And these are not new medications. So some people are like, well, it's too new. I don't want to try it. GLP-1 receptor agonists have been around since 2005 for treatment of type 2 diabetes, and they've just gotten better and better over time. So the first GLP-1 receptor agonist was exenatide. It was a twice daily injection for type 2 diabetes management. I mentioned liraglutide at 1.8. Victoza was approved for type 2 diabetes. And then we have semaglutide that's approved for type 2 diabetes and obesity management in both a subcutaneous form and an oral form for just type 2 diabetes and in the oral form, and the oral form will be approved for obesity treatment soon. So here are the current indications for GLP-1 receptor agonists. Again, GLP-1 receptor agonists are approved for type 2 diabetes. They're approved for chronic weight management. So these are not intended to be used for short-term purposes. So long-term to help induce weight loss and also help maintain weight loss. And they're approved in those who have overweight with at least one weight-related condition or the disease of obesity. That includes liraglutide 3.0, which is Saxenda, semaglutide 2.4, which is Wegovy, and then tirzepatide, which again is a GLP-1 GIP dual agonist, tirzepatide. Semaglutide, as noted here, it has the extra indication to reduce risk of major adverse cardiovascular events in adults who already have an established cardiovascular disease and also have overweight and obesity. And then coming soon or recently just started or approved, semaglutide 2.4 is also approved to treat MASH, which is metabolic dysfunction associated steatohepatitis with moderate to advanced liver fibrosis, which is exciting. So again, semaglutide 2.4 is approved for overweight and obesity, a decreasing risk of having a major cardiac event, and now MASH. And then tirzepatide is approved in those who have, as far as weight management, Zepbound for overweight and obesity, and also have the added indication for treatment of obesity in those who also have moderate to severe obstructive sleep apnea. I know it's a lot. Sorry. So when we're using these GLP-1 receptor agonists, it's important to note what these goals are care. So it's not just about inducing as much weight loss as possible. My goal is to decrease the amount of excess body fat my patients have while also decreasing their risk of having obesity-related conditions, and most especially making sure they're not losing too much muscle as they are trying to lose weight. And so it's important to use these as tools in combination with nutrition and physical activity, and especially reinforcing the importance of increased protein intake and incorporating strength and resistance training as you're utilizing these therapies to preserve that muscle mass. So I'm going to talk a little bit about the efficacy of these drugs. On the left, you can see that this is the data from STEP1, which is the first clinical trial to assess the safety and efficacy of semaglutide 2.4 in those with overweight and obesity. And you can see, well, I didn't highlight it here, but on average, over the course of a 68-week trial period, participants in this trial lost about 15% of their total body weight. And this was also in combination with lifestyle interventions, counseling on a reduced calorie diet, and increased physical activity. What's highlighted here on the left is the percent body weight loss. So obesity is a multifactorial disease. There's a lot of factors involved. Not everyone is going to respond to the therapy the same way. So you can see here what the categorical weight loss. So what percentage of participants in the trial lost at least 5%, at least 10%, at least 15%, at least 20% of their body weight. And remember, the health outcomes improve with more weight loss. So close to a third of the participants in the trial lost over 20% of their weight on semaglutide at 2.4, and again, over a 68-week trial period. On the right, you can see the data from SURMOUNT-1, which assessed the safety and efficacy of tirzepatide in patients with overweight and obesity. On average, at the highest dose of tirzepatide, which is 15 milligrams, participants in the 72-week trial lost about 21% of their weight, but still also clinically significant at the lower doses at 5 and 10 milligrams. And then on the bottom right, you can see that categorical weight loss. And so again, looking at the response here, clinical response of close to 37% of the participants on the highest dose of tirzepatide at 15 milligrams lost over 25% of their weight. One thing I like to highlight here, and I will highlight again, is that, not all of the participants in the trials lost a significant amount of weight. So if you look and you're like, okay, well, 92.4% of those on semaglutide 2.4 lost at least 5% of their weight. Well, what happened to the other 7%? They didn't lose weight. So again, there's going to be a variable response to the therapies. And again, this reinforces the importance of offering all treatment modalities to patients who have overweight and obesity. Semaglutide 2.4 is also approved. This is my pediatric side. So it is approved for adolescents ages 12 and 17. And this is the data supporting why it is approved for that indication. The data is very similar to what we saw in the adult data. So about 15% total body weight loss in children 12 to 17 for management of obesity. And we did talk about the cardiovascular risk reduction. There is a large trial, was worldwide. It was called the Select trial. It enrolled about 17,000 patients that either had a BMI, well, they all had a BMI of 27 or greater, and they had pre-existing cardiovascular disease, including a history of a heart attack, a history of stroke, or peripheral artery disease. And they were administered semaglutide 2.4 and followed over an average of 33 months. And what they found that regardless of weight loss, because these patients were not counseled on a reduced calorie diet, increased physical activity. So regardless of weight loss, there was a reduced cardiovascular causes. So there was less risk of having cardiovascular disease, decreased risk of myocardial infarction or a non-fatal stroke, and that reduced by about 20%. So I just want to reinforce that these drugs are not just promoting weight loss, but they're having weight-independent effects on the overall health of our patients, my patients, your employees. This is the data around Zepbound and why it is approved for treatment of obesity and in patients with moderate to severe obstructive sleep apnea. A lot of things here. Basically, the thing to note is that there was a reduction in the apnea-hypopnea index, the AHI, which we use to designate or diagnose the severity of obstructive sleep apnea. And so in the participants in this trial, and these participants were either on CPAP or off CPAP or not on CPAP. And there was a decrease in their AHI at the end of the trial, which was about 52 weeks, along with the weight reduction. There was a head-to-head trial looking at Zepbound in comparison to Wegovy. So open label trial enrolled patients. They were either randomized to receive the maximum tolerated dose of tirzepatide at 10 and 15, or the maximum tolerated dose of Wegovy at 1.7 or 2.4. And you can see over the course of the 72-week trial, those who were on tirzepatide or Zepbound lost more weight. And they had an increased reduction in their waist circumference. So this shows both of these drugs are very effective, but head-to-head in this trial, Zepbound had the overall improved more weight loss and more reduction in waist circumference. This slide here is just to reiterate that there is a variable response to use of these therapies. So this is what we call a waterfall plot. On the top left, that is a representation of basically every patient who was in the first trial looking at the safety and efficacy of semaglutide at 2.4. And so any patient below the x-axis lost weight. So one patient in this trial lost 40% of their weight. But then there are some patients, if you look more further towards the right, there's a small percentage of patients who were in this trial that actually gained weight. And that's unfortunate. But the other thing on the right is looking at what happens or how individual responses with tirzepatide at 15. And so you can see while most of the participants in this trial lost weight, there was 2.3% of the participants that actually gained weight while they were in the clinical trial, and they were on the highest dose of tirzepatide. These are some other clinical trials getting done right now, specifically in tirzepatide. So we're going to see an indication for tirzepatide for management of type 2 diabetes in adolescents, and participants are children ages 10 to less than 18 years old. That data is actually already published. They're conducting a trial to look at the safety and efficacy of tirzepatide in adolescents with overweight and obesity. So that added indication will occur. And also looking at tirzepatide in those who have underlying cardiovascular disease to see if there's an added benefit for tirzepatide for cardiovascular disease risk reduction. The SURMOUNT-MAINTAIN trial is also really important because, like I said, these drugs are approved for long-term use and we know that if you stop using the drug, there's a possibility that you can regain weight. But the SURMOUNT-MAINTAIN is actually going to assess if patients need to be on the highest dose of the drug to help maintain weight, or if they can be on a reduced dose for weight maintenance. So that'll be coming out next year sometime, the results. So based off that, we know that GLP-1 does a lot more than just regulate blood sugar and decrease our hunger and appetite. We're having all this data that shows that GLP-1s do a lot more in the body, and we have added benefits, which I didn't talk about, but semaglutide can also help with management of diabetic kidney disease and also management of osteoarthritis. But we're also studying these drugs in a lot of other indications, like looking at it in addiction and Parkinson's and Alzheimer's. We're looking at it in treatment of patients who have type 1 diabetes, inflammatory diseases like psoriatic arthritis. So there's a lot more indications for these drugs that we might be seeing in the pipeline. And there are probably over 100 different drugs in the pipeline being investigated right now for overweight and obesity treatment. This is just a list of some of the ones in the immediate future that you're going to see. Notably, the semaglutide at the oral form will probably be available for use towards the end of this year. But then we also have an oral non-peptide-based GLP-1 or forglipiron that will probably be available within the next year, and a combination of cagrilintide, which is cagrilintide is an amylin agonist. So we have a combination of GLP-1 with amylin agonist. And then retatrutide, which is a triagonist, including a GLP-1, GIP, and glucagon receptor agonist. So it's important. It's a lot of exciting things in the pipeline for me. More options for our patients and our employees. So back to my case. So like I said, I've followed this patient since 2022. I last saw him actually in January. You can see how his weight has changed over the last 3 years. So he lost about 40 pounds, which is 18% of his total body weight. As I stated before, we started him on semaglutide. He got up to the highest dose of semaglutide at 2.4. I did transition him to tirzepatide. And you can see that his blood work is all improved. So he no longer has prediabetes. His triglycerides have decreased significantly. So we have decreased his risk of having cardiovascular disease. But outside of those benefits, like he's no longer on blood pressure medicines. He's having less flare-ups from his gout. He's not drinking alcohol because this drug has significantly decreased his urge to even drink. And he's actually been a little bit more open to adhering to a high protein, high fiber diet with the use of these drugs, which is great. I'm going to talk briefly about surgery. I'm running out of time, but I think that this discussion would not be appropriate if I did not talk about surgery. So the most common surgeries that are done here include the sleeve gastrectomy and then the gastric bypass. As mentioned before, this promotes about 30 to 35% on average weight loss in patients who are on who have had surgery. These are the indications for surgery. This is based off of the ASMBS, the American Society for Metabolic and Bariatric Surgery. They recommend bariatric surgery for patients who have a BMI over 35. If a patient has type 2 diabetes with a BMI over 30, bariatric surgery is an option. But we can also consider bariatric surgery in those who have BMIs as low as 30 if they don't achieve weight loss with non-surgical options. And we can do surgery in kids too. So I bring that into because I'm a pediatrician. I wanted to bring up this data because I still feel strongly that bariatric surgery can promote it. It's the durable tool that can promote significant improvement in cardiovascular disease risk factors. And so this was a trial that was done. They basically reviewed over data from the Veteran Health Administration. So they looked at electronic medical records and basically, they compared those who were in a medical weight management program, the MOVE program, and those who actually had weight loss surgery. And they wanted to see like what happens as far as comorbidities with those who were involved in a medical weight management program versus those who had weight loss surgery. And what they found was those who had surgery, they had a decreased risk of having diabetes, hypertension, and hyperlipidemia. This was a similar finding that was found in what they call the LAB study. It was an NIH-funded study that longitudinally followed participants who had bariatric surgery over a course of 7 years. They lost over the course of 7 years on average 28% of their weight, but there was a decreased risk of them having diabetes and other cardiovascular diseases after their surgery. And the same data is present with kids who've had weight loss surgery, and that's the Teen Lab study. This is a trial or a paper that was just recently published comparing the treatment of obesity using bariatric surgery in those who've had those who have used GLP-1s. And so again, it's a retrospective study reviewing over electronic health records and basically trying to see like how much weight loss people lose on GLP-1s versus surgery, and then also assessing the cost. And overall, the cost savings is still significant for bariatric surgery. So you end up losing or saving more money offering bariatric surgery. And then there's also a decreased risk of having more of those comorbidities after bariatric surgery in comparison to utilizing GLP-1s. But how do we decide which one of these therapies to consider? Me as a clinician, I want to look at the disease severity. So in my patients who have more mild forms of obesity, they may not be candidates for weight loss surgery. So maybe we need to utilize, we have to utilize the non-surgical options. But I think for those who have severe obesity, a BMI over 40, despite how effective these drugs are, there's still going to be a role for surgery. My question is, do you see more weight loss in those who've had utilized the medication preoperatively, or do you feel like we should do the surgery first and then utilize the medication after? So we're still trying to figure that out. Another key consideration if you're considering a GLP-1 versus bariatric surgery is like what comorbidities are present. And assessing if the surgery would be more beneficial in comparison to medications. And then ultimately, it is the patient's decision, right? So there's a lot of misconceptions around bariatric surgery. I think we all know the 600-pound life. And so there's just patients are just like, oh, I don't want to do that. And so you have to listen to my patients, your employees, and not saying like they shouldn't be pigeonholed to have to do a certain treatment. The other thing just to recognize is even though GLP-1s are so effective, again, they're approved for long-term treatment. So I recommend that they're used long-term. And some of my patients who don't want to be on medications long-term, they rather have a surgery and know that their weight is going to be controlled and they don't have to take a medication forever. So this is my last slide. This is the employer's role in obesity treatment. So what do you take away from this? It's important to recognize that obesity is far more complex than just BMI and lifestyle interventions. Recognize that obesity is the root of trifecta, and so treating obesity can decrease the risk of having other concurrent medical conditions like type 2 diabetes and cardiovascular disease. And lastly, important to provide your employees with every evidence-based treatment option to manage obesity. So this can ultimately promote a healthier workforce, increase productivity, and aid in employee retention. Because I know a lot of employees are looking at coverage for these medications, and they're deciding if that's going to ultimately be a company that they want to work for. So all things to think about. Sorry, I went over time, but that is it. Thank you so much.
Let's thank Dr. Johnson. We're over time, but I think it's important. No, that's okay, that we give people an opportunity. We've got a number of questions on the phone. You choose your two favorite, Paula, and Dr. Johnson will answer it.
Sure. Thank you, Dr. Johnson. So one of the online questions, I'll go to the more clinically based questions, was if there are any known natural treatments that can mimic the GLP-1 drug in the body.
No.
Okay. Very fast answer. Thank you. The
Second question.
Yeah, the second one was, are there current medications to regulate the DPP-4 that you talked about?
There are. So that would be the SGLT2 inhibitors that the DPP-4 inhibitors is a class of drugs that are available for treatment of type 2 diabetes. So like Januvia is a big name, sitagliptin, that's a DPP-4 inhibitor.
So would those be complementary to each other or alternate?
So you could not be on a DPP-4 inhibitor and a GLP-1 receptor agonist.
Okay, one or the other. Thank you.
And I think Dr. Johnson said she'd be here until lunchtime. And so if you have questions, she'll be here during the break. I'm going to introduce our next speaker.
And I'll just say, you can find all of those slides. It was very tiny print, but you can find all of those slides in the mobile app if you want to look at any of that data. Thanks for sharing your slide.
And we have a word from our sponsor, Trestle Tree.
Trestle Tree is here to help you in your struggle to live a healthier and happier life.
Pushing education doesn't work. Everyone has a different story, and everyone is at a different stage of change.
You sort of hit that plateau mentally and physically. And sometimes it's good to hear from people that can help you think of things in another way.
I think a lot of our members have a good understanding of their health, but the implementation is the hard part.
It felt sort of like a mental health thing too, because she was just letting me describe my journey with my health, and it would help me like really put everything on the table for myself.
There is a strong connection between our mental and physical health. Life is messy. Health is messy. Trestle Tree knows how to help you change your health and well-being. Your very own psychologist-trained Trestle Tree coach is your place to start your journey back.
Always keep pushing, because it's about you, it's about your health. You can't give up.
To see them progressing and to see that they are happy and they have hope. They have hope.
Okay, I am really excited also about introducing our next speaker. Dr. Krista Marie Singleton is the Chief Medical Officer for the U.S. Office of Personnel Manager. She supports their strategic initiatives through healthcare, health insurance industry, health policy, population health, benefits design, standards of care, quality measurement. I'm still going, just so you know. And legislative and regulatory initiatives. She serves as a strategic content contributor of innovations in public and private sector health delivery, finance, and payment models, which could reduce healthcare costs and improve healthcare quality and patient outcomes for the federal employee health benefits programs, 8.3 million federal employees, dependents, and retirees. Prior to OPM, Dr. Singleton served as the Chief Medical Officer at the Office of Health Equity at the CDC. I've had the pleasure of serving on a board with her with the National Alliance of Healthcare Purchaser Coalitions. She is thoughtful, she is extremely knowledgeable, and she really cares about the people in the United States of America. Let's welcome Dr. Singleton.
Thank you. It's a pleasure to be here this morning. Let me see, how do I advance? Let me see if I go. I guess I can go. There we go. Okay, so I really enjoyed Dr. Johnson's presentation, and I just shared with her, I'm going to build on this because this piece you mentioned is about puzzle pieces. So let's building. So, and I was intrigued by some of the initial survey findings about lifestyle changes and employers' perceptions of this. So here's the poll question here. Do you, if you're an employer, require intensive behavioral therapy to access whatever your obesity management program is? And so your options are yes, no, not sure. And then what is intensive behavioral therapy? I love it. Exactly. What is this? That's part of the fun. So I am a pediatrician by training, and I worked my way through public health school. So I have a split brain. I was trained as a pediatrician, but in the first year of my internship, one of my attendings said to me, "You young lady are going into public health. You young lady are going into government." I'm like, "What's public health?" And so he directed my life pattern so that I trained in public health and health policy and management, looking at health and costs during the Clinton administration. So I'm going to age myself a little bit here. And so, but the point is so my brain consistently looks at health and cost, health and cost, health and cost. And so as I look through this process, it's how do you spend smarter to help people get to the desired outcomes? And that eventually landed me. I've done 18, almost 19 years of federal service. 16 of those were at the Centers for Disease Control. Prior to that, I worked in local government because I believe all things are local. And in these last 2.5-ish, I've had the honor to be the chief medical officer, as Cheryl mentioned, at the Federal Employees Health Benefit Plan. So what being at OPM, or the Office of Personnel Management, what that is, that's a long-winded way to say that's the federal government's HR arm. And within that federal government HR arm, we house the Federal Employees Health Benefit Program, as well as now a sister program for our postal employees. And we are the largest employer in the country, and we have the largest employer-sponsored group health program. I put 8.1, 8.3. Let's just say we have a moving target in terms of how many employees we currently have. But bottom line is those employees, what makes us unique is that we have the employees themselves, we have their dependents, and we have our retirees. So when you roll all that together, it gets into that $8 million range. And when this program was created around 1959, 1960, it has grown and evolved with the intention of having choice. So another thing that makes us unique, and some would say almost too much choice, we have at current count 64 carriers with multiple plan options. And let's just say we're having some intense conversations about, do we really need that many? And I won't tell you what my vote is on that, but nevertheless, we have a lot and members have choice. And what is common for all of them is that they all are required to cover these buckets of things. So prevention, tobacco, wellness, which I'll give you some thoughts on that. The whole concept around the journey around prenatal, maternity, medical, surgical, et cetera. So that's great. And then a little bit about our history of our program. So as I mentioned, it's been around since the 60s, but in around 2010, 2011, there was a focus on recognizing the role of chronic conditions and the benefits that we offer. And so the way we operate is that we put out every year a call for proposals. They're called a call letter. They're publicly available. You can find them on the OPM website, and you can see what the agency is telling anyone who wants to be a contracted carrier with us. Here's what you have to create in your proposal. And in 2011 was when the shift started to say, hey, wait a minute. healthy behavior change might have an influence, might be a key puzzle piece around chronic conditions. And then what we also said is that back then, by the way, carriers, we expect you to cover children and adults around this topic of obesity. But that was still kind of early in the process. And then in 2012, tell us how you're doing. So I'm the proud mom of a 19-year-old. And so I often put things in that space. It's like you go to school and show your work. So the first year was, we'll tell you to do it. The next year was show your work. But then as things moved forward, we said, well, wait a minute, the work's not moving fast enough, or it's not moving far enough. And so we were then, and then carriers were saying in their defense, hey, OPM, what tools do you want us to employ? And so we started to really try to narrow them around diabetes, heart disease, hypertension, stroke, around people who happen to be identified as being overweight or obese. And then in 2023, as science has evolved, we gave an updated guidance to them to focus on obesity specifically, but with a specific nod to include individuals that might have heart disease and diabetes, because again, we saw that those puzzle pieces were linking. So for us, and I notice again the concept of lifestyle, and we want to make sure that we say that lifestyle, this is not a choice. It is a chronic, obesity is a chronic condition. Heart disease, diabetes are chronic conditions. But lifestyle interventions as the foundation, I would offer that this is not an either or. And when I saw that poll up there, it struck me that maybe employers are thinking lifestyle's over here, medication is over here, and they're divorced. They are linked. It's not an either or, it's a both and. And in all these studies with all these really cool drugs and impressive drugs that are coming, a piece that is often not put out there that I would offer is that it's both. The patients that do the best with these awesome medications and these awesome pieces also have lifestyle interventions that have been put in there. That is the key foundation. You can't prescribe the drug without the behavior changes and then say, well, wait, we never addressed what's going on in that person's life. And so the choices that an individual makes will drive the changes in terms of hypertension, diabetes. And so when we as employers have this wellness one-offs over here to the side, kind of choose your own adventures, I call it, and then with some websites and some interesting stuff, which is great information, and think that that's going to change people's lifestyle interventions, then we're sorely mistaken. And so what we at OPM are starting to really zone in on is the focus on improving carriers' adherence and coverage for these lifestyle interventions. So bringing it to their attention and seeing more in that space. And so why should this matter for an employer? So if you don't think of where the lifestyle intervenes, and so you constantly see these costs keep rising, and then you want to know, well, why? And then you start the rabbit trail of, oh, well, let me find this vendor, or let me find that solution. But what's the underlying piece? And key underlying piece. So the left side puzzle is that if you don't look at a key fundamental puzzle piece being what are those interventions, you end up with high costs and the medication use. Our carriers are constantly complaining about their medication spend. Employees are not as productive. But if one looks at adding a piece of, again, key lifestyle interventions, what could those be? You get to some changes. And one of the interventions that we put forth to our carriers in around 2017 was the advent of the lifestyle program called the National Diabetes Prevention Program. And the reason why we zeroed in on that one, and the reason why when I was at CDC, I saw that program come to life. And the reason why CMS put it on, so when the payer for the government agrees to cover something, that means they've seen enough evidence that it's going to start shifting some costs. And that structured program of the National Diabetes Program helped people slow their progression to diabetes, which is extremely costly, and or maybe averted that change. And those lifetime costs considered with diabetes, that's a big chunk. And those individuals often, as mentioned before, have hypertension, they have all these other components. And in that program, people lose 5 to 7% of their body weight. That's what Dr. Johnson was talking about. That's a key thing you want to see. But there are lifestyle interventions that are there. And those lifetime medical costs can be reduced between $2,000 and $5,000 if people lose the weight. But you've got to affect what's going on in that person's life. So I don't have a full-fledged case story like was before, but I do have an anecdotal story. In Atlanta, where I'm based, I'm on a community health improvement committee, and an individual who's one of our patient advisors stated his journey. He said, I was formerly a substance abuse user, and so he got clean. Awesome, check. And as part of getting access to healthcare, check, he discovered that he had prostate cancer. Check, that got fixed and improved, so now he's in remission. Unfortunately, the medications for his prostate recovery, he gained a lot of weight. And now he's significantly overweight. And so he gets access to healthcare and says, okay, I'm looking for help with my weight. And the immediate point was, oh, you should get one of these shots. No one's, and he's saying, what am I supposed to eat? What am I supposed to do with this? How does it affect my life? Where am I living? No one stopped to think, to ask this gentleman, what's going on in your life and how would you even manage? Before they offered him, they went straight from 0 to GLP-1. And that is what we see happening with a lot of our contracts right now. Individuals will present with whatever state to be eligible, and very few conversations are about what's going on in your lifestyle. So it's not an either or, it's a both and. You can do a puzzle. If you're missing a piece, you haven't solved the puzzle. So that's one piece that we would look at. And so as employers, how can we make these lifestyle interventions and these changes stick? So what we would offer, and what we've looked at OPM, in 2024, we started to look at this a little bit further. COVID helped us kind of focus our thinking a bit. And so I'll point to that bottom, I can't do this, but the bottom chunk, the social needs. So if you're trying to get into someone's lifestyle, better understand how they can adhere to whatever creative new benefit you're about to have, is that you look at, can they get the food that's being recommended for them? Do they have challenges in access to healthcare? Are they even accessing medical nutritional and to talk about their diet? What we are noticing is that a lot of our carriers do not cover medical nutritional therapy. They might have 3-4 visits. That's not enough. Dr. Johnson's case study showed how that the journey of this individual, that to me requires a constant conversation with someone, educating them and working with them on the changes in their lifestyle. And those social needs, we as employers can compel our carriers to start screening for this. That's one piece. The workplace environment. In my previous life at CDC, then CDC Director Tom Frieden was very focused on how do we nutritionally improve the environment at the workplace. And so the first step he went after was the vending machines. And so he changed the contracts so that the foods in the vending machines were less of the sugary, fatty, salty. I mean, there's got to be some because that's life. And I'm in the South because we like our salt, but there's less of that so that every single item is not that piece of it. So you're making the default choice, the healthier choice. And he changed some of the contracts in the cafeterias that were there. So that's another place we as employers can start to make some of those shifts. Individuals who have this trifecta have been shown to often have additional comorbid components of mental health challenges. And so that piece needs to be in there. And then we talk about incentives. And so a lot of times approach that employers use, and we have tried as well, not to great success, is gift cards and those sort of things. I would offer, if one is going to look at incentives, think about what are the incentives that matter to your employees. Because we're seeing with some of our carriers, when we ask them, what are you doing in terms of advancing your obesity approaches and your lifestyle changes? They say, well, if someone fills out a risk assessment, we'll give them a $25 or a $50 gift card. And how's that working for you? How many people are actually showing? Because one of the questions we asked this year is, you've got an obesity program. Great. What was the utilization of said program? A lot of them said, I'm using vendor A, B, C. Great. How many people used the program last year? How many people signed up? How long did they stay in the program? What was their average weight loss? What cardiovascular metrics were you tracking? Did you track? Of the 64 contracts, the main ones that I looked at, I'd probably say 10% answered that question. So now kind of begs the question, are you tracking? If you are, then what's the answer? And are you trying to be like my 19-year-old sometimes? Like, I don't want to tell you because the answer is not that great. Might be, but the point being is that, you got to tell the story. And if it's not getting you the metric, then why are you spending money on it? It's just a thought. Okay, so I'm going to go in a little bit more deeper about OPM. So one of the things that we have done is to go in, we're zeroing in on these lifestyle interventions because we really believe that that's a key piece. It's not, again, not an either or, but it's a both and for these three conditions. What we have done is also look for what common denominator across the plans can we use. And so we look at HEDIS metrics, and I always have to look up because I'm so used to that acronym, the health effectiveness data and information sets. So all these commercial plans submit measures to the National Commission on Quality Assurance. And then those HEDIS metrics can be used to grade the quality of the plans. So recognizing that diabetes, cardiovascular care, prevention screenings, the things that are high priorities for us, have a HEDIS metric. We said, well, wait a minute, there's a way we can then look across this measure. If they're already doing this for their other commercial lines of business, we could look at this as well. So there's a HEDIS metric for diabetes care that looks at the percentage of people that are in the program that have their hemoglobin A1C. So that's that marker for their, how well is your diabetes controlled. And so lifestyle components that would affect that would be looking at their diet and their activity level. So how much is that carrier putting some of those into place? That's the undercurrent behind it. Because if that number is going where we want it to go, that means something's going on. Blood pressure control, the amount of members that are under 140/90. And again, you can change in terms of lifestyle interventions, things to address sodium reduction and exercise. Prevention screenings, the percentage of members that are getting their scheduled colorectal cholesterol screenings. There is the one for BMI for adult counseling, adult and pediatric. It's not the best metric, and we're still dancing whether or not we want to go with that one because it's really just the presence or absence that someone checked BMI. But as Dr. Johnson was talking about, BMI is not always the best source, but there isn't yet a HEDIS metric around obesity, and so we're still nudging on that one. About nutrition and activity counseling. So what for us, that's saying what gets measured gets noticed, or what gets measured gets done. I offer a slight switch on this. Using something like HEDIS, and my predecessors created this, and I'm grabbing it and running with it. What measured gets improved, and if you use something like HEDIS as an employer, as you pick your contracts and your carriers, it has the potential to connect lifestyle to accountability. And if you reward contracts that have lifestyle-based interventions as a key component, not either or, but a both and, you can see that some of these metrics improve. So again, going on that premise of what gets measured is paid and what gets improved. Another piece we looked at, because the carriers were looking for what evidence-based things we wanted, we said to them that an evidence-based component is the United States Preventive Services Task Force recommendations. And from the Affordable Care Act, it stated that if any of these recommendations are an A or a B, then they should include access to these things at no cost. So when we looked at them, we saw that there's a USPSTF set of recommendations around obesity-related morbidity and mortality, and there are several behavioral interventions. We saw that there is one for children and adolescents that have high body mass index, and there are behavioral interventions for diet and physical activity around cardiovascular disease. But a key component of all of those are lifestyle interventions. And again, it goes into what is the individual's going on in their life? What are the things that are ticking in their head, perhaps that are helping them or hurting them? What are the nutritional components that are there? These are behavioral aspects. And a lot of carriers we are seeing are not covering these lifestyle interventions. They might identify for the screen, maybe, or then if the provider says, okay, you've got this piece of it, and I'd like to refer you to this program, then the member's out of pocket to pay for the program. You got to have the screening and the referral. Those have to go together at no cost to the employee. So we require these carriers to implement and cover any of these recommendations that include lifestyle as a fundamental aspect for these puzzle pieces around obesity, around cardiovascular and around the high body mass for children and adolescents. And I will say that that one around children and adolescents is still a sticking point for us right now, and I'll explain why a little bit later. But and even the one for obesity-related morbidity and mortality in adults, the carriers keep pushing back because they'll say, well, the person's already obese, so we're not preventing obesity. And we say, stop. What we're trying to do is prevent those expensive complications. So if someone presents at some elevated case of where they are class 1 or 2 stage obesity, we're trying to prevent those bad, expensive side effects. That's what we were really trying to prevent. So again, when we saw this back in 2016 or so, we gave them the specific piece of the diabetes prevention program, the specific toolkit. And then we also advised them to consider in their programming and in their benefit design to use the principles that were coming out of the American College of Cardiology and the American Heart Association. Those were in 2018. The 2025 version of that just got released. And if you're not yet aware of them, you'll notice that the ACC and the AHA have changed their guidance a bit, and they emphasize for certain individuals, a large chunk of individuals, before going directly to medication, a 3-month trial of some of these lifestyle interventions, very specific ones about making sure that there is coverage and counts for access to nutritional therapy, not just, again, choose your own adventure and look on a website, but an actual visit with a dietitian, someone that can help them with these choices, help them with their lifestyle pieces around behavior change and nutrition and physical activity to see where things go before then the consideration of medication. So again, go back to this lifestyle measurement and plan. We call it the plan performance assessment. And so at OPM, for certain key metrics around these 3 in particular, diabetes care and blood pressure and cholesterol, we are tying part of the contract payment to their performance on these related chronic condition measures. And all 3 of those have lifestyle interventions that have been recommended by the USPSTF. And so we basically tell you, we're not going to tell you exactly how to get there, carrier. Goal is get there. Show your work and get there. And we point you to, you need to cover these things, but you got to get there. And so this plan performance assessment was created in 2014, went live in 2016. And it gives a kind of a universal clearinghouse for these common, objective, and quantifiable measures. The enrollees can see which plans are doing better. I would offer that we as a program can better explain that to members, but you can see which plans are doing better around controlling blood pressure and diabetes control. And those who do better in certain ones can actually get an additional improvement increment. Because again, what gets measured gets noticed, what gets paid for gets done. Follow the money. And so that was one that should have come out again. So here's what the plan performance assessment looks like. The contract oversight for our carriers, that they get a score and part of their payment comes from that. Underneath that is we grade them on certain clinical quality metrics or customer service metrics from HEDIS or resource uses for metrics. And so health plan profit gets tied to population control and hopefully shifts population health improvement. This is a list of our QCR measures from 2024. And you'll notice there are 4 that are starred, and the second and third ones are part of our trifecta that we're talking about today. Controlling high blood pressure and hemoglobin A1C control. And why the high priority matters to an employer in our group, a carrier in our group, the better they do on those metrics. And when it's a higher priority, it has a higher weight. So the calculation gets created. It's in their best interest to zero in on getting those scores where they are. And we show them that when you use lifestyle interventions along with medication, along with all these other components, the scores improve. And then for 2025, because NCQA has changed the names a little bit, so they're slightly different, but it's the same 4 buckets. And the 2 that are of interest to us today are controlling high blood pressure and again, the diabetes control. And what this shows is so that horizontal line is the commercial 50% percentile. NCQA looks at all commercial health plans that report to them, and they average out a score for them. Our plans continue to perform above that. Now, are they performing better because they're doing the right thing? Yes. Are they also performing because there's money tied to it? Yes. But the point is that that's the incentive that we put in place around a measure that's important to us. And because we know about the cost to the workforce, and we know that about the challenges to productivity and just life and health in general. Same thing with hemoglobin control with persons with diabetes. It's above the 50th percentile. Now, me personally, I like to see this a lot higher, and we're in some conversations because if the average is 3 and we're above that, so that's great, but we're more like a C plus. I want to be a B. I want to be an A student. So I want them to go do more, do better. And so for those plans that don't get into that middle grade and are below the 25th percentile, what we require of them is that they have to give us a corrective action plan. So we'll say, hey, you are here, what's going on? Again, show your work. So what are you currently doing? What are you going to be tracking? If you are below the 10th percentile, then the contract officers follow them and say, what new plan are you doing? Are you doing things besides, well, we'll send out a newsletter. Well, that's great, but so what? Well, I mean, do more. And so the contracting officers tie their performance scores to how well they advance that corrective action plan on these high priority topics. And so in the most recent scores for this, our team that tracks this showed that, again, for the QCRs, for high blood pressure control and diabetes continue to be above the 50th percentile. So we know they're doing something right. What we really want to zero in more is what else can we do? And we see a gap area around lifestyle interventions. And so in our future guidance, we're likely going to be headed that way. So let me turn the puzzle piece over to obesity, because I've talked about blood pressure and I've talked about diabetes. This is obesity. This is our most current call letter. You can find it on the web, 2025-01. And so in this extremely long document, there is a section around what OPM's commitment is to prevention and treatment of obesity. And I pulled out the puzzle piece. What we state in this letter, and we tell the carriers that pharmacotherapy for being overweight and obesity should only be used as an adjunct to lifestyle therapy and not alone. So our expectation of them is that you have to have some lifestyle interventions. Very specifically, our program is built on, I call it a 5-pillar approach. Medical nutrition therapy. The second puzzle piece that's the foundation is physical activity. Third piece is this concept of intensive behavioral therapy. So for the 36% of you that said, what is it? Here it is. This is a hands-on approach where you have experts that are part of the plan who focus on medical nutrition, physical activity, and behavior changes that help support the person's weight loss effects. So there need to be access to intensive behavioral therapy. What some of our carriers were coming back with, oh, they see this and that's it. Well, that's mental health or that's an eating disorder. We're not going to cover that. No, obesity is a multifaceted component. And for us, we have been continually saying since 2010, there should be access to medical nutritional therapy. There should be access to physical activity supports, meaning sometimes you have to help coach people. If you're grossly overweight, the 150 minutes a week might be challenging for that individual. What can they do? And then you advance them, but someone has to coach them and walk them through that. And coverage for that is what's often lacking. The behavior change coaching that can happen, that needs to happen. And then medication, if indicated, and surgery, if indicated. And so what we are seeing is the carriers are jumping to the medications because all of our carriers, all 64 and their different plan levels, have on their coverage, they cover at least one GLP-1 and they cover 2 others at least. But this piece about the behavioral therapy is the gap area, even though we've told them this is what needs to be there. And what we're seeing are holes in those puzzle pieces. And so there's now a much more intensive focus on that. And what we reminded them as a nudge from this administration is like, show me the money. And so there is data showing that when intensive behavioral therapy with medication or just when that is involved more, that there's a huge cost savings. That's why the diabetes prevention program got covered by CMS, because of the cost savings that were there. So you have to have both. And what we are seeing is that carriers are slowly moving to this, but only applying intensive behavioral therapy for people who get GLP-1s. But as Dr. Johnson talked about, not everyone necessarily needs a GLP-1. So then what? So what we're nudging them for is saying that anyone who is in the situation of being in that trifecta should have access to the intensive behavioral therapy as a precursor and as a piece of this, is a fundamental, and you don't move off of that. You don't just say, well, you get therapy and that's it. You get the intensive behavioral therapy of nutrition, physical activity, behavior changes, and then and include people who are overweight, because what we see a lot of the carers doing is saying you only get access to this once you're grossly overweight, and we're just like, no, let's bring it back, because you're missing overlapping the pieces. In that letter 2025-01 that we initially put as a requirement, and then with the administration changes, it got moved to an option. But I will say, in our carers' defense, a lot of them did say, well, we're just going to do this anyway. What we said that they needed to pay for is that the carrier must pay for the screening and support services to prevent complications for obesity. So individuals, members who might be adults who are at those obesity classes 1 and 2, then those individuals, again, coverage for that individual to get screened. And then if they get referred to a program, then that program gets covered. We also reminded them of their obligation since 2019 that children, adolescents who have the high body mass index also get covered, the screening and the treatment. So a lot of pediatricians will identify a child who's overweight, and then they try to do some counseling or they try to put them in a program, and then they're stuck. What we also pushed for is the expansion availability for people who are overweight and also have those cardiovascular comorbidities, the diabetes, those components. Because if you're just focusing solely on persons who are obese, you're missing those other puzzle pieces. And what we insisted upon, and we're pushing even more so, is the inclusion of lifestyle therapy. Again, that behavioral therapy with meal plans and medical nutrition, not just diet du jour, but is it really tied to their pieces of it and those behavioral interventions? And we recognize the world has evolved, and in virtual programs are often meeting people where they are, where we drew the line and said, if you pick a vendor that's doing this, great, but that vendor can't be app only. And we see, as the field is evolving, a lot of them are app only. There's no human contact. And so the problem with that is that the AI algorithms aren't going to deal with a person like my gentleman friend. Well, I've got this going on and I just had this other condition. A human being has to be part of that conversation. And so the app's got to have pieces and parts of both. The child, adolescent, and family programming, this administration is very focused on improving the health of children. And as a pediatrician, I'm all in for that. But remember, the child and the adolescent doesn't make their own choices in a vacuum. And there's a caregiver that's involved. And so the USPSTF recommendation states that there should be a minimum of 26 contact hours. So there needs to be coverage for these kids, adolescents, and their caregivers to be part of programs. The pediatrician can definitely do it, and there should be codes to cover for the pediatrician or the nurse practitioner to do that. There also, in addition to that, there are evidence-based programs that my former colleagues at CDC created called the Family Healthy Weight Programs. They're in every single state. And we have told our carriers, you can contract with these and as an option for your members, because just saying that the kid went to the pediatrician and got checked and so they're overweight, and you don't put that kid and its caregiver together to change that kid's activity level, to figure out how you can fit food into that cultural lifestyle, you're basically just spitting in the wind. So this is a gap area for us. A lot of the carriers don't have this. At least they're now agreeing to pay for the coverage codes for the pediatricians to do some of the work. But that's a huge gap area for us, and we're looking for that for next year. The last piece is that we are looking and asking the carriers to put a stronger focus of bringing in network specialized obesity care teams that have obesity trained registered dietitians, that have obesity trained physicians, because Most of us physicians were not trained in this field. This is not, yeah, I can write the script for it, but this is not what I do on the daily. Now, I am learning more as I use my continuing education credits to learn, but that's your expert right there. She needs to be in your networks. And if people like her aren't in those networks, then you're missing out as to having that expertise in your networks. So as I move to the end here, because I see my time is running short, is the key puzzle piece are lifestyle interventions. If you pair those with measurable metrics, you can get smarter spending. It's less of a case of spending, not so much spending less, but you want to spend smarter. And one thing that we as employers can consider is, again, integrating these comprehensive approaches where lifestyle interventions are a key component. You can improve your metrics, you can improve long-term cost trends, and you can improve the trifecta of hypertension and diabetes and obesity. So the takeaway for all of us is lifestyle interventions are the cornerstone of workforce health. And lifestyle interventions will drive a member's risk factors. For these risk factors, as we learned in the first presentation, so many people have one or more of these comorbid conditions, and focusing a key piece, not an either or, but a both and paying for coverage of things to support their lifestyle changes can simultaneously impact diabetes, hypertension, and obesity. And a key piece of embedding these supports for medical nutrition therapy, intensive behavioral therapy. I can't stress that enough. Get that covered into your benefit programs. And it's more effective when you have it as part of a comprehensive component than a siloed wellness one-off that's nice to know, that's a website add-on. And when you do that, as lifestyle is the center, then you have a much better chance of getting those puzzle pieces connected and get long-term health success. And that's it.
Wow. So what a wonderful example of how others than public and private employers do healthcare, do all this whole area. That was really, really outstanding. One question I have, and this may be naive of me, you rely on your carriers, the 65, you said, to do everything for you. Whereas I think in the private sector, we have not found that carriers have often met our needs. Right. Some do, and many of us are using them, but the point solution community has significantly grown as a result of that. I think you've given us a little bit of a roadmap for those of us that may want to, or who are currently working with their carrier, to ask the right questions and have certain expectations.
Yes, absolutely. And that was the thing we put in that guidance. If you look at 2025-01, I encourage you to go find it. We said to them, if you pick a point solution, because we know that's a lot of them, what they do, your point solution vendor needs to meet this criteria. So do that, because I've heard a lot. And those of us, I think Jane and I are part of the National Alliance Medical Directors Council. A lot of them come and talk to us, and we hit them. Are you meeting these pieces of it? And as they create, I'm in Atlanta with a lot of health tech, and I see all these health tech vendors coming up. Where is your human that's in this? Where is your human that happens to be obesity trained? Right. Did you just find this off the website, off of Google, or did that person really go through, certification? Who's your human that is still looking at these behavior changes? If that's not part of your algorithm, don't pick that vendor. And what kind of metrics do you have in terms of success? Utilization. Did they sign up? Did they stay in the program? And a lot of times they say, well, we had weight loss. But if they can't answer these questions, it's either you didn't show your work or you don't have the answer, but it doesn't add up. And like to say, the math's not mathing. So if I were an employer and a point solution is coming to me and you can't answer these questions, maybe it's time for a different point solution. Well, and it's also a roadmap for the point solution providers that are in the room today. But again, carriers weren't doing what employers wanted, and that always grows an industry, right? Mm-hmm. Questions in the audience. This was really, really compelling, or online. Over there. We're going to bring a microphone over to you. Thank you.
Aria. Thank you, Dr. Singleton. That was phenomenal. Quick question with respect to the lifestyle behavior programming. You mentioned something that was pretty nuanced. I'm a patient as well, so I've kind of lived this journey, and I'm 100% there with you. gold standard of care, right, is a holistic approach. In your programs, when the carriers come to you with these things, what is your approach to, you talked about offering lifestyle intervention, intensive lifestyle behavior therapy first,
Mhm.
right? For patients who have a long history, that can often feel like, here we go again.
Mhm.
You're gonna like make me go through the hoops.
Mm.
I could, if I had the documentation, I could show you the 30 years that I've spent doing everything that anyone asked of me. And here we are today. So how do you think about incorporating an approach that acknowledges that, that goes to kind of what's going on in your life, and allowing people to do multiple forms of therapy together at the same time? Or are you gatekeeping? There has to be this lifestyle intervention before access to other treatment modalities.
It's looking at what they have done, and we don't like the gatekeeping model where you got to do 3 months of this and only that, and then the next piece of it, because a lot of times an individual, and I too I have walked the obesity journey. I am walking it right now. As I tell people, enjoy your 20s, 30s, and 40s, because in your 50s, the check engine light comes on. I'm in that space where it's like flashing full. It's not even flashing anymore. It's just straight on. So I can tell you every pretty Weight Watchers, Noom, you name it. I've done it. I've tried everything. And so I could say, hey, I've got a 30-year history of all these things. The key piece is that you're looking for a risk assessment that has looked into all of that. And if all of that has then been addressed, but what else, what other puzzle pieces, of what blind spot are we missing? And then, okay, after all of that, then maybe medication might be needed. But again, it's not 0 to GLP-1. Look at all the pieces of it. And so I would offer, and what we put down, and we flat out said, things like Weight Watchers, Jenny Craig, yes, these individuals have tried that, but that's not a program. That does not meet the qualifications of IBT. So that's why you need a true specialist to help look at that whole holistic piece and then see what's the next path.
Did you create an assessment to help that patient get to that point, or are you requiring the carriers?
Well, right
look
now
at that
we're
first?
requiring them doing it, but that's after we saw this gap area, even still, because it's like now some will have it, but it's fragmented. So they've got the coaching under wellness, and they've got the nutrition over here, but so they're not connected. So that's why we said, well, you use a vendor that can pull it all together, that's fine, but then that vendor's got to meet this criteria. So that's what we pushed it. If some of us had had our druthers, we would have enforced it, but with the administration changes, it became like, okay, let's just get an option. But now we see what the gaps are. So keep fingers crossed for 27. It'll be a lot more formalized. Like, you got to dance this dance now.
We would love to have you come back at some point in the future. Tell us where you're at. Another question?
One of the things I took away was what you say, what gets measured gets paid. In my eyes, that means that incentives are aligned. Can you talk to how you've done that and aligned incentives so that the carriers are paid for this work or not paid?
Well, the incentive for us right now is tied to that HEDIS metric and those plan performance scores. So there's two that they are very, very focused on because they want to do better in their blood pressure control. So that's the incentive, their contract oversight component. That's the incentive for them, because the better they can get their members to have their blood pressures under control and their diabetes in the desired ranges, then they get paid more. Incentives at the member level is a little trickier. And so when we see these gift cards and these other components, we question that. We start questioning, is that really moving the needle for you? And if that's what you're going to be trying to charge some of your payment to us or charges to us because of that incentive, and that incentive is not working, now we're second set of eyes, third set of eyes saying maybe we're not going to pay for that, because gift cards don't always work. And so this is not on this topic, but one of my own personal topics right now is looking at maternal morbidity and mortality. And I see a lot with the carriers that they offer gift cards to the new mom. Well, that's great. But when you've got all the stuff going on, $50, that's barely diapers. So is there a different incentive that you want to give to the mom to help her get to the next spot? But that $50 gift card, that ain't working. So.
One more question, Tara, and then Jan, I see you have one. Go Tara, Jan, and we'll try and rapid fire
Awesome.
questions and answers.
Thank you. Thank you for making time to be with us. This was really, really valuable. One of your last comments was have intensive behavior therapy included, not an off to the side wellness program. Can you just say a bit more about that? Because we do tend to utilize point solutions. We do have a lot covered in our plan too. So I'd just like to understand that a bit more.
Sure. So the goal is to have different types of providers that can provide. So there's a Medicare study that shows that if you want to have the coaching for that intensive behavioral therapy, right now Medicare pays for physicians, nurses, I think nurse practitioners, you've got to be, the providers. So that's a solution option right there. And when those individuals provide the counseling and the nutritional components, and they can fall under one roof, like in my own medical practice that I see as a patient, they've got all that under one umbrella. And so they're in that space, in that practice. So having practices like that in the network. So that's one option. I'm tracking on the other piece, but that's where you want that. If you pick a vendor that's got that, you've got to have all of that together so that you've got, because the health coaches oftentimes have to work underneath the provider. And so that's why we would say if you've got an obesity trained team at the top, and then you bring in the health coach, so you've got it there together, but that obesity trained physician and nurses and that team, you're working as a unit, and that we know that coach is doing things in line with the latest and greatest with the science of it.
Dr. Berger.
I do. Plus I have a big mouth. So thank you so much. I want two quick clarifications, if you would. And you started to go down that path just now. The issue of nutrition counseling. As a fellow physician and a fellow pediatrician, I was trained nothing in nutrition. And most of my peers, no offense to my peers, we have not been. So if you have a patient or an employee, a covered beneficiary, who is pre-diabetic as part of the trifecta, most places are not covering nutrition counseling. It's only as diabetes. How are you handling that today? Because our providers are not in a position to do that. So that's really missing. And then the second thing is, are you covering CGMs and for whom? Thank you. Thank you.
So in terms of the nutrition, that's when we look to see the carriers that are offering nutritional therapy, we want to see unlimited, because particularly if someone's been identified and referred, that individual should get access to it. We see some of the carriers are saying you only get 4 visits. No, if you're identified and being in one of these categories, and pre-diabetes would be in that space. And so if a carrier comes in where they want to narrow the gap and say you've got to be full-fledged, no, we're saying you need to expand that to let these other individuals in. And we're frowning upon very limited 2 visits, 4 visits, 6 visits. No, you need unlimited access. Now, the next question is going to be coming is looking for the outcomes that go along with that. Because to your point, the key components of understanding what people eat, why they eat, the cultural components, how that fits in with their macros, all that stuff was definitely not something in my medical school class, and stuff that I'm still learning now in my new decade of life.
CGM?
Oh, CGMs. Some of our carriers do cover them. Not all, but some do.
Very helpful. Let us thank Dr. Singleton. Krista just shared that she's here all day. So if you want to talk to her, have questions, don't overwhelm her, but feel free. Same with Dr. Johnson. Okay, guess what? We have a break coming up, correct? Before the break, though, we have a vignette from Wonder Health. Let me get that started. I thought that was part of the vignette, but it's not. It's a horn outside. That was jazzy. Okay, couple comments about our break coming up. This is our break trifecta. Take some time to circulate, connect, and consume. We have a trifecta of trail mix on your tables. Enjoy those as well. Introduce yourself to 3 people using your 3 words from earlier to describe yourself. Visit our sponsors, both in this room and in the room next door. Turn in your completed prize drawing card by 2:10 today, and we will reconvene at 10:50. 10:50. Thank you.
All right, thanks everyone. Lots of great conversation, lots of great information this morning. We are going to continue with some employer strategies. So what are some of these key 3 employers doing in this area of the trifecta? But first, again, we are so grateful for all of our sponsors, but we're going to have another message from Inspira Health.
Inspira Health focuses exclusively on those with 5 or more lifelong chronic conditions. We address conditions that improve with behavior change, and critically, we address mental health and social needs. This group is 8% of your population. Each one costs $50,000 annually. 90% of our target is in the top 20% of your 3-year health spend. These members can be proactively identified and addressed. Without intervention, the cost and liabilities will only increase over time. Clients will see program graduates have both a 30% or greater improvement in health and reduction in health and pharmacy claims. Let Inspira Health help your population with 5 or more conditions with guaranteed results.
Hi there, I'm Mark Fligger from MBGH. I also lead MHPC, our purchasing collaborative. You're going to learn a little bit more about that this afternoon, but we're proud to have Inspira as an MHPC partner, and they are currently offering a pilot to MBGH employers. So please stop by the Inspira exhibit booth just around the corner here in the Monroe Room, and I'll see you this afternoon.
Thanks, Mark. I guess I should say who I am. My name is Paula Sheehan. I'm the Director of Member Engagement here at MBGH. I've met many of you. If I don't know you yet, please come by and say hi. And we, again, are here to talk to these employers about the strategies they have in place in this topic. First, I want to welcome to the podium Joanna Bentley. She is the Compensation and Benefits Director at Wabash. And since joining them in 2022, she's been evolving benefits to focus on holistic well-being that balances financial discipline with care for the whole person. So she has over 16 years of experience in manufacturing, logistics, energy, insurance, and business. She thrives at the intersection of data, storytelling, and belonging, and she crafts strategies that feel personal while working at scale. So please welcome to the podium, Joanna.
Thank you, Paula. It is so good to be here. I have to say hello, everyone. Good morning. Who is pumped for the Combating the Chronic Condition Trio Employer Health Strategy session? Right? Now, say that 5 times fast, right? I don't know that we could get any more words in that intro session, but thank you for allowing me to take a few minutes of your time. I thought when I was preparing, I had 5 to 6 minutes. I have 9, which means that I don't get to use my typical salesperson fast speech, which was from living in Connecticut for 13 years. After growing up in Texas and graduating from Texas A&M University. But that being said, this is an important topic, but I will say, I'm going to lead off with a couple things. One, anytime I get to do something like this, whether internally or in a forum like this, my spouse, Sarah, who's a 2nd grade teacher, changing the world with the little ones every single day, talk about impact. But thank you. Thanks to her. She's doing good work every day. But she tells me 2 things. First one, don't mess up, except with much more colorful language. The other one is don't try to be funny. I think I've already messed that one up, but if you could see here on this slide, which is the first one, and where typically my name would go, there's a blank space. That, however, is a reference to Taylor Swift. I'm a huge Taylor Swift fan. Any Taylor Swift fans in the audience, lucky enough to get to see her in Indianapolis and in Toronto with my son, an experience I will never forget. It is also true we are not here about Taylor Swift. However, I am absolutely looking forward to 10/3, which happens to be my birthday weekend. 12 is my favorite number. Orange is my favorite color, always has been. If you know, you know. We are not here for Taylor Swift. We are here about benefits, or as I like to call them, bennies, because it makes it seem way more exciting. Because at home, when I talk about benefits with my spouse, Sarah, she says, please stop talking about benefits. It's so, we don't use boring in our house, but if we could use boring, she would use that word. So I like to refer to them as bennies. It makes them seem more interesting. So a little bit about Wabash. Paul already talked a little bit about me, but I really don't matter. It's really the work that the majority of our people do. We're an industrial, a diversified industrial manufacturing company. What that means is that we manufacture things like tractor trailers. So if you're on a road and you see a Wabash or Wabash National, we rebranded a few years ago. We are, if you see sort of a Wabash logo with white font and blue behind it, that's our new logo. If the older logo is a map or an outline of the United States in maroon with Wabash National, once you see it, you cannot unsee it, because when a recruiter reached out to me on LinkedIn, the beginning of 2022, and said, are you interested in maybe looking at this opportunity? I'm like, what is Wabash? And there we go. Now you can't unsee it. But we have 5,000 Wabashers, which is a passion project of mine, to get folks to use the term Wabashers. Of those, 63% enroll in our plan. We have one location in Mexico, with the rest of our locations in the US, multi-state, multi-location, mostly male. We use hourly worker on the screen, but at work we've sort of changed that verbiage to say non-salary, because we're much more than hourly and salary when we're talking about our people. Our average age is 45, but if we're technically it's 44.8 based on a headcount report that I pulled about a week ago. And why we're here today, one of the topics, right? Diabetes, up on the screen, you'll see that it is in our top 5 spend. Technically, if you look at data from January through July of 2025, year over year, it's top 2. So it's very real and it matters a lot. So we hear GLP-1s all the time. I'm talking to folks who are subject matter experts in your field. I do not need to say anything more about it and the importance of it. I have notes for myself. What I'd love to is I prepared and I made notes on my phone. Then I just thought I'm gonna go old school and write some notes on an actual piece of paper. So I want to make sure that I don't miss anything, and I didn't. But next is really about, what does this mean today, right? So everyone here, who is in the middle of your open enrollment or annual enrollment cycle? Who is about to kick off your period? Ours starts 11/3. Everyone here today is in some form of pressure all throughout the year, but this is where it sort of accelerates. So here's where, one, you congratulate yourself on the work well done. Because what happens, right? You prep OE, you get decisions, you go, you're greenlit, you go make it happen, OE happens, and then you're like, never pause to take a moment and reflect. Do that. Give yourself a moment, pause, take a breath. Mindfulness moments matter. You matter. You cannot show up for others if you do not show up for yourself first, right? But the recipe is the same. You already read the screen, because once someone pops the slide up there, you're already reading the words on the screen, but it's always the same, right? And what's bolded there? We're talking about costs, outcomes, balanced with ROI, and making things accessible, right? And so the majority of our population have struggle getting places, right? We offer a subsidy for like transit and things like that. But that being said, it really is just about what is the right mix. And so what does that mean for me? So what? So what do we do? How do we fix this? One, we offer a curated ecosystem, not just point solutions. We meet people where they are with solutions that matter most to them. So for us, that means things like RegenX, Carum Health, Sword Thrives, Sword Bloom. We offer it at zero cost to our members wherever possible, unless it's a Regenix or a Carum Health, and we need to stay compliant and be mindful of deductible for a high deductible health plan. But really, the idea is to also offer something like a diabetes or weight loss solution. You see the numbers on the slide. I don't need to walk them through it. You guys get data, you understand it, but that is what it's all about, right? So what are we going to do about it? What action steps are we going to take? Ideas are one thing, but we need to get it done, right? So listen to your people, right? We did a roundtable discussion. We did roundtables discussion last year across multiple locations, and we were with our people that are doing the work every single day. I wouldn't be here today without the production folks on the floor doing their job every single day. They keep the lights on, and I absolutely try to keep that in mind every single day. So from there, we took that information, which really was more anecdotal than anything, but really we wanted to just take a look at, assess via sort of anecdotally testimonials, but also outcomes data, also meeting them where they were, literally bringing dental and also biometric screenings to the locations so they can get at least some form of healthcare on site, right? And so things like that. So from there, then we also offered a GLP-1 alternative, right? Sort of a weight loss diabetes support solution, but really we need to ground ourselves in why, right? Who was with us on this journey? And testimonials, look, we could talk about Benny's all day. We love it. We know it, right? It's why we're running a few minutes late already, because we're all so passionate about it. But what hits me to my core every single time is stories and connection and people. So I will leave you to read this and stop talking for about a few seconds. I'm a slow reader. You probably are faster than me, but basically real members, real impact, real results. The big reveal, it's Verta. They're here in the room. Make sure you go talk to them, go hit their table. If you're not an extrovert, I get it. I'm happy to go with you, but if not, scan the QR code. And also you can email them at partner@vertahealth.com. So, hey, I get it. Verta might sound like an Italian spa, but they are the real deal, right? So it worked for us and it could work for you too. But I'm going to leave you with 2 words. When I got to meet my CEO in June of 2022 for the first time, his name is Brent Yagi. He is passionate about people. He is passionate about well-being. It means that I am already having a seat at that table, which is super, super, super exciting. But he said to me, Joanna, just do something. So I'm just going to leave you with that. Do something. Thank you.
Thanks, Joanna. So every employer is different, every speaker is different, high energy, extrovert. We have variety on this panel, just as we have a variety of employers in the room. Next, I want to bring you to the podium, Melissa Dabrowski. Melissa and I go way back. We used to work together in a different capacity, but I've known her for years. She's the Employee Benefits Plans and Programs Manager at Constellation Energy. And I don't know if you noticed, but in the title slide with all the speakers, we have 2 constellations here on stage right next to each other. Probably kind of like when you work in a company and somebody has something similar to your last name and you keep getting their emails. So that's probably, but much different approaches, much different, focus areas. So anyway, in her role as HR benefits strategy team, she supports the comprehensive benefits offered to employees, which include emotional, physical, financial well-being, and life and family. Melissa supports various policies and programs as well, such as time off, federal and state law compliance, and contractor management. So a lot of areas of focus. Please welcome Melissa.
All right. Thank you so much, Paula. It's great to see you again. So Constellation Energy. Constellation Energy is the nation's largest producer of reliable, clean, and carbon-free energy. And we also are a leading supplier of energy products and services. Our headquarters is based in Baltimore, Maryland, but we also have a big presence in Illinois here, as well as New York, Pennsylvania, and also we have employees across the states. And we have approximately 14,000 employees with 78% male, 22% female. And there's 30 operating companies, but we look at 4 different sectors basically. So you have nuclear, power, commercial, and corporate. And of those, the employees that are mainly in the nuclear and the power, they work at plants. So those are the nuclear power plants, for example. And then those that are part of corporate and commercial, they're mainly working from offices as well as the home space. And then we have people that live in remote areas as well as that are a bit more busy, such as here in Chicago or in Baltimore. So we identified the following 3 challenges at Constellation. First up, there are coexisting conditions related to obesity, which is a top cost driver. So for example, you have the cardiovascular diseases that we were talking about earlier, as metabolic conditions too, and then respiratory issues. Number 2, there was no weight management program in place, but we covered the weight loss medications. So I think this basically goes back to the puzzle that we were talking about earlier, where we're missing a piece of the puzzle. So we wanted to have a natural way for our employees to lose weight. And then also for those that are on medication or even not on medication to continue with lifestyle changes so that they understood how to continue that weight management. And then third, we had an employee survey, and the employee survey showed that not all of our employees were aware of the wonderful benefits that we have to offer. So with that, it gave us an opportunity to provide more awareness and education on our benefits, as well as look at the communication strategy that we have on how we share information about the benefits. So to solve for these challenges, we went out for an RFP for a weight management solution. And we ultimately were looking at 2 different solutions. And in January of 2024, we went live with one of the solutions. And basically, it was one that was a bit more engaging than the others, and it was super easy to understand. So we thought that the users would likely use it. And it's 100% digital, and it's available 24 hours a day. So since we have a diverse workforce working in different locations, different time schedules, easy for them to use. When they're on break, they could use it, or if they're riding the train into work, they could use it as well. Oh, sorry. So in summary, it's an online weight loss program, and it's clinically proven to help you lose weight, sleep better, and stress less. And basically, the users have simple skills-based behavioral science, and it helps them to enjoy those foods that they enjoy eating while feeling better. And it means that there's no calorie counting or point counting, and it's all about learning about mindful things and mindful eating. So at the beginning of each week during the program, you have a video to watch, a series of videos, and it talks about the different principles of the program. And these principles are the keys that will help the users learn how to eat healthy and maintain their weight. And the users of the program, they also have access to counselors and coaches. And as we just talked with Dr. Singleton, they have the opportunity to talk to them live on the telephone. So you have that as well. And then there's the online community. So it's where you have the coaches, the counselors. You can also connect with other members that are going through the same program as you or who have previously gone through the program. So you can ask questions, you can have tidbits of information as well. And it's also a place for you to understand that there's other people out there that are going through the same thing. And of course, there's tools available for you as well. So there's the tracking your weight loss and monitoring activities. And for us at Constellation Energy, we like the pricing model. So it was based on those users that actually used the program, whereas there were other vendors that were out there, whereas more of if you signed up for the program, then you have to pay, but this was different. And then for us as well, this partner is already a partner of our health plan provider, so it just made it a lot easier to manage. We didn't have to go through contracting as well. And then in regards to the engagement that you see on the right-hand side here, we work very closely with our partner on the communications plan to drive enrollment and engagement. So we were just talking about open enrollment. We had the opportunity to promote it during the open enrollment prior to going live. And then with the program launch on January 1st of 2024, at Constellation, we had different communications. So we had emails, flyers, just talking about it during meetings. But then our vendor partner, they also had the opportunity to have it's called a 3 email drip campaign. So that's basically 3 emails at a time going out. They had asked us, would you like to do 4? We said, no, not at the time. But since then, we've moved on to the 4 email drip campaign. And then they also offered webinars to HR as well as the employees, and then also a home mailer. So in my opinion, the 2 best things about this vendor partner is that they're so easy to work with. I haven't had the opportunity, or I've had lots of opportunities to work with many vendors, but this one I always look back and say, wow, why was it so easy? And then the second part is that the marketing materials that they offer you, they're beautiful, and it just catches your eye and it makes people want to read them. So with that, we had a robust communication plan, and then the engagement exceeded our expectations. So in January of 24, just that month, we had 1,300 people sign up for this. And then in 2024 altogether, there were 2,174 enrollments. So it was pretty impressive. And then as you can see here from the numbers, we engaged our employees, where 62% completed at least 2 sessions, and then 60,000 behavioral tools were used. And that's a lot right there, 60,000. And then also, it was 8,222 pounds were lost. Our vendor partner and I, we like to say that that's as much as a hippo weighs. So just to put that into perspective. And then 34% achieved 3% weight loss. And then, of course, we had the improved quality of life. So 78% felt more in control of their weight, 59% more physically active, and then 54% increased their confidence. And in addition to just the data, we've had a lot of positive feedback come to us about the program. So from one of our leaders, he had shared, as you see here, this program changed the way I think about and enjoy food. I'm eating more slowly now, and I'm fully appreciating and enjoying my food. And then I want to share what else he said. He went in to say, I also take breaks when I'm eating. Then before I pick up my fork again, I ask myself if I'm actually still hungry. Don't tell my mom, but I've gotten away from the clean plate mentality. Yes. So. And then in addition to that gentleman, another person within the HR team, she had shared with me that she went on to this program after she had a child. So she wanted to lose a little bit of weight. And she said it was just so easy to use. And sometimes she'll fall off the wagon, if you will, during the weekend. She might eat something that she shouldn't have, or in her mind, she shouldn't have eaten. But she says she doesn't worry about it because it's just so easy to get right back on and get back into the program, and because she understands these skills. So if you're looking for a weight management program, we recommend that you implement a solution that is backed by science and addresses the root cause of obesity, as well as find a partner that will work together to engage your population with a proven approach. Identify a convenient solution that will address barriers to care by providing 24/7 access and support, and identify a partner with experience in the space who delivers on engagement and outcomes and ROI. So with that, our vendor partner, which is wonderful, it's called Wonder Health, and they're right in the back there. So we have Michael and we have Patrick here today. Again, you have the QR code, so please take a snap of that, and then please talk to them as well, or come up to myself or my colleague, Melissa. So thank you.
Thanks, Melissa. It's always nice to have at least one easy button somewhere in the program, right? So from Constellation, with people who are on poles and in holes, is that what you guys say? No. Constellation Energy, you have people on poles and in holes, is that on the ground, in the air? To Constellation Brands. Constellation Brands giving you energy, you know, at the after hours parties. So we've got Neil Peterson joining us. He's the Director of Benefits at Constellation Brands, leading international producer and marketer of beer, wine, and spirits. Operations in US, Mexico, New Zealand, and Italy. So hopefully get some travel in there. Constellation Brands, he has spearheaded the domestic benefit strategy and oversees their comprehensive health and welfare programs, which include medical, dental, vision, partner solutions, retirement plans, and other ancillary benefits. So please welcome Neil.
Appreciate it. I think you should have ended with your energy. I mean, the energy here, you got to end with the high energy here.
It's okay. The selfie at the end. It's fine. The whole group.
Okay. I'm going to try and coordinate the clicker and the notes here, but intro to Constellation Brands, we mentioned after hours parties. So my favorite brands, Modelo, Robert Mondavi, High West, so we covered the gamut, but there's also non-alcoholic options as well. We're talking health here today. So not going to go into the company too much here, but just wanted to give a background of, so today I'm going to kind of talk about my business case to really talk about what we're facing, and as you all are, and that is really looking at cost containment strategies, looking at helping our population live healthier lives, And really, we talked about employee surveys and surveying the population. What we found at Constellation Brands was that they really were yearning for support to live a healthier life. So we had the employee data. So that in addition to the fact that we had to control costs, help our population live a better have a better life. Really, how are we going to set out to do that? And how I was really looking at this or evaluating this was, what has our trend been over the last few years, and how am I going to literally take 1, 2, 3, 4, 5%, and what are the solutions I'm going to bring in? And I don't want to bring in point solution, and confuse people, because we want it to be easy as well. So I'm going to tell you, kind of paint the picture as to how we accomplish that. So I always like to bring in external information. So what is our population facing? What are the employees themselves saying about their support and their needs? But bringing in that external data. So the CDC, this is a very interesting stat, and thank you to my vendor who brought it forward to me as well, because I'm going to use it into the future. But so if you look at the progression of the total population living with, we're talking MCCs, multiple chronic conditions, that has escalated and continues to accelerate over the years. You can see the total population in the US, this is from the CDC, 2001, 20%, 1 in 5, over half in 2023. So it's a 142% increase, and again, accelerating. What's very interesting is the young adults, so we're talking age 18 to 34 per the CDC. That is seeing the highest increase when we're evaluating this 25% increase. So that's scary to think. Again, ages 18 to 34 living with multiple chronic conditions. And what does this mean? Ultimately, more costs in the system. You have older population staying in the system, those cost pressures on the healthcare system and in your organizations in a similar fashion. So making the connection to Constellation Brands as well, what was it looking like in our population? A lot of the same issues, areas of concern that you all have. We talked about those chronic conditions, top ones for us as well: metabolic disease, mental health, cardiovascular disease, MSK, and diabetes. We're all facing that, right? And we're talking, again, a lot of those individuals have several of these or are dealing with other chronic conditions. So really, that was what we're looking to tackle here in the population. And then and talking about those multiple chronic conditions. So look at the areas of 1 to 2 and 3+. Again, over 16% have 3 or more chronic conditions. So we're really trying to support these individuals in our support programs. And really, again, going out looking for a vendor who can help us control costs, make it easy, and really be, again, not old-fashioned and stacking those point solutions, tackling one by one and having this vast array of point solutions. So we really needed a kind of a more specialized, targeted approach here, and we're looking at a holistic approach to tackle these and support our population. So to solve this, we needed a better way to identify the people who were truly struggling, and not just those who have a condition, but those who aren't managing it well. Because if we keep targeting those individuals, I thought this was a tough screen, apologize. Oh. I don't know what it's, anyways, so precision targeting of those who need help. So again, not just looking at diagnosis of individuals, but really how are they utilizing healthcare, collecting data, and targeting those individuals specifically, and really those who need help. So being more sophisticated with that, not just looking at diagnosis codes. Hey, let's throw a solution at them. How are they using the system, and be more precise in targeting those individuals. Singular view of all meds, symptoms, conditions. Again, that holistic view together, and how can we support them in every area that they may need support. Not just talking about one element or one diagnosis, but how is individuals using meds those symptoms that they're suffering from and the conditions they may have. And then aligning those resources with whole person care. How can we support them, from your well-being, changing your behavior, talking about your pharmaceuticals you may be using, your mental health support, how can you look at that individual holistically, and sufficient time and budget to drive engagement. So this is an interesting point. Evaluating engagement in our clinical programs, and what I was seeing with our health plan partners was the engagement question was very interesting. Are they fluffing the numbers a little bit? What is true engagement? And really, I was looking for a vendor who is able to report and share meaningful engagement, meaning they're having conversations with individuals, they're measuring outcomes. That's true engagement, and I was looking for that creative solution. So really, with this vendor of choice, we identified it's not just, again, blanketing the population in whole, really having a targeted solution. And when at Constellation Brands, really, I look at the population as the healthy people, and this is out of the de-Eddington playbook, as I'm sure you've all read, but the healthy people, keeping the healthy people healthy, the suboptimal folks, and then the chronically ill or high cost individuals or more catastrophic individuals. And really, I was looking for that middle kind of suboptimal folks. And this vendor brought a solution where they're really targeting those folks that, may not be creeping up to significant costs or extreme costs, although these individuals do cost, anywhere from $16,000 to $20,000 a year. They're overutilizing the healthcare system. And when you look at the profile of an individual with those kind of conditions, they should be utilizing it less. So they're really going to focus their time on those overutilizers, and it's a great opportunity, low-hanging fruit for them to target those specific individuals. You can see here how the percentage in which we looked at 1,225 participants and really spent time with those individuals who have a great opportunity to really lower that utilization, look at that whole person care to support them as needed. So I'm a big numbers guy. This was one of the great elements and partnership that we've experienced is we talk about engagement. What is true engagement? We've been seeing great numbers, vastly outpacing our health plan clinical partners as well. We have true engagement with guides. So they have a model of guides and pharmacists, and they're having when you look at tracking results, so 84% of the engaged folks are tracking those results and engaging. And there's great opportunity in the medication space as well, or number of medication therapy recommendations, 219 plus, projected savings of $1.66 million. Just we're hearing great things. You can see a testimonial up there. We've seen great outcomes so far. So really, when rolling this up, we're looking to help individuals manage multiple chronic conditions, again, holistically, not just throw point solutions at them. Think about the time. I was in the doctor's office the other day with my daughter. We were in there for 3 minutes, and then the doctor left, and I'm sitting there. Wow, I had a lot of questions, but they needed to leave. So providing the time and focus needed for dealing with those multiple chronic conditions. So getting people, allowing them the opportunity to have great discussions with experts, pharmacists, health nurses who can support them after the doctor's visit. Not all MCCs are created equal. So again, we're talking medication guidance with lifestyle change. Again, that whole person view for managing chronic conditions. So does your healthcare strategy address the specific needs of a multi-chronic population? That's the question you need to ask yourself. Big reveal. I can't say enough about Moby. Sarah and Curtin are in the back. To summarize my business case, this was an easy win to bring into the organization because, again, that holistic support, they have a shared savings model, performance guarantees. I'm a data guy. I'm sure you all are. They provide the quarterly business reviews to show the outcomes. They're showing you the hard savings. We're in year one. They already have projections of 1.6 approaching $1.7 million. Again, I'm lowering that trend. I can go to leadership and say, I have X% that I'm tackling this medical trend with this partner. And it's been phenomenal. Again, go have a conversation with Kurt and Sarah in the back. Yeah, I'm happy to visit the booth with you. I would love to do that. So appreciate your time.
Thank you all. So I'll just ask a couple questions here and then we can open up to the audience or any online questions. Each of you kind of tapped on, key stakeholders, leadership, involvement, and support. Can you talk about how did they come to the table? Were they bringing this to you? Was obesity the main concern? Were they aware of this obesity, cardiodiabesity, trend? Anybody want to start?
I will.
Yeah, give it a tap. Yep.
So at Constellation Energy, we actually split away from another company back in 2022. So with that brought on new leaders and a new culture that we were able to reinvent. And starting from the top down, we have a culture that cares. So our leaders were aware of what our needs are, but it was very easy to receive approval for to go with Wonder. So they're very happy with it.
Great. Joanna?
Hello, hello. I like that you just called me out there, just Joanna.
Hey, so I mentioned already, right? The two words from my CEO, do something, when we're having a conversation in June of 2022. That really sums up our CEO and our senior leadership team. I get to have a seat at the table with people who understand the importance of valuing people. We talk about people first culture. You probably hear it all the time. Culture, culture, culture. I believe in belonging. I think it matters so much more. But when I went to, I call it game day, and I get in front of my CEO and my senior leadership team, and I say, hey, here's where we are, here's where we get to go, and here's the journey. It's not really a decision point. It's like, I've already done the work for you. It's a no-brainer. And then it becomes a conversation about not only what we're going to be doing today, but what we're going to be doing in the future. So it's a strategy discussion. It's a partnership in a way that, and for a company that I've never been a part of a company that has done it this way. It makes me proud to be a Wabasher, but I know it is challenging, and I have worked at companies that is not the case, right? The first thing on the chopping block, similar to a school, right, is like art and music, right? So sort of like similar to maybe a company, what's the first thing on the chopping block is maybe a Verta, a Moby, or other, right? And I think that it's important, right, to just continue to use data as your friend, which is what we learned from Neil, but also, just telling your story. Culture matters, which is just what we learned as well. Just continue to believe, and eventually, I always say it like this: if you're given a no, I see a no as a not right now. And a not right now is a maybe. And there is so much power and possibility in maybe.
Thank you. Neil, thoughts?
It was, as I mentioned, it was an easy sell having a vendor coming into the organization or providing a solution that is a shared savings model. Again, I think seeing that more and more, moving away from PEPM is that's just a no-brainer. And guaranteeing cost savings, delivering that to leadership, again, easy win. It's interesting. One of my leaders then, after we implemented, brought up in a leadership meeting, who forgot, maybe didn't connect the name to the solution when I spoke about it last year, but what's his Moby partner that we're working with? And he called me up. I said, yeah, they get in your face. They are super rigorous and engaging your population, which is what we want. I'm glad that you're talking and bringing Moby up. That means it's working. And here are all the stats behind it, and the engagement numbers and the anticipated savings to date. It was easy conversation. Fearless conversation, because here's the backup. So
Great. I love that you're all talking about data, putting this all together, making it easy for those decision makers. Leaning back into what Dr. Singleton was talking about too is, what gets measured gets paid, and that's what makes a difference. So were there any lessons that you've learned, anything, that was a barrier or particular successful, about these programs that you would share with other employers in the room who are taking on this space?
I mentioned the chatter around Moby, and we got a few calls. Who's this vendor? Who's this vendor? And it was an opportunity to normalize the conversation with employees on, we're trying to help you engage with your well-being, normalizing that conversation, not being afraid of that complex conversation. Because you typically stay away from, oh, we're helping manage population health, clinical engagement models. I think sometimes we shy away from those conversations, but why? Let's have those conversations. Employees, give them the benefit of the doubt. We're here to support you, give the opportunity to manage your chronic conditions. And we see it in the engagement. Approaching 90% are tracking their how they're utilizing this vendor. So they're using it and they're engaging and they need it. So that's been a great eye opener for me, is having those conversations.
I'll go next. So for us, for lessons learned, it's really success stories that I have to share. I'd recommend going through a trial period. So before you sign the contract, go through the trial. So we tried it to the two vendors that we were looking at, and it gave us a great opportunity to see what they were offering and for us to understand the user experience. And I have to say that I actually like the other vendor a little bit more. Sorry, guys, back there. But then I had the opportunity to see what Wonder has to offer. And it really is on the go. You can easily use it. So I think that's a great story to share. And then also work with your vendor on communications and also provide timely feedback. And as I shared, and we've all had shared testimonials. So our employees are coming to us, sharing the stories that they have. And then we've used those testimonials in the communications we have. So in our benefits newsletter that goes out during open enrollment, and I want to say Benny's newsletter now, that we have testimonials about Wonder. So then the employees understand and they can relate to those stories as well.
Final thoughts, Joanna?
For sure. I have to say though, Neil, and the question for last ended with the word fearless and having that conversation with that senior leader. And also my microphone number is 22. I'm just saying, if you know those references. All kidding aside, I will say, look, Neil's hit on, I love data as well. You could tell any story with data, just make sure that it's a thoughtful, accurate one. I think that's important. And then also, look, I call my benefits and holistic well-being guide, which I should probably change it to Benny's. My baby, my second baby, really. It's a product of love. I'm sure it's similar. You have something similar in your lives. But it is also true that, maybe a subset actually read that thing and they use it when they need it. And I think that's important to understand when you're curating an ecosystem. It's important to meet people where they are. And so in 2026, what we're doing is we're rolling out a navigator that will be basically sort of a one-stop shop. Like, hey, if you have a question of where you don't know what you need, this is where you're going to go. So I think it's important to think about how we can help people access and navigate. I would say even without just these one solutions that we're talking about here today, that navigating medical on its own is already challenging. Most people don't even know what medical plan they're enrolled in. And you get to look at their ID card and have that conversation with them, right? But it's also true if it isn't working, so doing something is trying, and also trying means failing. And failing is also a success. So it's okay to toss it. Sometimes we just need to say, you know what, it's not working. Let's try something else. And that is okay too.
Thank you all. So I think in essence of time, we are going to go ahead and move forward. Are the three of you here over lunch? Yep. Yeah.
There's lunch now.
Yeah. So if you have burning questions, you can find them at lunch or find their vendor tables out here for additional conversation. And with that, I am going to go ahead and ask our panelists, you can step down. We're going to bring up our fireside chat. And thank you so much. And we do have a word from another one of our sponsors, Vida. Thank you for your sponsorship.
Excellent. Thank you so much. We are calling this a rapid fire fireside chat. And I could not miss the opportunity to have one of our sponsors and someone that we have worked very closely with, Lilly, invite their expert who works with all of the key stakeholders in healthcare to share his thoughts today and allow me to ask some tough questions. But we have 15 minutes start to finish. So it's going to be fast, targeted, and I'm going to try and save 3 minutes at the end for any questions in the audience. And I'll also add that James has graciously agreed to be in the presidential bar. They're not serving alcohol yet. So you would walk through this door, walk all the way across past the stairs and in there for employers only. We have 8 slots left, okay, to ask good questions of him during lunch. So you'd get your food, you'd go in there, and then we come back to the program. James Gilroy is—
I was on the edge of my seat, by the way. I didn't know what I agreed to, and then I was like, okay, that's fair. We'll do that.
How about
Sounds
you
good.
agreed to it all?
All
You're
right,
just
sounds
going to
good.
show up. That's the way it works. First of all, where's the woman that was just on the panel that was super funny? Oh man, she was good. Okay. James Gilroy is the Senior VP of Corporate and Strategic Accounts for Lilly. He leads an effective team that manages their business portfolio with plans, pharmacy benefit managers, group purchasing organizations, institutional GPOs, and employer customers. He is focused on building enterprise-level partnerships, delivering exceptional customer experiences. We had a chance to prepare for this panel, and I was impressed. And so that's why I asked him to join us for lunch. I'm going to let him do like a 1-minute overview. You want to make some opening comments right or now, or should I go right to the question?
Yeah, I'll be brief on some opening comments. First of all, thanks for having us. Appreciate being here. I'd say as Lilly, we're relatively new to this forum, and I think that's probably been a miss, right? I think we certainly have a product portfolio that is very much in the sights of this community right now. But even prior to that, your stakeholders that are the primary payers of commercial healthcare in the United States. And I think we've missed an opportunity over time to not be more fully engaged and understand your needs. So better late than never, but over the last couple of years have built a partnership and we're super engaged. So I know we're going to do some rapid fire and open it up for questions. Really excited to do that. I too am a Swiftie. I'm from a family of Swifties. I can't believe she's outside and not hearing this. I had like 3 jokes I prepared that maybe only she would laugh at. So why don't we just get on with it? And hopefully Joanna's in the bar, you know?
Well, and the good news is we've been working with Lilly and the other GLP-1 drug manufacturer, and I'll say it's Novo. We have great relationships with both organizations. We're really following this closely and we're asking the tough questions. So let me start with, how can a pharmaceutical manufacturer provide employers more flexibility while retaining the lowest net costs when incorporating obesity medications, both on the diabetes and obesity side, for their into their benefit?
Yeah, I mean, it's a fairly broad question. I know something that this collective group probably wrestles with all the time, and also recognizing, and I think it's been stated pretty well so far this morning, that The pharmacologic intervention is just one step of a broader suite of resources that are required for a patient to live a healthier, more effective life when they're struggling with obesity or diabetes. I would say, we're at this intersection right now of this wave of innovation, clinical effectiveness that we've not seen before out of pharmacy intervention, and patient demand that I know is, rather challenging when you put those things together, what that means for budget pressure and just I didn't realize we were actually up on the
It's on my
screen.
bad side,
I'm
guys.
like watching people look at that. I'm like, how's my hair? It's gray. Okay. In any in any event, sort of that wave of innovation, clinical effectiveness, patient demand, all those things sort of coming together. I mean, I think we can speak a little to flexibility. I know you were going to ask that specifically around dynamics relative to rebates and how that works with dynamics with pharmacy benefit managers. So maybe I'll just combine that and say, I mean, I think when we came to market with Zepbound as Lilly, we came to market with lower WAC pricing, lower net pricing, and more flexible options relative to what was on the market at that time. I think since then, that's only continued in terms of prices coming down. I know for many, not far enough, but prices coming down, flexible options expanding. And I think to meet the needs of what you talked about, really ensuring there's clear dialogue as we've aggressively bid with pharmacy benefit managers and other stakeholders to ensure that these options are as affordable as possible. And there's a range, right? There's a range from broader, labeled indication, a relatively frictionless, seamless prior authorization experience, all the way to a dynamic that would provide, lower rebate concession, maybe a higher net price for a scenario where you want a smaller patient population than the label, maybe a differential BMI dynamic, maybe you want more interventions in place. So, I mean, I think it's rather complex, but I think the dialogue needs to be there with PBMs to be very clear about what are the options available to me, what is the then resulting impact on my net price across the category.
Well, and regardless of what GLP-1 you might have on formulary, we need to give employers guidance about the questions to ask, the benefit plan design, and all of those elements that drive up costs on the PBM side that you guys have no control over. One of my questions is, a lot of employers want to carve out GLP-1s and then their PBM says, no, you can carve it out, but it's going to cost you, $15 or $30 PMPM. And we're seeing that happen less and less, but there was a period of time. How can, if they do lose those rebates, if they make changes to the parameters of coverage, what would you say to them? Would you say, find a new PBM? Maybe that you wouldn't say that. I'll say that, find a new PBM. That's what I would say.
I certainly wouldn't say that. I mean, again, I'm not here to vilify PBMs any more than I want to be vilified as a manufacturer bringing innovation to this marketplace. But I understand there's a lot of tension right now, and I think we're exploring that tension every single day as we work with stakeholders in this marketplace. I mean, again, I would reinforce, more often than not, the dialogue around rebate loss and price concession challenges seems to be one of misperception. I think we didn't do a good enough job when we first came to market in identifying tools and resources to communicate some of that flexibility. And I mean, if you talk about a full carve out, that's a very different scenario. But if you talk about flexible options, the ability to whittle down from a broader FDA approved label population to one that is, a better mix for your current budgetary constraints at this point in time. I mean, there are examples of that where we have deals across all three PBMs where three major PBMs and many nested underneath them that would still be able to provide rebate concession there. Devil's in the details. Obviously can't speak to your specific contract with your PBM, but I think it's that dialogue and that clarification that's critically important. More often than not, we find there is misperception, and oftentimes we're willing to get on calls together, not to the specific detail of the actual price concession, but to talk through needs and make sure if there's a matching option that's already out there, that we can execute on that together.
And I'm going to challenge the employers that I'm working with on this, as well as you and your colleagues, what those questions are, because we need more specificity.
Yeah.
That would really, really help us. As a manufacturer, you're
I think, if I could just say, I think that's totally fair. And I think you should you said this is hard hitting. You put that question to us. I think the things you need to discuss are, what are the dynamics around BMI? What are the different cohorts we could look at, and what is the resulting impact on rebates? What are the various point solution dynamics and language associated with those? There's a misperception that if you are essentially, utilizing some of these programs, then you automatically are losing rebates. Certainly not the case. We support them. We think they are an integral part of a holistic offering for patients that are on this journey. And there's a number of permissible dynamics that would enable you to still take advantage of rebate offerings. Your level of friction that you apply within a PA, from a scenario where it's seamless and automatic, electronically adjudicated look back, to one that requires chart notes. If you talk about a spectrum like that, there's price concessions associated across the board, and they modulate accordingly. So that's just a start, but perhaps in the room over there that I committed to, we could talk about more of that.
Sounds good. So you and your colleague both offer, in the GLP-1 space, both offer direct-to-consumer programs, about $500 a month for them. Do you think we'll ever be able to move into something that simple for the employer community?
Yeah, it's a wonderful question, and certainly a journey to get there. I would say, like, when we led in this marketplace and launched Lilly Direct, it was by no means intended to be like our core strategy to get this innovation to patients, right? Our North Star continues to be core reimbursed offerings via employers like the ones represented here in the room. We understand, and the data would suggest that about half of that population is on the sidelines today, and in some cases for very good reason. We understand that. So we built this as a secondary option to be able to get product to patients. We also recognize it's not ideal for you if you've not selected coverage and you don't provide coverage for the obesity class of medication, to have one of your employees outside the benefit accessing care like this. We recognize that that's not ideal. We'd love to continue to sort of whittle down the DTC offering and build up an offering that is via that core reimbursed population. There are examples today of pricing, though, that is relatively consistent depending on your contract to what you quoted at the Lilly Direct, or call it NovoCare level, any sort of DTC program, to what you might see via a PBM as well, depending on the options that you select.
And it's interesting because I just read an article, and the information is out there, and our AOM Employer Action Brief has some information in it. The average cost, and I'm not going to ask you a question about this, but the average cost for an employer is $1,300 a month. Some have it get it as low as $1,000. The DTC rate is $500. So we've got some work to do. Talk to me about future innovations in the space, for example, oral medications.
Yeah, I think we talked about the wave of innovation that's here and the clinical effectiveness associated with it. I'm not able to, proactively promote to non-FDA approved products, but I can just share, and it's public knowledge, that Lilly, our competitors, are pursuing oral medications. We think these oral medications will have the opportunity to reach a broader audience, be more convenient. I mean, certainly as you think about populations outside the United States and supply supply chain dynamics, like the bringing this innovation to the world in a better, more efficient way is something that we're certainly after. So I think you'll see different formulations from an oral perspective. I think you'll see new indications across other sort of disease states that are equally as challenging as obesity. There's a number of them. If you look on clinicaltrials.gov, you can see what's being studied. But I also recognize that all of that just puts a bit more pressure too on trend, on spend, on budgetary dynamics. So I think you'll see, as this wave continues to come, you'll see us putting pressure on price points as well to make sure that we get to more accessible, more affordable options for patients here in the United States as well.
And I think there's a lot of lessons to be learned for the pharmaceutical manufacturers for what happens with GLPs, both on the obesity or the diabetes and the obesity side. I'm going to open it to the audience. Do we have any questions out there? Here's your chance. This is it. So it's interesting because we talked about.
Don't make us go to the second bank of questions below the fold. I know there's got to be something in the room from
I've got some online here.
There you go.
Yeah.
Oh,
Okay.
good.
So has Lilly considered eliminating rebates on their products, especially GLP-1s, whether procured through PBMs or direct contracting by employers?
Great question, whoever asked it.
Let's go to the second bank of questions. Listen, I think a world without rebates is one that we're certainly interested in as Lilly.
So are we.
Yeah, our CEO has spoken out around that. It's a hard system to unwind, and I think there's value for a number of stakeholders across the healthcare continuum in that regard. But we would be more than happy to progress to a world with more transparency, more opportunity to know exactly what, a patient is paying at the pharmacy counter, what you're paying as an employer. And if that winds up being a world without rebates, we'll work with any stakeholder in the U.S. healthcare marketplace to get to that.
And I won't ask you that question, but I think the only thing that is going to get us there is legislation on transparency and what that looks like in the future. That's the only way that they're going to make changes. Hey, James, this was awesome. It was quick, but awesome. Let's thank him for being honest. So we've got lunch coming up very shortly, but before that, we have a special little session that we want to do on recognizing someone. And let me see. But first, do we have a word from Moby now? Oh, I'm going to read this. That's right. So I have a word from Moby. They didn't have a vignette, but I'm thrilled to be able to share a little bit about who they are and what they do. They were founded in 2014 with a mission to help people discover new ways to live healthier. They partner with employers and health plans to find an often overlooked population with multiple health conditions and concerns. They offer whole person solutions that combine a 5-star app, personalized lifestyle guidance and medication optimization, and proven solutions that deliver improved health for thousands of people while saving employers and insurers millions of dollars in healthcare costs. And thank you, Moby. And now Paul and I are here to share a little bit of sad news. Dawn Weddle, our vice president, did you know it was coming? No. Okay, well, it's coming. Is actually stepping into retirement at the end of the year. And I'm pretty ticked because I'm way older than her. So anyway. First, we have a short slideshow of some of Dawn's highlights. You can, I'm done. Look at that. board meeting. We'll see you now. I'm reading my notes because I don't want to get emotional, and I probably will, but Dawn was a friend and colleague for a long time when she worked at Navistar. Then she went to a population health management company, and we had a colleague, a good friend who was in Indianapolis, and she was very sick from inflammatory breast cancer, and we wanted to go visit her. So we had a 6-hour drive to Indy and back, and in the car, talking about working for a nonprofit. It's really hard working. We work super long hours and we're very passionate, but we love the work. And she'd been with this pop health vendor company and said, I'm ready for a change. And we started talking, and by the end of the trip, we kind of figured out a way that we could have her join us. And how many years has it been? 3, 5, 10? 7. 7? Is it really 7? Wow. She joined in April of 2019 and immediately became an integral part of the team in early 2020 when the world came to a halt. She knew how to quickly pivot and was instrumental in turning our biggest event of the year, the annual conference, into a seamless virtual event. We literally had about 6 weeks to go from the JW Marriott downtown Chicago to making it virtual. It was a tough time. She is an excellent speaker and facilitator, presenting with confidence, grace, and humor, except I hear you fell off the stage once, didn't you? Yeah. She has a knack for highlighting key insights, asking poignant questions, and keeping audiences engaged. Behind the scenes, she has been a driving force in our growth and strategic direction, contributing to countless operational improvements. And she said to me recently, you know, what I'm good at and what I've tried to help us do is that if I see something wrong or isn't working well, I fix it. And she does. And that's going to be, beside being a friend, one of the biggest things I'll miss. The senior staff gets together several times a year, and we come up with the theme for the annual conference. She's always there with like really compelling ideas, and we'll miss that too. She contributes to countless operational improvements, projects, toolkits, action briefs, educational event. Her skills are unparalleled. She is a consummate project manager. Did you write some of this? I think, you know, meaning that she juggles countless priorities with ease. And so it's going to be almost impossible to replace her. So we're looking at other options so that, you know, we have several people doing some of these pieces, but how exciting for her. Are we letting her come up? Because otherwise I'm going to say her husband retired. So of course he was in the background saying, when are you retiring from the federal government? So figure that one out. She has grandkids that she wants to spend more time with. She wants to travel more. She has no idea what to expect, but just know how much we'll miss you. She may do a little extra work for us after the first of the year. Paula?
Yeah, thank you. So I've known Dawn since 1996. We were just spring chickens. My first job out of grad school, I really could not have asked for a better coach and mentor from early on in my career. I've had the privilege now of crossing career paths with her 3 times, the 3rd time being here at MBGH, and now she's leaving. So I don't know. Is there something wrong with me? I don't know. But anyway, these are not just Cheryl and I's sentiments. This was a team, we collected everybody's thoughts. So we're just kind of summarizing them for you. But Dawn is the idea person. Like Cheryl said, she's always, looking for ways to make what we do better and make us more efficient and faster and smarter at what we're doing. As a leader, she makes herself available. She's so responsive. She not only encourages us and her team members to have work-life balance, but she really lives it and models that. And she's present for every conversation. This woman can juggle so many balls, but she's always present with you. She's present with her family. She makes you feel valued and appreciated. And we know that you, as our members, feel that as well. So Dawn rarely sits still. You saw a picture of that. She was meditating, at one of our events. She also knows how to pump the crowd up. She does her energy breaks. You'll see her up here a little bit later for some of that fun. And her fierce competitiveness comes out. You saw that with the balloon video there. So she's generous by nature, always giving out our prizes at the end of our events, but also just personally, we all look forward to her homemade granola.
Yeah.
Top notch. So she'll be with us till the end of the year. She's going to trade in her MBGH projects and to-dos for, like Cheryl said, golfing, traveling, baking, sourdough bread, canning pickles, all the things, enjoying her Tillamook peanut butter ice cream every day, matchmaking. There's fun stories on that too.
You
And
have
then,
matched with me. Why?
yeah. Yeah, and being the fun grandmother. So we are going to miss Dawn as she goes. We are going to go into lunch. Please visit all the exhibitors, take your card, make sure you drop that off by 2:10. But we wanted to give you this announcement, let you know this is happening so that you can stop by and wish Dawn well as well, because this will be her last learning network with us. So thank you, Dawn.
Many years of service. Aw. Thank you. I'm thanking them on your behalf. So just a quick reminder, we have 8 slots open to sit in the room directly across here by the stairs with James and get your lunch and go in there and go have some lunch. Thank you.
Good afternoon. As we come back into the Michigan room here for our afternoon program, we're going to start with a little video that our friends at Gallagher helped us pull together, reinforcing the value of MBGH membership. So my colleagues in the back are going to start up that video and enjoy. Oh, I do? Okay.
There's a magic that happens at MBGH events.
Networking is actually one of the most valuable parts of the membership.
Different employers from all over the country, the opportunity to meet and engage with some really smart people, many different states, all different sizes, many different industries.
Amazing employers who I can learn from, they can learn from me.
There's an area where we're able to exchange ideas, ask questions, and find out how other employers are solving some of the same problems.
I love coming to these because I can have those in-depth conversations, get like good, thoughtful feedback.
What's really helpful are the other webinars throughout the year, right? They're an hour long, they're round tables, sometimes in person. You get to hear from the industry experts. You also hear from employer experts.
I mean, we're getting to hear from really deep, seasoned experts and get insights that you just wouldn't get elsewhere.
They're so passionate about advancing healthcare, about disrupting healthcare.
They are advocates for the employer.
You can trust the MBGH staff in some of their vetting of some great industry partners.
They want to make sure we're doing the best job for our associates.
Compared to other organizations that I've been with, the vendors are really partners. They're looking to help advance us in our profession and support us with our needs.
I'm really impressed with what MBGH has put together.
Very concrete, unbiased information.
Every single different type of employer can get something out of either the MBGH website or being a member of MBGH as a whole.
That gave me the comfort level of what I should and shouldn't do and how I should be thinking.
White papers, action briefs, roundtables, meetings, and of course, our not to miss annual conference.
The annual conference that we hold is always fantastic.
It's definitely one of the most energetic and engaging events.
500 people in a room talking about the most pressing issues for employers.
There's probably no better event.
There's a lot of great thought leadership that goes on all throughout the event.
Different thoughts and ideas, real difference makers.
Seeing all of these employers meeting new people, talking to each other, making friends, and I am so grateful that we are able to foster that.
The employers that belong to MBGH are very close.
It almost becomes like a family. It's not just about benefit geeky stuff.
Yeah, participating in MBGH is more than just business. It's a great way to make friends.
We learn a lot, we laugh a lot.
Just a really cool, great network group of people.
It makes me better as a benefits
And a special
professional.
thanks to our board members, MBGH employer members who helped us pull this video together. And now we'd like to extend a word from one of our sponsors, Verda.
Hi, my name is Jason Arnold, and a little bit about me and my history. Like so many people, I wanted to get healthy for my wife and kids. I tried multiple diets, tried multiple workouts, and things would go good. I would lose some weight, I would start to get in shape, but then, like so many people, I would plateau. And when I would plateau, I would get discouraged, I would get depressed, and just say, what's the point? And then I would start eating it again, gain the weight back, and it was just a cycle. A new diet would come out, I would try that, same thing, I would plateau and repeat the cycle all over again. My employer, Old Dominion, they started using Verda for type 2 diabetes, and I'd heard good things about it. And then in the fall of 2024, they opened it up for weight loss. And so I thought I would give it a shot. Might as well try it because the very worst is going to happen. I'm going to just continue this cycle. But I tried it. At the time, I was 242 pounds. I was overweight, tired, wasn't sleeping very good, and just unhealthy. And so I officially started Verda on October 20th of 2024. My coach, Harmony, she's been nothing but amazing. And with her help and support and encouragement from my family and friends, I was actually able to kick down the plateau door. And I lost 41 pounds on Verda. The lowest weight that I got down to was 201 pounds. And my goal now is just to maintain between 200 and 210 pounds. I feel like that's a really healthy weight for me. And I've been able to maintain in between there now for several months. I believe anyone can have success on this program. In fact, I've actually gotten several coworkers on this program. They've seen similar success. And so that's been great. I'm a firm believer in Verda, and I highly recommend it, especially if you're looking for a healthier lifestyle.
Again, I'm Mark Flager, and one of the hats that I wear at MBGH, along with membership and strategic partnerships, is leading the Midwest Health Purchasing Collaborative, or known as MHPC. MHPC offers MBGH employers the opportunity to use their collective purchasing power to contract for health benefit products and services that have been vetted and approved by the MHPC board. These best-in-class partners offer their unique set of customized solutions at special MBGH pricing to help employers save staff time and money. I am truly proud to have 3 MBGH employer members on stage and online with me to talk about how Vita Health, Inspira Health, and Carum Health, again, all MHPC partners, have made a difference in their health and benefit strategies. But before I introduce our employers, a little bit about my perfect fall day is a crisp, sunny Saturday afternoon cheering on my beloved Michigan Wolverines on to victory in Ann Arbor. So go blue. Okay, let's get started here. Our first employer is Amy Hedkowski, who is a senior benefits analyst at Fortune Brands Innovations, specializing in communications, strategic benefits design and employee engagement for approximately 6,500 associate population. She has over 10 years of experience working in employee benefits at manufacturing organizations with a focus on making benefits accessible and impactful across diverse workplaces. And Amy's perfect fall day is hiking and enjoying the fall colors. Welcome, Amy. So, Amy, what is the primary problem you were trying to address for your organization, and how did you solve it?
Sure. Thanks for having me. I would just like to add that with Fortune Brands Innovations, we're a manufacturing company, so we have a diverse population of salaried and manufacturing across the whole US and the globe. We focus on the US. So some of our brands that you might recognize would be Moen Faucets, Master Lock, Century Safe. So just wanted to add that. I forgot to put that in my intro. So primary problem and how did we solve it? As with most of you, which is why we're all in the room today, primary problem, we're all experiencing high pharmacy costs, particularly GLP-1s. They're on the rise. Back a couple years ago, we had siloed vendors. So we had a vendor for weight loss and we had a different vendor for diabetes. A couple years back, we had some reorganization where we actually spun off one of our businesses and we had the opportunity to restructure our benefits strategy. So we came up with new strategies, goals, guiding principles, some of which are really key to our hearts, being removing access to care, more accessible benefits, simplifying our benefits, providing value. So with this, we had the opportunity to really take a deep look at our vendors. In doing that, we decided to take those two siloed vendors, bring on one comprehensive solution that went beyond that approach and really took care of that whole health approach that we've heard about so much today. So we chose this vendor for that whole health approach, integrating our medical, behavioral health, nutrition, and coaching support. They bring flexible clinical processes, so they meet our associates where they're at, which we've also heard so much today, with realistic, personalized plans. So we'll talk more about all of that, but that was kind of our problem and our approach to solving it.
Great. Our second question is, how are you measuring the effectiveness of this strategy for your organization, and what are the outcomes?
Sure. We really look at the numbers. So we've also heard that as a theme so much today. So our vendor provides us real numbers. So those measurable outcomes, we're seeing our utilization higher than our vendor's typical book of business. Our NPS score is very high. So those clinical outcomes, we're seeing significant weight loss of over 5% amongst our population over the course of those 12 months, reducing A1C numbers. We're seeing a strong progression. So only 1% or 99% have not progressed to a diabetes diagnosis within the population using the program. And one number that we're also really proud of is we're seeing a high reduction in depression and anxiety symptoms. So those that are using the program reporting that they're experiencing anxiety or depression, we see a 79% reduction in those symptoms when they're doing one of their future check-ins. So we're really proud of all of our numbers, thinking that our numbers are showing real results. So hard numbers to measure that effectiveness. We're also hearing strong employee feedback. So our vendor does a great job of collecting feedback. As I'm sure I can speak for a lot in this room, when we're in HR, no news is good news. Sometimes you often hear just negative feedback, but early on when we introduced this program back in 2024, we were hearing positive results early on, showing that we're hearing it from our employees as well. And lastly, we measure effectiveness with our communications. So they do a nice job of every time they do an email campaign or a mail campaign, we can see a chart with our registration numbers spiking in that particular month.
Compelling. Question 3, what is your organization getting out of this relationship that you feel you would not get from a typical vendor in this space?
We really feel that this vendor we have a strong partnership with them. It's valuable, it's trusted. We have a great relationship with our account team. And then we have trust in them, and then we're seeing the trust with our associates. So they're proactive, they're customizable, so they're not a fit in the box approach. You know, we tell them what our needs are. They work with us to address our needs in a customizable plan. Last year, when there was some regulation, formulary changes in the GLP-1 world, they came to us with a plan. And we had just barely heard from our PBM about this formulary change. About 5 minutes later, I swear, we had an email in our inbox from our account team saying, here's our plan of attack, here's what we're going to do. And we felt so just, we were in their hands, trusted hands, and we couldn't speak more highly about that trusted partnership. We were with this vendor for approximately 10 months before we moved to them for our sole prescriber for GLP-1s for weight loss. So we had been with them, they kind of, knew us, we learned about them, and then we decided to expand the program into that sole prescriber. So, and that was last October. So we're almost a year into that, and we're really still very happy with our relationship.
And lastly, Amy, what makes the approach unique, and what do you value most in your relationship with this vendor?
Kind of touched on it a little bit with the personalized approach. So we really truly value that member first, member centric approach. Each person that signs up gets that personalized plan depending where they are in their journey. So not just a, curated, here's our plan of attack for you to lose 10 pounds. It's where are you? What have you been doing? Again, we've heard about that this morning. It's really important to take into consideration, what can you do? Not just here's 5 things that you have to do. So really trying to meet people where they're at to have success. Any success is success in this space. So we're really look for that with that personalization. Again, removing barriers to care is one of our objectives. So we find the ease of access is very important too. I mentioned we're across the US. We have a lot of rural populations. I've been to some of these sites, and sometimes it's hard to find good food to eat at. So it's really nice to have a program that's accessible, quick reach. They can talk to somebody, get that nutrition counseling. For example, we all know it's hard to get into a provider. We've heard this morning, nutrition is not exactly something that's top of mind for providers or easy to find in your network. So to have one at your fingertips, yes, it's a digital program, but again, it provides quicker appointments for our associates.
So we're going to keep you in suspense until the very end with the reveal slides where we'll connect each employer with their vendor partner. We'll see if you can guess. You heard the 3 MHPC partners we're featuring, but again, the big reveal at the end. But thank you, Amy. Moving on to our next employer. She's virtual with me all the way from Omaha, Nebraska.
Thank
And
you.
we have Kelly Grimes, who is a registered nurse, certified ADA coordinator, and the director of human resources at Mutual of Omaha Insurance Company. She has many years of experience as an inpatient cardiac care nurse, but at Mutual of Omaha, she provides strategic oversight for all employee health and welfare benefits, including disability inclusion, absence and leave management, and well-being benefits programming. And Kelly and I share a fall passion together. Kelly also is a college football fan, an avid and dedicated Nebraska Cornhusker. So welcome,
Yes,
Kelly.
frenemies in college football world. So thanks for having me, Mark.
You're welcome. Okay, so let's go to question 1. What is the primary problem you were trying to address for your organization, and how did you solve it, Kelly?
Yeah, I think like many of you all today, we're here to address the high cost and often poor health outcomes that our associates with chronic multiple health conditions often face. I think like many of you probably can relate, it's a very small yet highly impacted group that drives a disproportionate amount of our healthcare spend. So our hope was to partner with our vendor partner to offer our associates and plan participants really a specialized program that could meet their personalized and collaborative care plan needs. Mutual of Omaha takes very seriously the health and well-being of our associates and our customers. And we really recognize the importance of making sure that people have the tools that they need to take care of themselves, but that, I think we all know, can often be confusing to navigate for our employee populations. And so by partnering with our vendor, we were able to implement a program that really goes beyond disease management and we think addresses the whole person, incorporating their emotional, physical, financial, mental health well-being while taking into consideration those social determinants of health in a really meaningful and impactful way, and with one-on-one coaching that can drive for them identifying problems, pain points, and implementing solutions to help our associates take control of their chronic conditions and really be supported with the resources that we hope they're utilizing to drive for a meaningful change in their lives. With, of course, the return being that healthier employees means that the programs we put out are being used appropriately and can drive, certainly for us, cost savings that we've seen.
Thank you. And how are you measuring the effectiveness of this strategy for Mutual of Omaha, and what are the outcomes?
Some of ours are similar to Amy's. Certainly, we receive a tremendous amount of positive feedback from the employees and their family members, candidly, who are engaged in the program. But we also, are mindful to measure the clinical effectiveness of these programs, and our vendor partner utilizes a special proprietary metric to benchmark and quantify the metrics for healthcare improvement. So we've used this to point to a number of key areas, tracking everything from biometrics to behavioral change, and the outcomes we think have been very compelling. First, we've seen the average health outcomes of our participants improve by like 47%. More notably, we've been able to address and close the gaps that we see in healthcare. I think I mentioned before, we put these programs in place and we hope that people use them, but this program has been able to close, 36% of the gaps that we saw in preventative care access challenges. And I think most notably, we've seen an 80% improvement of some of the mental health resources among this population. Lastly, not to be overlooked for us, is the financial impact. And while I think we all know claims reductions can be a lagging indicator, our average medical and pharmacy claims for these populations were well over $60,000 to $70,000, and our vendor population participants and the cohorts we've had in partnership with our vendors are seeing reductions nearly half that amount. So we've seen that it's not only improving their health, their behaviors, and driving good engagement, but we hope that these things translate and continue to translate to long-term savings for our employees and the plan.
Kelly, what is your organization getting out of this relationship and you feel you would not get from a typical vendor in this space?
Yeah, I think, what our vendor has that many others often strive for is really a whole person, individualized support approach. As we mentioned, they integrate mental, physical health, and social determinants, but it's rare to see it done in a truly comprehensive way that, focuses individual one-on-one with those employees and their family members to see what roadblocks exist and how can we break them down to get them on a path to a healthier lifestyle. So for us, it's not just transactional, it's focused on sustainable and incremental behavioral change. And I think our partners do that well, and it's in their long history. We think that their success is rooted truly in the multidisciplinary team that they have and the strategic insight and collaborative support that they give us as a plan partner is rare. Like Amy mentioned, we've come to them with problems in the past, and how can we provide these highly impactful programs to the customer populations or employee populations that we know need it most. And they've met us in that, helping us think through how we might design the plan to support that. And really, it's the individualized custom solutions that we so often want to implement in these populations. And we're able to provide them to our associates directly in real time and in ways that resonate for them, while managing the enrollment to ensure that the programs we're standing up really meet the populations who need it most.
And you touched on this a little already, but what makes the approach unique, and what do you value most in your relationship?
I think it's the win-win, right? That our vendor partners are talking with our associates, understanding their behavioral change needs, often what might be driving their needs for change, their support for us as an employer and what they're seeing, and that visibility, the creativity on how we can design the health plan to meet these needs or account for the needs that we're seeing. And I think truly it is a vendor partner that allows us that individualized, customized solutions that you can't often roll out to the masses. And this allows us the creativity and the access and the ability to do that, to provide one associate or their family member access to a resource without opening the entire plan to that in a way that allows them to improve their health. It's rare.
Thank you so much for joining us all the way from Omaha. Hang on there, Kelly. And for everyone, you're going to have the opportunity to extend questions. We'll have a Q&A period at the end of this fireside chat. But before there, or then, I'm going to introduce our third employer, Sue Latang, is the Senior Manager of Health and Welfare Plans at US Foods. Her key responsibility is the development and implementation of US Foods wellness strategy and initiatives to engage the associates and over 40,000 plan members. Over the last 4 years, she has rolled out 10+ point solutions to ensure specific health conditions are addressed within the US Foods population. In addition, she leads and manages the benefits communication strategy, design and distribution, while coordinating and engaging 70+ wellness champions across the USA. And Sue shared with me her perfect fall day is cider and donuts in Long Grove, Illinois. So you all ready for the big reveal? I'm sure many of you connected the dots already, but okay, Amy Hukowski from Fortune Brands Innovations. Who is your partner?
Is Vita Health.
Okay, great, thank you. Kelly Grimes from Mutual of Omaha. Who is your partner?
Inspira Health.
Great. And Sue Latang from US Foods.
The one and only Karam Health.
Okay, great. Well, thank you very much. We really appreciate you sharing all of this feedback about your vendor partnerships. So we're going to open it up for Q&A right now. We have 5 minutes left. I'm looking at the screen here next to John. So bring them on. We welcome your questions. Okay, see one over there. Right over there in purple, right? No? No.
For our Zoom participants.
Thank you. So I've spent the month kind of in all of these roundtables, and I'm curious, Sue, about your thinking about, will you continue to make it optional, or now that you're seeing these results, and I guess for all of the employers in the room, how are you feeling about mandating at least a screening through these programs before you proceed to surgery?
And I love that question because we just rolled out color. So I look at color as the precursor to Karam because it's all about cancer prevention. And I think the key here is prevention, because during COVID, a lot of us did not follow up or follow through with our appointments. And so now we're seeing the ill effects of that with all the cancers that's on the rise. Because I'm sure you guys would agree that that's like your number one spend now, and it's very costly. So the great news is, to your point, prevention, key. We haven't mandated that because we just started it. We've incentivized it for years now, where you can do a colonoscopy, a PSA, a PAP, skin IO cancer screenings with a dermatologist is just as great. Colonoscopy, Cologuards, we've done that. So to incentivize people, we give them $65 monthly for the entire year to make sure that they get their preventative exams done. So that's a great question, because a lot of times the high cost claims we see is because of lack of prevention. So we feel that burden down the road because we didn't take care of ourselves earlier on.
Great, thank you. It looks like we have a question online.
Yeah, rapid fire. So quick response here, but did you have any additional asks that were outside of your vendors' standard contracts to better address your needs?
So Amy, let's start with you.
I have to be honest, I wasn't involved with the contracting process, but I do know that we always make sure there's room for us to customize our programs and our contracts.
Great. Kelly?
Yeah, I've had some time to ruminate on this since I saw the question coming through the chat. And what I would say is, we have had several conversations with our vendor partners, and I think that probably the key differentiator for me is they've brought forward to us several opportunities that were not originally discussed in our original contracting. They've been key participants in meetings with our health plan, our pharmacy plans, and our consultants to ideate on what else is possible, how we can open access to these things, and really contracting and additional pricing structures hasn't been a conversation. They have access to the types of providers we're often hoping to get, behavioral health resources, different physicians, dietitians. And so their creativity in those conversations about how we might adapt the plan or think about our offerings differently while opening them up to a different population or to a segmented population, they've really been critical in bringing some of those things forward and have been key participants in helping us ideate through what else is possible for things like prior authorizations and clinical step therapy pathways to the previous questions. So I'm saying this knowing that they're probably listening and wanting to revisit our contract. But yes, they have been key partners for us in navigating a lot of those conversations.
Yeah. And I wanted to say something.
They're in the room, Kelly, as you suspect. Okay, and moving on to Sue.
Yes, I wanted to say that with regards to that, what I like about our partner is the evolution. A lot of point solutions, I've done about a dozen. What I see is they've found a solution and they're done. It's like, oh, we found this, magic bullet and we're done. What I see is the evolution of Carum Health and the service lines, the COEs, the centers of excellence, and they come to us. Now, the service lines are all voluntary, so it's nothing that's shoved down your throat, but they come to you and say, how about pain management? Do you have a need for that? How about ear, nose, and throat? How about gastroenterology? They come to you with that. And I like that because we have a very small team. And so we don't have time to do all of that. So when they come to us and they mention the COEs, even the substance abuse, the alcohol and substance abuse, who would know that it's, with 81% male, we're seeing some, women are being impacted now. It's all the wine that we're drinking, ladies. So good for us that Karen said, you know what, we have a solution for this. Because we didn't even know what we needed just yet.
Great, thank you, Sue. Just a reminder that all three of these vendor partners, Vita, Inspira, Carum, are just around the corner here. So during break, be sure to stop by and ask questions that we may have not been able to get to because we're out of time. A big round of applause for Kelly, Amy, and Sue. Thank you so much for a great fireside chat. Thanks, everyone.
All right, I think next up is a word from one of our vendor sponsors, so Curex.
Hi, my name is George Hampton. I'm president and CEO of Curex Pharmaceuticals. 5 years ago, we founded this business for the purpose of tackling the number 1 and number 2 causes of preventable death in the United States. We now have the number 1 oral branded anti-obesity medicine in the U.S. Unfortunately for our country, we've failed to treat obesity. For the last 2 decades, obesity has been untreated and has unfortunately become now our nation's number 1 epidemic. Fortunately for our country, we now have 3 different types of medications, 3 different classes of obesity medicines, all at different price points, all that work differently. Having access to these medications is a critical part of who we are as a business. We've created and initiated programs for employers and patients to make these medications more affordable. I encourage you to speak with one of our Curex teammates to determine if we could potentially put one of these programs to work for you.
You know, I feel like I've come full circle because as Cheryl mentioned, I joined MBGH in April of 2019. If you live and breathe MBGH, that is the last month prior to our annual conference. And I came into this team and I'm all like, you know, the newbie, like, what do we do now? And they're like, okay, we're like heads down. We got a lot of work to do. But I remember Cheryl say, why don't you do the stretch break during the annual conference? And I'm like, oh, okay. Up in front of 500 people. And it was fun. And I continue to do that through a lot of our events. And I feel like I've come full circle because I'm going to lead you through a stretch break in the next couple of minutes. And we're at that time of the day where we've been sitting a lot. We need to be maybe re-energized a bit. So I encourage you, if you're joining us on the phone, to step away from your computer. If you're in the room, I got all eyes on you. You guys got to play along with me. So if everybody could stand up, maybe find a little real estate around you to be able to stretch out a little bit. We're not going to do anything crazy here, but don't want you to run into anybody. I did recruit a couple of furry friends up on the screen here to help me with some of those stretches. So follow along, do what they're doing. So we're going to start with our Well, okay, not that one. We're going to start with our feet shoulder length apart, and we're going to take a big breath in. And as you're at the top, breathe out. Pull those fingertips to the ceiling. Big, big stretch. Every vertebrae is pushing up towards the ceiling. Oh, look at you guys. You're twiggling your toes or your fingers. Nice. All right, let's do it again. Big breath in. Exhale as you press up high. Press up towards the ceiling. All right, big, big stretch. All right, looking good. Now let's take that right hand, grabbing onto our left wrist. Little bit of a side bend. So just off to the side, using that hand to pull up. Feel that added stretch. Yep, just like that. And switch it out. Looking good. All right. Now we're going to take it to field goal. So elbows, 90-degree angles. Yep, just like that. Squeezing those shoulder blades together in the back. How about a big chimpanzee smile? Do like he's doing. Show your teeth, people. There you go. Yeah, everything's better with a smile. All right, hands behind your head, chin tucks to chest. So keep those elbows nice and wide. Pressing down on your head for that added stretch. All right, looking good. Now looking up straight ahead, what do we have next? Oh yeah, we got that. So right hand to the side of your head, left hand behind your back, left shoulder presses down. Little puppy dog eyes while you're doing this, why not? And switch it out. Yeah, we look just like that, just saying. All right, now let's take it out nice and wide. We're flying like an eagle, I think. Right, Paula? We're flying.
Take a picture.
Okay, there you go. Right hand crosses over. And switch. All right, another big breath in. Arms up high. Pressing to the ceiling. Every vertebrae, everything's going up towards the ceiling. And take it back to field goal. How about some flexing those muscles? Look at that gorilla. We can do that too. Show your muscles. Yeah. All right, hands behind your back. Clasping those hands together, squeezing your elbow or squeezing your shoulder blades together. Lifting up those hands for a little added stretch. All right, here comes the massage part of it. So hands to your side. Now let's move those thumbs towards the base of your spine and just dig in. Give yourself a little massage. Maybe circle to the right, circle to the left, so up and down. Now let's find one other area right above on your spine. Move those thumbs up, little circle to the right, little circle to the left. Oh yeah, that feels good. Up and down, back and forth. All right, now we're gonna do what this guy's doing. So looking straight up in the air, looking towards the ceiling, just a little tiny back bend. Feel that stretch in your lower back. All right, looking straight ahead. These last couple are going to be a little more tricky, so they're optional, but you know, try to follow along. All right, here we go. Arms and chest to the floor, feet straight up in the air. No, we're not going to do that one. Okay, how about this? 1 foot up in the air. How about 2 feet? Yeah. Or we could just roll on the ground like a cute little panda, which is next. There you go. So, all right, thank you for joining. All right, hopefully that got us, got the juices flowing for the rest of our day today. So it is my pleasure to introduce our next presenter, and she's going to be sharing her organization's journey to putting together an evidence-based strategy for obesity management. Dr. Melanie Cheers is a senior physician executive who serves as the corporate medical director at the United States Steel Corporation. In her role, she leads the organization's health services through transformative public health challenges and has championed a workplace culture rooted in safety and caring. She has a very extensive background and a very impressive bio. I'm not going to read it all, but just so you know, the bios of all of our speakers are on our mobile app, so I do encourage you to read a little bit more about the people that you've been hearing from today. So let's give a warm welcome to Dr. Melanie Cheers. Thank you, Melanie.
All right. Hello, everyone. I hope that all of these sessions have been so informative that you are no longer tied in knots like that panda and more prepared to, know exactly how to head head forward into this ecosystem that we're in. So yeah, just a little bit, about me. I am an emergency physician by training, as has been mentioned, and I joined U.S. Steel the day before the global pandemic was declared. And so it's been a bit of a wild ride, and I have spent the last 9 years learning more about the benefits space that you all are so well steeped in, and now I am a bit more too. So I'm going to walk you through this afternoon our journey to finding an evidence-based obesity care solution for our workforce. And I wanted to tell you a little bit about our title here, which was Doing the Right Thing. So as this has sort of been the through line of my professional career, because as a young student, I often would run into my mentor's room and say, so we have this situation and these characteristics and these options, and what should we do? And the mentor would always swivel around slowly on his chair and look us in the eye and say, do the right thing. And at that point, it was a bit frustrating for me because I wanted the right answer. I wanted to know what the right solution was. But obviously, we needed to choose and see where that path would lead us. And I think that's what many of us are doing here. I believe it was Joanna that said that she was charged with doing something, right? And getting a start and figuring out where that gets you is really, the best way to gain momentum and learn. So Andrew Carnegie is one of the founding fathers of U.S. Steel. And when I moved to U.S. Steel, I was surprised to see his picture and cardboard cutout around the office with that same mantra of do the right thing. And so having spent many years with this mentor, I was very comfortable with this idea. But it was also along with this idea that JP Morgan Chase, when he founded U.S. Steel with Andrew Carnegie, also coined the phrase safety first. So it had been production first, outcome second, and then safety was further down the line. Well, they had seen many adverse outcomes from, a high industrial accident rate. And so JP Morgan said, we need to put safety first. And it's really through this lens of safety first that I came to this conversation around obesity care. So, doing the right thing doesn't mean just offering a benefit. It means offering the right benefit at the right time and in the right way. And as so many people have discussed today, we know that that this landscape is really challenging, and it's been eye-opening and it's been frustrating. And so doing the right thing isn't always very clear. But what we do know is that we have a real problem with quantifiable costs. As everybody has said, you all have seen this chart for the last several decades, right? Where now it's 70% of our populations are struggling with the diseases of obesity and overweight. And this isn't just a public health statistic. It's a very real employer issue. It's a real issue that walks through our gates with our employees every single day. And with that extra weight comes additional challenges for us. So at US Steel, obviously, we're in a safety-sensitive industrial setting. And what I found in the beginning portion of my journey in occupational health is that our employees were not able to safely use portable ladders, for example. Even an extra heavy-duty portable ladder is only rated at 275 pounds. Then I quickly realized that while they might be able to find a safety harness to work at heights that was rated for their weight, the tie-offs may not have been approved for that weight. And on the challenges went. We found that the seats and the mobile equipment that they were operating were only rated to 350 pounds, and therefore may not be safe for them to sit and operate mobile equipment. Or, for example, that when they were doing gas hazard rescue or in a confined space, that sort of thing, you can imagine that it's much easier to extricate someone that is of a lower body weight than if you have someone who's of a higher body weight. So if you need to do confined space entry and you need to safely try to get someone out of that area, it's going to take 2 or 3 people to rescue them. So more and more, we saw these problems in our workforce. And we also have talked about the downstream implications of obesity, right? So the trifecta that we've all been talking about, diabetes and cardiovascular disease, and the multiple comorbidities thereof. So obstructive sleep apnea, increased risk of heart attacks and strokes. I've got folks in my facilities that are driving production trucks that wouldn't even fit in this room. Clearly, you wouldn't want them in here as it's so beautiful, but this is a 500-ton truck. So I think your, F-350 is like a 3-ton truck. This is, fully loaded. We're at 500 tons, and the production trucks are the size of a 2-story house. We also have employees that are moving ladles of molten metal through our facilities, overhead even. And so when there's a risk of sudden incapacitation secondary to the cardiovascular disease, poorly controlled diabetes, heart attacks, strokes, those sorts of things, that impacts how we're viewing whether or not our employees are able to safely operate equipment in our facilities. So we were trying to figure out, what are we going to do with this problem? How can we ensure that our workforce is safe to do the essential functions of their job, while struggling with this rise in the disease process that's just becoming so common across our nation? But it's not just in safety-sensitive industrial settings, right? It's all of us. I don't know how many of you were getting buzzes from your watches while we've been sitting here today, but and even on a good day, standing in front of the computer, many of us are sedentary for hours and hours on end. But for employees who are up on their feet all day, they have the chronic burden of carrying that disease state around with them for every single moment. So increasing MSK, increasing joint damage, increasing degenerative conditions. And that's impacting my disability numbers, right? Similarly, if they are to have an accident at work, even if it's something really simple, like a slip, trip, and fall, that slip, trip, and fall for someone may result in an ankle sprain. But for our individuals who are struggling with the diseases of overweight and obesity, the extra mechanical stress of the weight during that fall can certainly result then in a fracture, delayed healing, and it just snowballs from there because we have more overtime to replace them and things like that, and more expensive comp claims. So this is impacting us on the comp side as well. So for those of us who are working remote, for those of us doing sedentary duty, for those of us operating mobile equipment, for those in call centers, truck drivers, this is impacting every aspect of the American labor market. And I read recently, actually, that Americans aged 17 to 24 years old, only 27% of that population is cleared now to participate in military activities because they don't have the physical capacity, the physical fitness, secondary to obesity, poor nutrition, and and a lack of activity in general. So not only is it impacting our workforce, but it's also impacting our military readiness as well. And we could go on and on and on. So for us, employers are experiencing this on all ends of the spectrum. We were seeing it in the pre-employment arena. We do pre-employment physical ability testing, and we also do post-offer pre-employment testing that's a bit different from that as well. So what we found at the time of hire is that 10% of our applicants were not capable of doing the essential functions of their job. These are folks that know that they're coming into a work environment where it's very physically intense. They're working topside on the batteries in high heat. They have to lift 50, 60, 70 pounds, and they're very physically active. So you have to imagine that there's some self-selection going into this process. And yet 10% of the population that had been hired and had an offer were not able to complete the physical demands of the job. So we're stuck eliminating 10% of our otherwise qualified candidates. And then within the existing workforce as well, even after we go through that, we have got a large union population, as I know many of you do, and we have long tenured employees with very low attrition. So their health changes over the course of their careers with US Steel, with many people that are there for 20 and 30 years. And so what we were seeing is that we were doing these OSHA required surveillance exams. And when we're completing the surveillance exams, their health status is changing. Again, we're seeing those risks that we need to do something about, that they're not able to safely use a portable ladder, that they're not able to safely tie off using a harness. And so what we ended up doing is simply applying restrictions. These were medical restrictions based off of their chronic conditions that we then were obligated to accommodate, but it didn't do anything to change the health of the employees to apply those restrictions. And we didn't really have a good place to refer them. I want to refer them to Dr. Johnson, right? Like I need that level of expertise. And at that, this was kind of at the beginning of our journey. There weren't very many, and there still aren't enough of her out here. We just need to clone you. So when we were doing these surveillance exams, we were finding risks that we couldn't ignore, and we were attempting to solve this problem by applying the restrictions. No confined space entry, no portable ladders. You can't use equipment unless it's rated for X number of pounds, that sort of thing. But what we really needed was a partner where we could restrict our employees where we could refer our employees, because the restrictions don't make them healthier, and the restrictions don't make our workforce more capable. In fact, it was making our workforce less capable as we were restricting more and more people against certain activities. So we ended up falling back to the same old standby in our medical facilities and clinics on site. You need to follow up with your PCP. We need to talk about diet, exercise, weight loss. What are you eating for breakfast? How's your nutrition? Those sorts of things. Like, you got to talk to your doc. We got to do this. And the restrictions kept that employee safe. But again, we wanted to improve the outcomes and for our workforce over the future. So then that took us to about, 5, 6, 7 years ago, and we started trialing solutions because we needed something to help us in this space. And as we trialed those solutions, I think that we learned more and more about what didn't work. We wore continuous glucose monitors. We did food diaries. We downloaded all of the apps. We took pictures of our meals. We, looked at behavior modification and the impacts there. We incentivized folks to go to the gym. We did all of those things and trialed them. And very quickly, some very concerning things sort of popped out to me. The main one is that many of the programs that were pitched to me weren't evidence-based. They were built on the same bias and stigma that's been so prevalent in our society for forever. And really, it's that same overemphasis on willpower that ignores the biology and the genetics that are so critical to these patients. And so, we saw many pitch that they were getting to the root cause of obesity, and that, simultaneously suggest that if you could be more mindful, if you could, consume less, if you could do better, that would be the winning solution for our population. We saw the diet-only solutions with the restrictive diets, and in that case, for example, one that I was trialing gave me a big green star when I had a picture of 1 pound of fried chicken wings without breading, just the way they're supposed to be done. And yet I got a red, X, or when I had tofu and stir-fried mixed vegetables over brown rice. And there's something about that just intrinsically you're saying, that doesn't add up. That's not sustainable. That's not going to work for the long term. So we were really concerned that these restrictive diets were not an option for our population either. And we didn't want to subject them to that soul-crushing yo-yo of, trying something again and then having the downstream impacts of additional failures, right? We also evaluated many of these sort of name brand diets and fads, but they lacked the clinical rigor that I was looking for. And they were focused on these short-term wins, but not sustainable habits. And so it was around that time then that GLP-1s were coming to market, and even, still a year or so before that. So we really started to try to dial in what we were going to do with this happening. So we felt very strongly that anti-obesity medications are a great tool in the physician's armamentarium, and that these were tools that were needed to address the complex disease state of obesity. So we knew that we didn't want to limit access to these life-saving meds, and we chose to cover GLP-1s with a copay and a deductible. We also were really concerned about covering GLP-1s for one disease state, but not another. We felt that there may be significant ethical and legal considerations there, on the disability discrimination side of the house. And with regards to unfair access, we had the concerns around, the legal risks. Why do we prioritize one disease state when obesity, for example, has been recognized as a complex, multifactorial disease, chronic disease for more than a decade? So, and then we were trying to address other ethical considerations as well around health equity and this biased piece. Do we not want to provide this medication only because we think that having the condition of obesity points more towards a moral failing? I didn't want to go down that route at all, because I think there's a lot of evidence to suggest that there are so many factors that are contributing to these disease states. So, so we knew that we were going to cover them. We knew that it was going to be an expensive proposition, but we knew that it was going to be life-saving. Another thing that then, as the GLP-1s came into the space, that we saw that really raised red flags for us are the vendors who said that they would do what we wanted. You want compounded drugs? Great. We'll give you compounded drugs. You want deprescribing? Awesome. We'll deprescribe for you. You want microdosing without, that seems reasonable. Why not? We can pull that off for you. And prescribing with minimal physician oversight. It's terrifying to me. For me, I think of, any of our employees that have had a heart attack or have had a stroke. They can't just get online and get their anticoagulants from some physician that hardly sees them after they just put their information into a simple little click box form. And then here you go. Here's your blood thinner. Good luck with that. See you later. And even those employees that we had that were following with physicians who are really skilled in this. We have the examples of one who, at least, and I know that there are many, who had a really strong PCP, but was also seeing an endocrinologist. And with the endocrinologist, was working through the process with the GLP-1s, had seen great success, but then ultimately had side effects, very severe side effects that landed her in the hospital and almost having to have a very significant bowel resection for an extended period of time, because even that endocrinologist wasn't as familiar with the side effects of GLP-1s as the board certified physicians in obesity medicine are. So, really red flags. Again, we didn't want the vendor to do what I wanted. I wanted the vendor to do the right thing. I wanted the vendor to leverage the evidence in the field and provide evidence-based medicine effectively to my patients. So, as plan sponsors and as the fiduciary, we have the responsibility to spend our healthcare dollars widely. And so for me, it was really important that we were also addressing this limited access to care, that we didn't want to perpetuate the stigma and the bias that's inherent in limiting access to those medications. And we also wanted to call out fragmented care, as we've seen so many people here speak to. We needed to avoid programs that sort of undermine the trust of the employees by sending them back to the strategies that they've tried and frankly failed maybe for decades and decades, over and over and over again. What we wanted to do is that we wanted to increase access to care. We wanted an evidence-based solution, and we knew that we needed specialty care. So We wanted this to be clinically led care, and we chose to leverage the American Board of Obesity Medicine certified physicians to guide the care. Again, from my perspective, and I think this has been mentioned on a couple of occasions here, as a physician myself, I actually looked it up the other day, and in the 4 years of medical training that doctors get, on average, they get 10 hours of training in obesity medicine. 10 hours for a condition that affects 70% of our population. And then even beyond that, there's that nutrition component, right? Where it's a similar number of hours that a regular doc like me would have been trained on 20 years ago, right? So you really do have to work to keep up with these things. And so that's where we need this to be evidence-based and clinically led care, so that we're leveraging board certified physicians and that we're leveraging board certified dietitians and others that are really equipped to have these conversations with our employees. Because we also know that the doctor's office, for example, is a place when some of the assault has, for lack of a better word, has sort of occurred to our populations when they have attempted to reach out for healthcare, that they've gone in and the doctor has said, have you been on the scale? Do you know that you gained 40 pounds since I saw you last year? Also, by the way, what are you eating? And you need to exercise and diet. And that doesn't create a therapeutic alliance that's so important for our members, for our employees to get better. So again, leveraging, using sort of a specialty care model, we knew that we were going to have people having the conversations with our workforce who were prepared and equipped to have those conversations in a way that would be meaningful to our employees so that they could get better and have better outcomes. So again, comprehensive model as well was something that was really important to us, because we do know that in addition to the genetic components, the mental health components, we know that many of the environments where we're working are, as with many of you, essentially food deserts, where you can go to a quick trip and get some really great cake donuts. Someone was speaking about how much they love cake donuts last night. I can't remember who it was, but I'm with you on that. But if all you get every day on your way to work is, 5 Monster Energy drinks, a couple packs of cigs, and a box of cake donuts, the behavior modification piece is rough, right? So we really do need to meet our folks where they are. So let's see where we are here. So we needed that specialty care where they could provide that comprehensive care with the wraparound care, leverage our mental health partner, and be willing to say no to all of these things that I consider to be unsafe and not based in evidence, like the deprescribing, like the compounded medications and that. And we needed a partner who was going to be there with us for the long term. We need a face that will be able to walk with us and provide this coordinated care for our members with measurable outcomes. So after doing our due diligence and moving through all these solutions and trialing all of these solutions, and then GLP-1s came into the landscape, and then your spend goes up, and then you finally decide on the right vendor and you're like, all right, here we go. We're ready to rock and roll. But then what happens if your partners aren't aligned with your choice? So essentially that's what happened to us, in that we were, in that the PBM basically just blocked us from requiring our chosen program to be used. They surfaced up this option that we could go ahead and require authorization through our vendor, but that we would face really steep penalties to the tune, with a large employer, of tens of millions of dollars. And, then they surfaced their preferred solutions, which frankly were really substandard, hastily built, and focused on pushing drugs without all of the wraparound care that we knew that we needed, that we had worked to identify a vendor that would be able to do that. And it really wasn't based on outcomes. So there were major red flags there, which then, as we continue down our journey, was just enough to light a fire such that we knew that we had to get out of this relationship. This was not what we were looking for in a partner. And so amazingly for my organization, which I wouldn't like to say that, you know, a 125-year-old org founded by Andrew Carnegie and JP Morgan is glacial, but we don't move quickly, shall we say. And so we're going with a transparent PBM. We don't want to play these games anymore. Yeah. Yeah, so basically you can find the right clinical solution and it can be really undermined by these misaligned incentives from the benefits ecosystem. And then it's just another hit, right? So you take all of these hits along the line and you're trying to dodge what's coming at you from the ecosystem. So, so we ended up now, well, we'll let you know how it goes on the transparent PBM part because that's coming up, but you know, we still were able to implement our program on a voluntary basis, and we really have seen improved employee health and satisfaction. One thing that's been really striking for us as we made that change is that right off the bat, the folks who signed up with our program were more than 3/4 of them were in the moderate to highest severity categories of obesity. You know, you could really see that there was a need, a pent-up need for a solution and a trusted partner. And so more than 3/4 fell into that moderate to highest severity category. And more than half of our patients that enrolled had BMIs greater than 35. And also more than 90% of them had another comorbid condition as well. So we were really happy to see that because we weren't sure what we were going to get. Again, we've got 15,000 employees and we've got about 38 covered lives. So it still could go any which way, but basically what we saw is that the people that really needed the care and needed the medications sought it out and got it. And also, thankfully, what we found is that our weight loss trend was higher than what you would typically see in the clinical trials or around what you would see in those clinical trials. I think someone had 15 to 22%, and at 12 months, we're seeing 16.4%. Which is really quite fantastic when you consider and you know that the real world use of GLP-1s can sometimes be on the order of 2 to 3 to 5%. And sometimes, as was mentioned earlier by Dr. Johnson, you know, that people don't respond to the medications and don't have any weight loss. So with our partner, we were able to, you know, get better metrics around these conditions. We were better than the legacy diet programs, and we were able to get more bang for our buck effectively, right? Because our employees were able to get the weight loss that was that we saw from the clinical trials that we were hoping to get from us paying for these medications. So it's really maximum efficacy out of this program. But this isn't going to be a set it and forget it sort of program. You know, we think that the evidence will change, that the medical indications are going to change. And again, that's why we leveraged an evidence-based provider, a specialty medicine provider, so that they can move with us as we see these ongoing challenges. One of the challenges, obviously, that's been brought up here in the conversation thus far is the direct-to-consumer medication access. And that can play out in a number of different ways, obviously, as we still see many compounded medications leaking into the ecosystem that our members are accessing, and then we're paying for the negative outcomes on the health plan when they are having adverse reactions or infections or you know, they themselves are paying a great deal for these medications, but they're not getting the results that they need. So a lot of monitoring is still required. I think that we have a long way to go, but our members have been really satisfied. We've had people come to us and tell the stories that they were actually on compounded medications and that they would get online from a simple visit or from their PCP, and they thought that it was just as good. And they have come to us and said, we're so grateful for you offering this solution because on the compounded medication, I wasn't losing any weight. I don't know why. I don't understand. And in that particular case, it's one of my HR benefits partners, and she has now been able, with our preferred vendor, has been able to lose that 15% and is much more satisfied with the outcome. She had a complex process where she had been diagnosed similarly to the case that was described earlier with breast cancer, and then is on medications that impact weight gain, and wasn't even being managed with regards to her GLP-1 because she was going out and getting it from a compounding site. And that's obviously has really significant risks. So it was great to bring her into the fold, to have her meet with our partner, and then to have success and the weight loss that she was hoping, and to just be generally healthier so she can be back out running and biking as she always had. So as I mentioned, folks have been really satisfied with the program thus far, and just generally we are seeing a positive impact on the safety front, where I am having to restrict people less, where we're not worried about people on the ladders and with the harnesses and in the mobile equipment seats. But we have a long way to go here too, where we need to get more data. And the proof is in the pudding for sure. But we do need to follow that health and safety impact, and then also see what the impact is going to be on the disability side, on the workers' comp side. And our vendor is working towards better data on the productivity side. But for my folks that are working up there topside on a battery, which is a high heat environment where they're basically cooking coal in a what you would think of as an old wood stove and walking over the top of it, when you're carrying an extra 100 pounds around with you, when you're in a heat index of 105 degrees or whatever the case may be, it makes it much more difficult to be productive on your job and to be safe on your job. And you're much more at risk for heat injuries and things like that. So we have had so many people come to us and that are so grateful for the fact that we are covering these life-saving medications. And we have seen so many that really have had sustained weight loss and are much better able to participate in the safety sensitive industrial work that we have. So I think that these steps are more of a sort of a challenge to you, right? As we've had these conversations today, I think that we've heard time and again that it's really important that we recognize obesity for what it is, as a chronic medical condition that's upstream of our biggest cost drivers with diabetes and heart disease and cancer. And if we address it as anything else, we're doing a disservice to our population. So I also would encourage you not to accept the quick fixes, just reject the quick fixes and the good enough solutions. We really need to go back and make sure that we are getting evidence-based medical care for our employees. And we need to challenge the misaligned systems that are blocking optimal care, whether that means going back and talking to your PPM or switching to someone who's going to work with you. So, it's a challenge to work in these entrenched systems and to have them block us when we feel that we're doing the right thing. But at the end of the day, doing the right thing means saving lives. It means improving the safety of our workforce, and it means protecting our plan's sustainability. So we've got lots of work to do in this space, and I'm happy to talk to you about my journey more after this session. Or there may be questions.
Oh, yes. All right. Thank you so much, Dr. Cheers. I have a question and first of all, kudos to you for not hitting the easy button and just sticking with your PBM, but getting a little uncomfortable and making that switch to a transparent PBM. I don't think we shared all of the pulse of the purchaser survey results this morning, but there is one data point that I did remember seeing. When we asked our employers how many have switched to a transparent PBM over the past year, 21% they said they had. 47% of employers are considering it in the next 1 to 3 years. So there's a wave of this going on. But I'm curious to hear from you if you have any words of wisdom for employers who are looking to make that switch. We know that contract optimization is super important, that you get those words in that contract from the get-go. Anything you would recommend?
Yeah, I mean, it's been a really interesting process, and I am being totally forthcoming when I'm saying that it was this conversation around the obesity medicine solution that pushed us over the edge. We were dissatisfied with the way that those conversations went. And so we were able to leverage our current provider in the obesity medicine space to also make sure that we had proper language in there. But the PBMs, the transparent PBMs were really great about coming to us and saying, these are the things that you want to look for when you are contracting, and actually just kind of collecting all of the suggestions that they brought to us for the contracting language and making sure that it was in there. Many of the folks that have made the transition recently, and some of the employer groups that I've been with, have also changed their consultants. And that is another strategy that has been helpful as well. So like I said, we are just going down this path, but I am very hopeful to see this wave of change, because I think it is certainly taking us in a better direction than where we've been in the past.
Awesome. I think Paula has a question online.
Thanks, Dr. Cheers. So two questions online. One was specific to the restrictions you talked about. Somebody asked if those were OSHA restrictions or your safety team had put those in place.
Yeah, so we would see the patients because of OSHA required surveillance exams. And then when we would identify that they were participating in activities that we didn't think that they could safely do, like using a portable ladder, if they were over that it would be over 250 pounds, because they have a 25, 8 pounds for your boots and your PPE, 25 pounds for your tool belt, that sort of thing. And we would have to work backwards from there. Then was our on-site medical team that would apply the restrictions. And again, with obesity being a chronic medical condition, these individuals are protected by the ADA as individuals with disabilities. So we would basically be applying with our incumbent employees, we would be applying medical restrictions. With our pre-employment hires, we had the opportunity to apply safety restrictions. And the safety restrictions were sort of separate and didn't need the same review for accommodation.
Thank you. The other question online is, do you cover maintenance doses after your members reach goal weight?
We do. We align with what's recommended by the physicians. And that's really our guidepost. I think that they know best what is best for our employees. And so we will cover what they prescribe.
Awesome. Any questions from here in the audience?
I'm standing between you and a break, so
I think you are. So let's give a round of applause to Dr. Cheers. Thank you. All right, we have a word from another one of our sponsors, Karam Health.
My experience with Karam Health, in a word, would be unbelievable.
Phenomenal, compassionate.
Couldn't believe it.
Excellence. This is amazing.
Nothing out of my pocket was too good to be true, but it's 100% true.
You have a dedicated person. They are with you every step of the way, and she was absolutely fantastic. Everything was covered, every detail.
Seamless procedure, fantastic. Nothing could have gone any smoother. I can't say enough.
Karam, they said what they were going to do, and they followed through 100%.
The process was super easy. There's no out-of-pocket costs, and they reimbursed me for mileage. So I was very happy with the overall experience.
It was way better than dealing with my own insurance company. It was a lot easier. It went a lot smoother. I knew what to expect every step of the way.
I had the choice to fly, use my own car, or use a rent-a-car.
Karen was taking care of the surgery. They're taking care of my travel, my lodging, and paying for everything. And nobody believed me. I said, just go onto the website.
2 knee surgeries later, and we had not a bill. I'm still not believing it. I think is like
You think the bills are coming?
somebody's gonna be like slipping something under our door.
If you haven't filled out or your exhibit or your prize drawing card, do it super quickly because they're going to tear down now. But you should also stay in here for this. Okay. I love when we have clinical panels because their expertise is unique and oftentimes they sit on the fence between patient advocacy, taking care of patients, working with other stakeholders, and that includes employers. So that's what this panel is today, and who better than to moderate it than our corporate medical director, Dr. Jan Berger, who is, she's been with us since 2015, but we've known each other way longer. She can tell you a little bit about her background if she wants. Jan helps keep our team up to date on clinical best practices and issues in the industry because she knows where the skeletons are. She writes position papers for us, is a contributing author on timely and relevant healthcare topics that we utilize. She is a veteran healthcare executive. Does that mean you and I are old? Is that what veteran means? Okay. Shares her expertise through her consulting agency, Health Intelligence Partners, as well as through participation on multiple advisory boards. We adore her. She's brilliant. Please welcome Dr. Jan Berger. But before we do that, we have a word from one of our sponsors, Novo Nordisk.
Some things can be solved alone, but some can't. Some obstacles can be solved alone, others can't. Some tasks can be solved alone, while some can't. Some challenges can be solved alone. Obesity cannot. It will take collaboration to take on this challenge and change the future of obesity.
Unique commercial. I liked it a lot. Oh, now I can, again, Jan, come on up.
Thank you, Cheryl. What an appropriate lead-in commercial for this conversation. For those of you who have been to past meetings, most of you know me, and often I am the only clinician in the room. So I hold a kind of unique position and speak in a language that half the time people don't understand. Today, I am really honored to say I am the least clinician of my clinician panel up here. I will introduce them in just a moment, but I also want to say Cheryl and I had a conversation earlier today that with all these amazing conversations and talks and information sharing, we didn't have a patient in the room, although many of us are patients, but we didn't have a patient speaker. Should I hand this over? Thank you, Paula. So instead of taking the clinician role today, I'm taking the patient role. And I'm taking the patient role because if we had had this conversation 2 years ago, I would have said, I'm not a patient. I'm a really healthy middle-aged woman. By the way, middle-aged is 10 years older than I am at any given moment, if you're wondering my age. And my world changed 2 years ago. And I've talked about it on stage before, but I got diagnosed with a genetic heart disease, with prediabetes because of it. And I am not obese, but I am considered by the numbers overweight. So I have the trifecta. I went from 0 medications 2 years ago to 8 medications today. So I am the poster child for some of the conversation we're going to have as clinicians today. And I think it's important to have a profile of what your employees and beneficiaries are going through as you do your plan design. So that's why I come out and use me as an example. But now I want to introduce our clinicians. First, we have Dr. David Dungan, I still did it wrong, sorry. David is a primary care physician at Dooley Health and Care. He's board certified in internal medicine, pediatrics, and wait to hear for this, guys, culinary medicine. Way cool. He was one of the founders of DuPage Medical Group, now Dooley, and he focuses on leading wellness and food as medicine initiatives to enable the whole person health for patients. David, can you tell me what the trifecta of a perfect fall day is for you?
Sitting in a chair, looking at the steam rising off a pond, enjoying a polyphenol-rich coffee, going for a hike, and then biting a crisp apple in the afternoon with the juice kind of running down your chin.
I love it. That's great. Next, we have Dr. Catherine Saunders. And it's interesting, she and I have now realized we know all kinds of same people, even though we have never met before today. She's a physician innovator and an internationally recognized expert in obesity medicine. She co-founded Flight Health, a software and clinical services company that provides evidence-based, cost-effective medical obesity treatment to health systems and employers throughout the U.S. She co-hosts the Weight Matters podcast and publishes extensively on obesity medicine. Can you share with us your trifecta of the fall?
Sure. I don't know if I can compete with that amazing, beautiful answer. But I would say, you know, the trifecta for me would be, I love what I do. So spending time working. I love my kids and don't get to spend enough time with them. So spending time with my kids. And then I would say having like 5 minutes to myself. Would love to take a hike in that time for myself. We live in Connecticut and the leaves are starting to turn. So it's really, really beautiful. So enjoying the leaves in Connecticut, working and being with kids would be ideal for me.
Wonderful. And our third speaker is Jennifer Guy, who is a PharmD with 17 years of clinical and operational experience in the hospital system, including nephrology and oncology care. Since joining Trestle Tree, she focuses on helping participants optimize their medication use and achieve better health outcomes through a personalized, holistic model of care. What is your trifecta for fall, Jennifer?
Fall is the best in the Midwest, and I look forward to it every year. And we have a screened-in porch at our house, and it's my favorite place to sit in the fall to watch the Oregon Ducks play football, and definitely drinking coffee, watching the Ducks play with my family is a top priority for me in the fall.
Well, I must say they all had very healthy thoughts. I'm still thinking about cinnamon and apple cider donuts. So as we're talking about obesity, you know, occasionally having something different is good. And then for someone like Cheryl and myself, it's reduced temperatures outside. So the humidity and the heat of the summer of Chicago being reduced in the fall is always a great thing. So with that, I'm going to get us started in having a conversation. So I want to start, hold on, is this on? Hello? Now it's on. I want to start out because we do have 3 really great thought leaders as clinicians up here. And I want to ask, why are each of you passionate about this topic? You're not new to the topic. You were leaders before we were having these conversations. What's your passion on this? Well, we'll start here.
I'm passionate about this topic because, as Jan mentioned, I came from working in the health system for 17 years, and 10 of those years I spent working with solid organ transplant patients. And so I feel like I've had first-hand, upfront, close experience with patients dealing with the kind of the end of the road with obesity, diabetes, and cardiovascular disease, to the point where they needed an organ transplant. And then the defeat in them, knowing that that didn't cure them to get the transplant, it just traded in one set of health conditions for a new one. And after many years of doing that, and then eventually transitioning to the oncology space, I just knew that I had to go upstream and to help people prevent these illnesses. I felt I got to a point where I just could no longer, honestly, in day-to-day got really hard to take care of patients. I felt hopeless. And so I really wanted to completely change what I did. And I joined Trestle Tree. And for the first time, I feel like I can focus on holistic care and fix some of the problems before, or help people fix problems before they ever develop diabetes, before they ever have kidney failure. And so that is honestly why I'm so passionate. So great.
But, so I actually went to medical school thinking I was going to be a reproductive endocrinologist and help women get pregnant. But when my mentor, Dr. Lou Aroni, gave a talk to my med school class in my third year of medical school, it just changed the course of my career completely. He was one of, the founders of this field starting in the 80s, recognizing that there was more to obesity than just being a lifestyle problem. And so he gave us a talk, our first talk about obesity at all, my third year, about how obesity was a disease and how he had devoted his career to developing effective treatment protocols. And from that day, I started working with him. I became the first fellow to specialize in obesity medicine at Weill Cornell, and one of the first fellows in the whole country. At the time, people were like, what are you doing? Like, why do you want to be a diet doctor? What's obesity? Why do you want to work with this guy who's doing all this weird stuff? And now fast forward, you've seen his name on all the slides earlier today. He's run over 65 randomized controlled trials of all the obesity meds, and he's finally like, I told you so, I told you so. So it's been an amazing transformation. But I honestly think that the field of obesity medicine, there is no more exciting field in medicine today. It's the fastest growing field in terms of number of providers who are becoming certified in obesity and practicing. We have so many patients who need help. We're barely scratching the surface. The medication pipeline is incredibly exciting. There's just, it's hard to keep up. There's so much going on every day. And then finally, I think there's no better way to transform healthcare these days. GLP-1s have been such an incredible breakthrough, but beyond GLP-1s, it's not just about GLP-1s. Treating obesity is just such a rewarding, incredible way to save people's lives and transform people's lives. And so I've, after treating thousands and thousands of patients with obesity in my career, it still excites me so much. I love every patient I work with, and I find it so incredibly rewarding.
Great. David?
Well, as a veteran primary care physician, I should say, I like the word seasoned better, would be a little bit better for us. I think that works a little bit better. Been around the block a few decades, 33 years to be exact. And so over those 33 years, and you probably saw slides earlier today about what's happened to our population over the last 33 years, as we've continued to gain weight, become more unhealthy, become less fit. And so I'm kind of a back to basics guy. I really believe that the lifestyle component that's the foundation for any treatment of any of these conditions we've talked with. And it's the cornerstone that patients still have to do. The medications are great, the treatments are great, the surgeries are great, but if they don't fix the basics and what they need to do, it's not going to work. It's not going to be sustainable. So, and I've seen this over the 33 years for patients that make those changes and make it stick. It's dramatic for them. And so I'm really passionate about helping patients drive to that sustainable change to help all these other efforts be successful.
That's great. Can you share with me, your conversations just now were focused a lot on obesity, because that's where the change and that's kind of the catalyst to many of these others. But how many people are you seeing that have the trifecta? And, is that a large portion? Is that a smaller portion? We heard one of the speakers earlier talk about 51% of people have chronic conditions. And we know that that leads to employer cost increases, provider workload at a time where we have provider shortages, and employee patient implications. So how many do have the trifecta that, that you're seeing and dealing with on a daily basis? David, let's start at your side this time.
Well, in primary care, we're the front entry, right? We're in the trenches. Patients are walking in to see me first before they'll ever see any of the other colleagues here in terms of that. And so I would say at least half, probably 2/3 to 3/4 of my patients that walk in the door at this current time. If you would ask me this question 30 years ago, I would have said maybe 30, 40%. So it's significantly higher. That's a big strain on all of you for your productivity, your workforce, your employee well-being. And so it's really important for us to recognize this early in the primary care space. Not only that, okay, yes, you got this problem, do this, blah, blah. No, it's like, how does this affect you? Does this impact your work? Does this impact your life? What happens with in your family situation? Because there's always more to the story. And so one of the things that we need to tease out in a holistic, integrated way as an organization is to help patients find that, so then we can get them on that right path.
So I have a very medically complex patient panel because I've been doing this for a long time. So we try to triage our, more simple patient cases to less seasoned providers. So exactly. So we have very complex patients. But I think it's really important to point out that, it's this trifecta, it's not just, do you have established disease? It's really a continuum. So I would say, if you think about the fact that obesity is associated with over 200 weight-related health complications, all of our patients have at least 1, 2, 3, sometimes 10 to 20, diagnosed conditions that are weight-related. In terms of diabetes and cardiovascular disease specifically, I would say 100% of my patients, if they don't have diabetes, they have prediabetes or they have some evidence of insulin resistance that eventually is going to progress. And then same with cardiovascular disease. If they don't have established cardiovascular disease already, they are at very high risk, or maybe they do have it and they haven't been diagnosed. And so, it's just incredible to be able to kind of treat someone's obesity and improve all of that, diabetes, cardiovascular disease, and all of the other health implications that come along with it.
And I would say participants typically don't come into health coaching and they usually have obesity or overweight. And I would say a large majority have at least one comorbidity. They might not have all three, but typically when I get involved to do consulting with those participants, often they will have at least one comorbid disease state, or potentially ones they aren't aware, but they do have the presence of insulin resistance. So
what is as clinicians, knowing that people have, whether it's the full trifecta or the road to the trifecta, what is the greatest challenges and opportunities for these patients? What would you say? Start? Oh.
I'll jump in. They're overwhelmed and confused. The information that is out there in terms of this diet, no, this marker, no, this marker, no, this med, no, this workout, no, do this workout. They're really, really confused. And so I think the challenge for that we have to do together is to make it simple for them. Because patients are already a very busy life. They're already very overwhelmed in a lot of different ways. So if you can provide them ways that they can make simple changes in their health, simple changes you can make at the workplace to promote that health, simple changes that we can do when we're giving them a treatment plan or recommendation, or if we're helping to coordinate that care within our integrated system, to help give them the simple steps to follow that really makes a big difference for them. But that's, I would say, one of our big challenges for patients. It's just confusing and they're overwhelmed.
I love that answer, and I'll build on that. I think that, you know, the misinformation or the lack of information about, you know, health and disease is just a huge, huge problem for patients receiving care. You know, my typical patient, by the time they come to see somebody like me, has lost and gained weight 1,000,000 times, has tried everything, and so they come in hopeless, completely hopeless, blaming their willpower and not really understanding what's going on. And so I find it so rewarding to do a really comprehensive initial evaluation where we look at every single factor that's pushing their weight up and every single barrier that has made it hard for them to lose weight. And so I spend a lot of time listening to them, asking them 1,000,000,000 questions, looking at 1,000,000,000 labs, and then educating them on, this is not your fault. This is actually a disease, and it's really hard to treat this disease. And everything else you've tried, you know, don't be discouraged, don't give up, you know, because that hasn't worked doesn't mean that it's not going to work going forward. And so, you know, a combination of education and giving patients hope is so incredibly powerful. And just dispelling all the myths and simplifying it and just making it really understandable, but then also delivering on it, you know, saying this time will be different. You know, we have an incredible track record of really improving patients' overall health and keeping those health improvements long-term. And so I think the opportunity is really to transform people's lives and, you know, get them off other medications for their, you know, weight-related comorbidities, to help them finally achieve their weight and health goals and, you know, sustain that long term. But in terms of the barriers, I mean, we could talk about this for hours and hours and hours. I would say the number one barrier, and I don't know if it's come up today, is 100%, you know, weight bias, stigma, discrimination. I mean, that is a huge issue that needs to be talked about more. But the other barriers are cost, coverage, you know, lack of information, you know, lack of providers who know how to do this well. So it goes on and on. We have a lot of work to do, but there's tremendous, tremendous upside.
One of the biggest challenges that I feel like patients face is in a world where you see numerous physicians, you know, you have your primary care physicians and your specialists and potentially, you know, other outside physicians that you're going to, and even the internet and information. People feel very siloed. They feel like one provider isn't talking to another provider. My cardiologist is telling me this, but does my primary care doctor know about it? And there's just so many things to communicate. They're so overwhelmed. And again, they're completely siloed. And as a pharmacist, you know, pharmacists aren't out in the community really accessible anymore like they used to be, like when I, you know, first went to pharmacy school. And so I feel like the opportunity that I've had is to bridge that gap again. And help participants understand, okay, these are your physician directives from your primary care provider. These are your goals. These are your specialists are saying this, and trying to connect those dots of this is why they prescribe this medicine. This is how to take it, that, you know, just some of the basic things a pharmacist would educate on. But even deeper than that, our health coaches are able to dive in with them on those lifestyle changes to say, like, how do I even begin? How do I even start an exercise regimen? You know, how do I even start eating healthy? How do I identify these barriers? How do I break through those? Like, can you help me? So I think people feel so heard when you can connect all of those dots and you have someone to go to frequently. Because that's another thing. You have maybe one touch point with your primary care doctor when you're sick or once a year, and then you have your specialist visits. But who are you talking to every month or every other week? Someone to check in with, and honestly, for people to pause and say, I need like 15 minutes or 30 minutes to focus on me, take a break from my job and my stressful life and all the things I have going on, and to revisit, okay, how did I do on my food this last couple of weeks? How am I doing at my strength training? How am I doing at these like little basic things? You need those frequent touch points with people. And so I think that's been just such a fun and exciting way for participants to feel like someone is connecting all those dots. So
It's interesting.
I was going to jump in. I think that's a really great segue to what we need to talk about in terms of having integrated care in terms of that, because of the siloed opportunities with that. So as employers, as you're trying to find, how am I going to help my employees find the best health, and then we have their best productivity, and then we have our least costs, is to try and seek out solutions that provide integrated care opportunities with that, whether it's a single physician organization, whether it's a different provider, whether it's some plug and play opportunities that are available and that you've heard about today. But somebody has to be providing those touch points, coordinating that care for that patient. We like to think that our primary care doctors are the trusted advisor for the patient. And so being able to be that person that they can go to working with the partners for support and to guide them to the right specialist at the right time, so that we're doing not too much and not too little, I think super important.
And it's interesting that you bring that up, because David, I was going to say that. To give you an interesting example, I went back and looked I got advice on what foods I should be eating for each of my conditions right now. And I went through, and once I crossed out, no joke, if this one says I can have this and this one says I shouldn't have this, 75% of what was on the list got crossed out by one of the three. There was no consistency. So I'm like, well, I can have water. This is really good. And I'll agree I should have lots of water. But that was like the only agreement. When you talk about the multiple providers, and then some of these wonderful point solutions to help, because not everybody is as lucky as you, David, working in a system. That's the system I worked in, because I worked in a staff model HMO. That's very rare. And nobody has the time or the ability to be a quarterback. So when you get these conflicts, how do you see each of the three of you? You talked a little bit, David, but I would ask I want to hear my two other clinicians, but even in your world, are you as the primary care doc talking to the specialists as well when they're seeing 3 or 4 people? Because I can tell you, I have my new care team here. I'm quitting everybody, and this is going to be my new care team. Now I just have to tell Blue Cross Blue Shield that in Medicare. But how do you all handle when patients come to you and say, I'm getting conflicting messages all over the place? Because it does happen. I'm living it. And it causes depression, which makes things even worse. Not just confusion, but depression. So I'm going to start in the middle of this time. So when you're hearing somebody say, you're giving me very conflicting messages, or I'm hearing different things from different people, how do you handle that?
Yeah, well, it's when it related to obesity specifically, people come in with all these preconceived notions and so many different myths. So, when people say, oh, you're talking about this in a different way that I've never heard before, but my understanding was that this is the best, this is the best, this is the best. And so, educating about kind of why we're making those recommendations, and educating about the science and, the principles of treatment, and pointing out, if you've tried all these other things to lose weight and nothing has worked sustainably, let's try something where we have the evidence, we have the experience, and see if this works. In terms of coordinating care, though, we don't do primary care. We are very specialized in obesity, but all of the obesity-related comorbidities, which is basically, everything. I don't do vaccines. I don't do, all the healthcare maintenance. So we make sure that every single one of our patients has a primary care doctor. And if they don't, when they come to see us, we make sure that they establish with a primary care doctor. That's a requirement to work with us. And then we do a lot of communication. It's absolutely time consuming, but everything when it comes to obesity is time consuming. I mean, you can't just, see a patient, prescribe a medication, and call it a day. So we provide extremely comprehensive, thorough care where we are communicating with patients' other specialists. To be honest, though, once you successfully treat someone's obesity, other things get so much better. So it's easy, but there's a lot to think about because when you treat someone's obesity, blood pressure decreases, any weight-based medication needs to be adjusted. And if someone is losing weight and seeing a specialist or not seeing a specialist and, not keeping track of that, there can be really dangerous outcomes. I mean, treating obesity isn't just prescribe a med and call it a day. And so we keep very close track of that. We're monitoring people's blood pressures remotely. We're speaking with their primary care doctors to monitor, weight-based medications. We do a lot of labs, but we share all those with the other providers. So it is a fair amount of care coordination that is absolutely extremely time consuming, but absolutely essential for safety and for just good, high quality care.
I would say that, I mean, in the pharmacist role, it's a little bit difficult because you're kind of serving as the person to try to go sometimes between providers to help them communicate, which in the hospital setting, it was a lot easier to do. It's a lot more difficult in the outpatient setting. So a lot of times we will recommend that participants always defer back to their primary care doctor as kind of that sounding board. Because if they do get mixed messages, they need their primary care doctor to help them, navigate that. And I feel like that tends to be the safest option. Unless I would say a caveat would be if they went through like an acute event, and then often that specialist kind of becomes like they're higher up on the totem pole. Like if you just had an MI or a heart attack, or you just had a stroke, most likely your cardiologist or your neurologist, like they're kind of trumping all the recommendations at that moment when they're talking about how long you're going to be on Plavix or like your CT surgeon, if you just had open heart surgery, they are the most important provider to you at that moment in time. But working with the primary care doctor as well to know when do we kind of transition back to, okay, when I need to bridge that gap between those providers. But it is a very difficult thing. I don't know that I have an answer other than talking about communication is key, and just trying your best to, it is time consuming, but communication is the only way really.
So David, we in Chicago had a quarterback who had 4 touchdowns. So I have to use a football analogy.
Did you have your hot dog today then?
It's not on that list of foods I can eat, but yes, my brother and my nephew did go get their hot dogs. Kind of fun.
For those of you who don't know, there was a hot dog stand here in Chicago that promised free hot dogs if the Bears quarterback had 4 touchdowns or more. And he did, so.
Thinking it would never happen. So the quarterback analogy I have to use because we actually had a win. How do you feel and what do you do to be the quarterback for these patients?
So I think one of the challenges, and I mean, we could have a whole conference on a weekend about what's happening in primary care and how primary care has changed in terms of that. And so I have the benefit of training in days where it was pounded into me in residency. And when I started practice, you are responsible for that patient and nobody else. So you better know everything about that patient, take care of everything about that patient that has to be done with that. And so I've carried that mantra for my career. I've tried to help my new physicians that join with us to understand that and to take that ownership, because you found out firsthand, right, how siloed everything's are. And it's really a tragedy that we've gone away from that. And in the patient's desire to have the best expert for each of their things, then they've lost sight of who's really taking care of them, who's taking care of their soul, who's taking care of their heart, who's taking, I mean, like their emotional heart is what I mean, who's taking care of their body in terms of their well-being. And I think it's really important that we maintain a holistic approach to that, for that, whether it's coming from an employer side in terms of what patients need to work to be their best, or whether it's what they need to have their best in healthcare. And I think that's really important for us as a quarterback role. Your comments about how patients come in completely confused. There's a 4-word phrase that I dread is I've done my research. And that's a challenge in today's information age. And now patients are coming in with Chat GPT printouts of what their diagnosis is and what tests they want me to order and how I would need to confirm it and what prescription I should be sending in for them. So it's really getting challenging for us as clinicians to navigate that and to help the patient understand and navigate that, no, they really need a human and they need somebody to hold their hand at times, and they need somebody to give them a little kick sometimes in terms of trying to make sure that they get their best health.
It is interesting, for those of you who are at the annual meeting, Lynn, one of the keynote speakers who used to work at Edelman, talked about the fact that 72% of people think that they can do a better job than their providers, due to the democratization of healthcare. Very frightening, and especially in patients who have multiple comorbidities and the challenge with that. Can I ask if the three of you are using remote monitoring of any sort and/or CGMs, and how you're utilizing them? And do you find them valuable or not?
Yeah, we use remote monitoring devices such as, scales and glucometers and blood pressure cuffs, but we're also starting to use over-the-counter CGMs to help with lifestyle changes. And we're getting ready to launch a pilot where we, potentially have participants use it for a couple weeks, see if it, they can work with their coach. Like, what did you notice and observe during this time? And again, they might not have pre-diabetes even, but what we're hoping is that what if they discover they do have pre-diabetes and don't even realize it, but more so just to bring awareness to, hey, what is happening when I'm stressed out? What happens to my blood sugar on the days that I exercise? And it's super, I've used one personally. Yeah, it's very powerful to see like what you ate that day and why did my blood sugar spike at 1 a.m, or why was it low when I woke up? So it's really interesting. There's a learning curve to it, I think, because we're not used to seeing our blood sugars like that all the time, unless you're a type 1 diabetic or if you're type 2 diabetic and you have a CGM all the time. But so we're definitely starting to do that with over-the-counter ones.
So data for us is absolutely critical and guides our management. So we, through our employer programs, everybody gets a scale and a blood pressure cuff. We require for some of our programs, and strongly suggest for others, that patients weigh themselves at least once a week. Because if I don't know what happens between visits and I just have a starting weight and a current weight, I have no idea if they're still losing weight or if they've lost and then they're sitting at a plateau. And so I need that information so I know, if I don't need to make any changes, and I can say, great, keep doing what you're doing. Or if they've been sitting at a plateau and they haven't yet achieved their health outcomes, then I need to know how long they've been at a plateau, what that looks like, or if they lost more and regained. So that weight trajectory is absolutely critical to guide our management. And then, as I discussed before, with blood pressure, we don't need blood pressure measurements from all patients. But for patients who have hypertension, especially those patients who are on, 1, 2, 3, I saw a patient this morning who was on, 4 blood pressure medications. And between visits, he was like a super responder to a medication I put him on, and he lost like 30 pounds in, 3 months. And so I did talk to him once or twice between, during those 3 months to make sure everything was okay. But, for somebody like him, if he's not checking his blood pressure, it can be very dangerous because he could have hypotension, he could have orthostatic hypotension. And so we need those readings in people who are losing weight. I don't, and some of the medications we use can increase blood pressure a little bit. And so it's important for us to, have a baseline blood pressure and heart rate. And then once we start a medication like that or increase the dose, we need to know that somebody is safe. We don't use CGMs, in a serious way. I think, just in terms of, the evidence base, we don't have, randomized control trials looking at, CGMs and the outcomes in terms of, weight and weight outcomes long term. I think they're a nice to have. I think it's very interesting, and I think they can absolutely change behavior, but I don't think that every single person needs a CGM. And I think that, of course, our patients with diabetes, our patients who want to do that, great. But it's not something that we use for every single patient. I just think we have so many other tools that can change people's behavior without needing to spend more money on a CGM. But I think it's, they're exciting opportunities for, when the cost makes sense. And, if we get to that point with people.
Yeah, I would say some of the wearables and remote monitoring, had a lot of ballyhoo promise 10, 15 years ago, and it hasn't really materialized like we would like to have seen, especially in terms of their ability to integrate into our information systems. For us at the point of care, I think they're good in the home setting to give that information back to patients in terms of blood pressure, glucose trends, things like that. I like to use the CGM, especially in the over-the-counter ones, in the setting where the patient's at risk. So they're that pre-diabetic or that type of thing. And they're like, no, doc, I'm exercising 5 days a week and I eat great. And I say, well, maybe let's get a CGM, get one of those ones over the counter and put that on and let's see what happens. And then they'll come back and like, you're not going to believe this. I thought this was going to be good for me and look what it did to my sugar. And so that information is powerful. And I think it's not something they need long-term, but it can be really helpful for them in a short-term manner from that perspective. I think in terms of your comment about that evidence base, I think we really need to see that wider trial in terms of where they are more utilized in that aspect. But if the cost gets better, then that's going to be better for patients to utilize. I think being able to personalize their medicine or personalize their care is one way to help with that. Because I'm curious, how often have you seen patients respond differently to the same treatment plan, right?
Oh my gosh.
All the time, right? So they're so individually different.
I love that question, especially with obesity and other conditions too. I mean, obesity is such a heterogeneous disease. So different people respond completely differently to different interventions. And so, as much as we want to scale and see as many people as quickly as we can, it's hard. It's really hard. And, because this kind of medicine needs to be so personalized, figuring out what works for different people. Yeah.
And it is interesting when you talk about that. So as I said, I wear a CGM 2 weeks out of a quarter to keep me honest. But interestingly, if I were to say to the three of you, are blueberries a healthy food? You'd all say, yes. Interestingly, it spikes my blood sugar to over 160. So there are little things that maybe you can find out about this. I want to translate just for a moment to our employers in the room, because I think you've heard some really, really important factors. And I'm going to come back in a minute and ask the magic wand question to each of my peers here. But in translating, there's a couple of things that we've heard. Number one is the importance of a primary care doc. Okay? And I would even argue in some ways a primary care pharmacist. But I do think we are in an era right now where primary care is a real challenge. And so as you all are doing your plan designs and you are looking at your health plans, having a serious conversation about primary care in today's world becomes really important. God bless you. And I think it's a question that should be asked regularly. And then trust but verify. Because if somebody can't get a primary care doc, or my primary care doc is retiring in 2 months, do you know I cannot find a primary care doc? And if I can't find a primary care doc, what happens to people who are in the general population? So I think that's number one. Number two, we've talked about support programs. Lots of focus being spent on the medications for obesity. But as you can hear, it's not as simple as giving people a drug and telling them to have a nice day. It's just not. And so having the support systems, many insurance companies will not give patients coverage for nutrition management unless they have type 1 diabetes or are insulin dependent diabetics. I would highly suggest it is just as important that you all look at those kind of support systems as covered benefits. Because otherwise, the truth of the matter is, no matter who the pharmaceutical manufacturer is who has a good or a great drug, it has the risk of not being as effective with all the other things that you all talked about. So that is a translation. Before I pass the magic wand to each of you to tell people in the room what is an offering or a plan design that if you had a wish of all the employers in the room to do, I want to put that out there because it's really important for each of y'all as you are struggling with figuring out the new vision of obesity and the trifecta, because it's very different from the old era of just stop eating, stop having the hot fudge sundae. That's not, and I loved the comment earlier that overeating is not the cause of obesity. I loved that. So I'm going to ask David, starting with you. You get the magic wand to start. What's the one thing you'd like the employers in the room to consider as part of an offering or a plan design out there?
So my magic wand world is that employers and us clinicians work directly together, bypassing the intermediaries that add cost, aggravation, headaches, red tape, and for your patients, our patients, your employees, and each other, and prevent us from really having constructive, innovative, unique solutions. That's my magic wand. Now, obviously, that's not going to happen overnight, but there are many opportunities where you can start having those conversations with clinicians to think about small areas where you might be able to start a collaboration with, or do a little test group with that, and provide that opportunity focused on that lifestyle approach, focused on that healthy nutrition approach that you highlighted very well, because that's really the cornerstone to any of the chronic conditions that you're trying to manage in the sick care model. And so really thinking about how can I help my employees move from a sick care mindset to a well care mindset, to be happier, productive, and have healthier families too.
I love that. So more specifically in sort of obesity and cardiometabolic care, I think it's really hard for employers to, make the best decisions because this is all really, really, really complex and it's also changing really, really quickly. So I would say, oh God, I could talk about this for hours. I'll try to boil it down to 2 or 3 things. But I would say, figuring out solutions that are not just one size fits all and not just like myopically focused on GLP-1s. I feel like we're seeing so much of that. As you've heard, obesity is such a heterogeneous disease and, we need all the tools in our toolbox to be able to help patients. They need so much education and support. So all of that is so important. GLP-1 medications are wonderful, but they're not my first line medication for the majority of people I see. We have so much expertise and, our business model to make sure that everything's cost effective is to try 1, 2, 3, 4 medications before getting to a GLP-1 because we have so much success helping people lose weight without GLP-1s. And so, having a stepwise approach, having, a really comprehensive model that personalizes, and then, I'll throw in there, safety. A lot of what's happening right now, there are health risks associated. Medications for obesity and cardiometabolic care are really powerful medications. And so if they're being prescribed like candy without, labs, without a thorough evaluation, without, significant education and support, like there are real health risks. And then it's the employer who's paying for the health complications. So the last thing I'll throw in there is just, compounding. I spent a lot of time last month. I did a congressional briefing on Capitol Hill with, a few of the experts in the compounding space on just, how this all works, what are the safety risks, there are serious health risks associated with compounded medications. And, I would never let a patient I see take a compounded medication. We see many people present to us on them, and we switch them over to very well-studied, FDA-approved medications. So if you are thinking about, using compounded medications, I would really think twice because, one, there are serious legal ramifications, and there are, two very serious health risks associated. And again, you're on the hook when your patient has a bad outcome from a compounded med.
I think David hit the nail on the head earlier when he said that we need to get back to the basics. And I think if there's one thing I've learned from my years in the health system is that we have to offer and focus on lifestyle changes. And as Catherine mentioned, you can take medications. It doesn't help if someone isn't actually administering them, if they can't tolerate them. And as a pharmacist, I see this all the time, and the struggle with the medications themselves. And when someone hasn't actually changed how they're eating or exercise, moving their body. And I think, I know this doesn't have to deal with the employer side, but from the medical side, I think like there has to be a huge focus on nutrition. Like we have to change. And if I could go back 30 years and what our society has learned about food and our highly processed food and what we're eating and our children, what they're eating. And I could talk for hours about this subject. But I think like med schools have got to start incorporating nutrition in teaching med students in pharmacy schools. And we really have to educate healthcare providers, because we are not educated on that when we come out of school. We are learning this, with the general public and trying to do extra things to get caught up, versus dietitians obviously have intense training in this. But I think it goes back to those basics, and those lifestyle modifications have got to be a focus. Those are a prescription, and they have to be written as such, even potentially prior to going on medications. So.
And Jen, I got to just throw in that little tidbit. So there's a fun fact that really nice study done about maybe 5 years ago that showed if patients with prediabetes added 1 cup of vegetables a day to their diet, that's it, 1 cup, right? So probably a heaping palmful, reduced their progression to full-fledged diabetes by 35%.
Wow.
So basics, it's not easy. It falls back to nutrition, helps you out in terms of what you're trying to get your patients to do. So it's very simple things that you want to think about as employers. How can I get these right incentives into my employees' hands to help them embrace that and incorporate that into their lifestyle?
That's a great way to now open it up. We have time for just a couple questions. Are there any questions?
I'm going to start with Paula. If any of you have questions, we probably have time for 2 questions in the room. I'll go to you next. Paula, go ahead.
Yeah, so this was an online question, kind of a 2-parter. One is, are GLP-1s still kind of considered lifelong, or can an individual be titrated down to 0 over time? Part 1. Part 2, if they do stay on them, is it recommended to kind of move over to a less expensive drug for weight stabilization at any point?
Great question.
I'm dying to answer this. So I've prescribed, I've sent thousands and thousands and thousands of prescriptions for GLP in my career, and I've seen patients for many years. And I can tell you that obesity is a chronic disease. And so you can't just give somebody a medication, get them to their goal, stop a medication, and hope for the best. I mean, that's not what works with hypertension. That's not what works with diabetes. That's not what works with any other chronic disease. Obesity is a chronic disease. And so there's all this focus on deprescribing, and it is outrageous.
What about reducing the dose?
Yeah, so basically what we do is, we're very thoughtful on the front end. So don't put everybody on a GLP-1 if you then want to stop it. Don't put them on in the first place. I will not prescribe a medication for a patient unless they understand that they're going to be on some form of medical intervention. Doesn't have to be exactly the same thing, long-term for life. We may have a cure in our lifetime. I hope we do. We're making a ton of progress in terms of treatment. But once we get somebody to reach their health goals, whatever we did to get them there, we were very thoughtful at each step along the way. So I would love to bring 10 patients up on stage who can tell you for one reason or another, they stopped a medication or they reduced the dose for some reason, they regain their weight. So there's studies ongoing right now, but in terms of the evidence, we don't have studies yet showing that, figuring out other protocols. So it needs to be a very thoughtful decision on the front end to not put everybody on a GLP-1 and be very thoughtful about that. And then on the back end, we don't decrease the dose or frequency most of the time. We do sometimes, and sometimes patients can get away with it, and sometimes they can't.
How long is the longest?
We've got about 30 seconds for each of you. Sorry.
How long is the longest study for the GLP-1s in terms of outcome? Is there a 5-year one now? Okay, yeah.
And I would say, like, just remember, every patient is different, and a lot of people don't want to, even though they start the medication and they lose their weight and say we're 2 years down the road and they really don't want to take them long-term, or they have not tolerated the fatigue or some of the side effects long-term. I think we really, hopefully in this 2026 data will show us what that microdosing looks like and some of the long-term maintenance. I'm hopeful that we will have more evidence to back that up, but understand not every patient can continue them long-term. And so I think just some sort of wraparound program and supporting patients that want to titrate over long-term, potentially coming off of them. We do know they will gain weight back, but again, hopefully having those lifestyle modifications in place to help them, so they do have the tools to come off of them if they need to. And it is a hormone therapy, so I mean, it does change your hormones long-term too when you take them long-term. And so we know that hopefully, again, in this new evidence, we find out what that looks like, what it does to leptin and ghrelin and some of those hormones.
So with that, please join me in thanking my clinician partners here.
That was really good, guys.
Right.
All righty. As our speakers are making their way off the stage, wanted to share with you another message from a sponsor, Flight Health. Trestle Tree, sorry. Never mind. These are our sponsors. We had Trestle Tree, we had Flight Health, and we had questions. So check, check, and check. All right. I did want to mention that MBGH has done extensive work in this area of obesity management. We have some turnkey resources on our MBGH website. Here's just a quick overview. We have a toolkit, an action brief. We have videos that you can use with your employees. We have some communications that you can customize for your organization. They're easy to find, they're easy to use, and we're actually doing some updates to them. So they're going to be new and improved before too long. We do have a brand new snapshot document that is posted as of, I believe, yesterday. And this is through some work that we've been doing around non-GLP-1s and the use that they can bring and the benefits that they can bring to your organization. It's a really quick read. Not only did experts in the field help us develop this, but we worked with our employer members to message or to get the right messaging so that you can use the tips easily within your organization. So check that out as well. Now we have a word from one of our sponsors, Knox Health.
50 million Americans have a sleep disorder, but too many of them aren't getting the sleep care they need. Traditional fee-for-service sleep care is uncoordinated and highly fragmented, which means most Americans have never been asked by their doctor about their sleep during routine health appointments and struggle to navigate a frustrating system of referrals to a sleep specialist, testing, diagnosis, treatment, and ongoing care. So their sleep disorders stay unresolved. Comprehensive sleep care can make a world of difference, not just in treating underlying sleep disorders, but also lowering the risk of the most common and costly chronic conditions. Sleep Charge provides a simple and seamlessly coordinated experience for every member. With a clinically integrated team that addresses barriers and supports members along every step of their sleep journey, resulting in more satisfied members, better health outcomes, and significant financial savings. With high adoption, adherence, and persistence rates, our value-based program more than pays for itself.
So we're just going to spend a couple of minutes at the table, letting you converse amongst yourselves, share some of your ideas on what you have heard today that will impact your approach to the trifecta of obesity, diabetes, and heart disease. And if you're at a table with just one person or two people, please join one of those larger tables. We're going to ask just for volunteers at the end to share one or two of your learnings. There's a notepad at your table, so if you can assign somebody to jot down notes, and then we are going to come around and ask for those insights. We're also going to read off some of the insights from our virtual participants. So if you're joining us virtually, please jot down a few things that you think you can take away from today's event. If you'll just entertain me for a moment, because when I'm at these events, I just like to jot down for myself one or two learnings from each of the speakers, because it just helps me to remember their message. So I thought I would share my notes with you, and maybe that would help you jog your memory of what was covered and how you might take some of this back to your organization. So I'm just going to, just in a minute or so, share with you some of the things that I took away. So we heard from Dr. Johnson this morning. She laid the foundation for the wide range of ways that GLP-1s can be used within organizations. And it's not just about treating obesity. There's other comorbidities that it can be impactful for, as well as other indications around chronic disease. We heard from Krista Singleton about all the performance metrics that they use to keep their vendors accountable. I loved her puzzle pieces and how she showed that connecting all these evidence-based approaches with lifestyle modifications are going to give you the best solution. And I kept thinking, boy, if the feds can do this, then I bet employers, we can do this too. Then we heard from our employer panel. We heard that one size doesn't fit all. There's a lot of great and different solutions out there, and they work well for some organizations and not for others. But I did hear kind of a common denominator theme from everybody, and that is their vendor partners are really an extension of their benefits and wellness team. And we heard about the importance of leadership support, using data to drive their strategy, and what employers really want. They want something that's turnkey and that has creative and unique ways to engage their employees. We got that fireside chat between Cheryl and James. We got to hear the manufacturing perspective. We heard about some new medications in the pipeline. And what I heard were some of the shared vision and goals between manufacturers and employers. They too want a world without rebates. They want to make these medications more accessible, more affordable. We heard from our MHPC partners. I just want to put in another plug for some of these vendor partners. These are partners like Vita, Carum, and Inspira that have been vetted not only by MBGH, but by our employer members. So if you check them out and if you're using them as an employer, not only do you get white glove treatment, but you also get discounted and preferred pricing. We heard from Dr. Cheers. She shared her journey about doing the right thing, following the science, doing things that are evidence-based. And sometimes it's okay to break up with a partner if they're not meeting your needs, and to do the bold thing and look at other options. This last panel was awesome, hearing from physicians. Certainly what I took from this is that this is complicated. It's complicated for employers, but it's also very complicated for our members. So we need to be the quarterback as health benefits professionals in keeping the message simple, focusing on integrated care, and continuing to push back on stigma and bias, which is alive and well. And there's opportunities for us to collaborate with physicians and understanding from their perspective how we can have this message that's a little less confusing and helps our members be a little less overwhelmed. So with that, if you could take a moment to share at your table some of the messaging that you heard that you could take back to your organization, jot it down. We'll ask for some volunteers, and we'll be back in about 5 minutes to hear from you. Thank you.
All right, we are gonna circle back up here. We have one more phenomenal speaker we can welcome to the stage. So is anybody willing? We're looking for 2, 3 volunteers who might be willing to share what you talked about at the table. And I'll share mine. One of the comments was, love that the Lilly rep was interested in transparency and removing rebates in the prescription world. So it was one of our online comments. Anybody willing to share? Okay, this table is quite talkative right here. Anybody want to share? Yeah? Okay, here we have a share.
Okay, so I'm Jenny Hendricks. I work at U Chicago Medicine. And I think when you've been part of employer wellness for a long time. So I started in 1996. And I've taken some little adventures. I still feel like we come back to the conversation that our employees are showing up to a place where it's really hard for the healthy choice to be the easy choice. And I had a stint where I coached probably over 400 or 500 bariatric patients. And our curriculum was they had to graduate when they learned about environmental control because they had to control the environment. So it really wasn't on the employer to providing the supportive environment. And I think that's something that we're all just still dealing with. And I think our environments have maybe gotten slightly worse, not more supportive as they've made cuts internally and they put more and more of that responsibility on the individual. So, if those clinicians were to flash a wand on what would happen to your patients when they show up to work, what would you want us to do for them so that they could follow the guidance that they're getting from their coaches and from their physicians?
Thank you. So supportive environment. Any other thoughts? 1 or 2 more volunteers? Yes, Matt. Thanks, Matt.
Okay, so we talked about a lot and have a lot of different perspectives, which is nice at the table. And one of the big things for me was aligning incentives. And looking at HEDIS measures, and we're kind of like laughing because like, when do you see HEDIS measures as an employer anymore? I said, you have to have an annual review with Kaiser because they're the only ones that are showing you those. And thinking about like, how are they managing member health? How is your partners out there? How are they helping you manage that? And I think that was a great takeaway. Also supporting people with multiple comorbidities and the challenges that they have. But I think that lends to something Nara was hit on was the foundation of all this is lifestyle change. And I think there's a little bit of, I can say for myself, there's ignorance in this because we know that that's foundational for people living with obesity, but like, how does that expand further to people dealing with autoimmune diseases or other things that we're like, oh, that takes change. But are we looking at that more holistically? So that's some of the topics. Anything?
Great. Thanks, Matt. Anyone else? I think we have filled our time. We are still on schedule here. Cheryl? Yeah, thank you all for sharing. And we're going to come around and collect those notes too from your table. So you can have those ready.
How did the discussions go? Any big pearls, Dawn? What was the biggest? All good? Yeah, Dawn knows I'm going to miss her because she would do those summaries and we appreciate that. So we do have a vignette by Cardio Diagnostics I want to share right now. Lori? Oh, I guess I have to press the button again. Sorry about that. Thank you, Cardio Diagnostics. I had the pleasure last evening of having dinner with George Huntley, the CEO of Diabetes Leadership Council. He's funny. He writes songs and then sings them. He said maybe he would sing one sentence today. We will see. Let's learn a little bit about him. He has been living with type 1 diabetes since 1983 and is a passionate advocate for people with diabetes. In his former life, he was a CPA and the plan administrator of self-insured employer-based health plans for more than 25 years. He learned firsthand the impact of chronic disease management on his company's bottom line and the importance of strategic health plan design decisions to manage costs, reduce overall risk, and improve health outcomes. And I wanted to make sure that George talked to you as employers about the challenges you face and how to work around it. And I was blown away at his knowledge and how he really understands the marketplace. And again, where some of the skeletons are buried. With that said, come on up, George, and share with us your fall trifecta.
Oh gosh. Okay. My fall trifecta is to not fall walking up the steps. Yesterday we talked about the fall. It gets cool. The temperatures are nice. I like to run. I'm not fast. I never beat the Kenyan, but I like to do it. And so when it turns in the mornings are 50 degrees and not 70, it's a lot easier for me to do that. And I just enjoy that, and I can go longer. The other is it's time to visit with family. Thanksgiving is certainly one of those times, but other times we're going to go visit nieces and nephews and enjoy being together as a family. Kind of reminds us, because you spend most of the year just working, and that just seems to be a time moving into the final holidays. And the other is I'm a singer-songwriter, so I have a gig. I'm a CPA. Nobody as a CPA tries to go out and be a singer-songwriter, but I did. And I have an opportunity to sing for 2 hours my material on October 15th. So I'm very excited to do that. So forgive me for that. I will not, but you can find me on Pandora, Spotify, iTunes. Just look up George Huntley, turn the volume way low. I would urge you to bring, earplugs. So we have the Indy 500. I'm from Indianapolis. So the Indy 500 is something where they give you earplugs for safety purposes. So in my singing, I encourage that. It is a pleasure to be with you, and we're honored to be part of this. And thank you for your time today. Actually, before I do that, I want to say just a little bit. The Diabetes Leadership Council, we are an advocacy organization for patients, for access to care, affordable care, equitable care for all types of diabetes, type 1, type 2, gestational, doesn't matter. We work with state legislators, members of Congress, and employers, CMS as well, to make sure people have what they need. Chronic disease is nobody's fault. We've talked a little bit today about the stigma. I think that's something that we should be talking more about as organizations. And I actually do presentations on obesity, and I really share the stage with a psychologist talking about what happens in the basic policies, the underarching conversations. We talk about lifestyle management, and I'll go into this in a second. You talk about lifestyle management. Lifestyle management is not a punishment. It's a therapy, it's a treatment, it's a help. And it's really important that when we talk about having lifestyle management as part of our program, it's not, you've got to do this first before I get to the reward. This is part of therapy, and that's got to be in all of our thinking and psyche. And it's going to take us a long time. It's taken us a long time to get to this point where we're talking about obesity as a disease. So give ourselves some slack for that, but we still have a ways to go in that. So we're going to talk about diabetes, because now we want to talk about something sweet. All right, diabetes is an epidemic just like obesity. 1 in 8 adults have diabetes. It's a big, big problem. You all are paying for it. 38 million Americans have diabetes. We're going to come back to that stat in a second. 5 to 10% are type 1, which is an autoimmune disease. 95% are type 2, which is metabolic syndrome driven by, guess what, obesity. So we all know why we're here with this, but it's a big piece of your health plan. It's a big piece of the population. This is the heat map growing from 2004 to 2021. We saw a similar map on obesity. This looks just the same. This is more down to the congressional district, to the zip code. You can kind of see where you live. It is by definition, almost everybody's darker than they were in 2004. And that is not because you've been out in the sun getting a tan. Why is diabetes expensive? Why is obesity expensive? Because it is a chronic and progressive disease. It is the complications of diabetes, as is the complications of obesity, that cost money. And by the way, also are very devastating to patients and their quality of life, their health. Diabetic retinopathy, eye disease, 1 in 3 over the age of 40. I am going to knock on something, wood or rock. I have not had that yet, but I've had it for 42 years. 2 to 4 times more likely to die of heart disease, heart attack, stroke, kidney failure. You go to a dialysis ward, you're going to see a lot of people with diabetes. Yes, they probably also have obesity. Lower limb amputations, 60% of non-traumatic amputations are caused by type 2, by diabetes, by uncontrolled blood sugars. It's these things that are driving healthcare costs. It's not the cost of medications. It's the cost of not taking the medications. It would be a theme in what I'm going to be talking about. So it's a major plan driver. 1 in 4 health dollars are spent in 2022. You guys know what you're spending in your plans. You probably actually do know that, what you're spending on diabetes. That's probably something that is reported to you. I bet you that you don't have a similar stat for obesity, because obesity hasn't been tracked. It's not even in the medical, it's not in many patients' charts that, oh, they have obesity and you're tracking that. Why would that be? It's a head scratcher. Well, obesity has only been a disease since 2013 in this country. It's been a disease, physiologically much longer than that. But it's a relatively new disease. Also, staying on obesity for 2 seconds, we're not covering it. So why would the physician check the box? If they check the box, it's another excuse not to pay for it, because the obesity was never paid for. So you don't have the stat on how much obesity is actually costing you, because it's not checked in the charts. So keep your eyes and ears open on that. The ROI of obesity, the true cost of obesity, is just beginning to be understood. We do know it. We do know diabetes. And we're not doing a very good job of controlling diabetes, much less obesity. 38 million people have diabetes. They go to the ER 19 million times a year. That's crazy. We go to the ER 19 million times a year. We must really like the ER. But that means we're paying for the wrong stuff. And so our health plan design and our chronic disease management really needs to be focused on care. And I think this conversation today, everybody in this room gets that, but we've got to get that really implemented in our plans so our people aren't the ones in the ER. Let them be other people's people. And maybe having a lot fewer of those visits would be just wonderful. Insurers report 3 times the spend if a person with diabetes has a complication than without diabetes. I am expensive. I get it. I'm worth it, but I'm expensive. I know it. So why is it so hard to manage diabetes? And I'm not going to go through this slide in every detail, but I want to get back to explaining why this is a difficult disease to manage, even with all of the tools. Obesity is similarly difficult to manage. It is not the patient's fault that they have the disease. If only they would eat right and exercise, everything would be okay. Well, from a blood sugar perspective, all of those things about what food do you eat, what's the carbohydrate, what does that what impact does that have on my blood sugar? You heard other folks talk about CGMs. I've got a slide on a CGM in a second. All of these things impact things slowly. I could do exactly the same thing 2 days in a row and have completely different blood sugars 2 days in a row. And it'll drive you bananas. Trust me, I've done it for 42 years. No 2 days are ever the same. If you eat a meal and you start with a salad and then have the pasta and then have you will actually have your blood sugar spike less than if you skipped the salad and went right to the pasta, because it's going to go right and digest that pasta quickly and turn it into a higher blood sugar spike. The timing, what you eat, what's on that plate, how stressed are you, your fight or flight. You're sitting at your desk And people say, get off, get up and move around, which is why I'm doing this. You're sitting at your desk and your stress, your blood sugar is going up. Well, I haven't moved around. Why? How could that possibly, what's going on? You're stressed. And that stress could be from work. It could be from your family. It could be anything. But what happens in stress is your liver kicks out some extra glucose so that you can run away from the lion that is not chasing you. But you've got extra energy, and that extra energy turned into blood sugar because you have diabetes and you are not dealing with the sugar in your blood efficiently and effectively, so your blood sugar goes up. And that's just stress. And we have stress everywhere. Behavioral decisions, whether you're exercising, I do love to run. If I run far and long, the first 40 minutes of my run, my blood sugar goes down. The next 40 minutes, my blood sugar goes up because I'm now stressing my body and that I am trying to run away from the lion, and I'm finally getting some help to do so. It took me forever to realize that they made those goos for runners in a marathon. They weren't for people with diabetes in case they go low. They're actually for the runners so they can finish the race. So you actually have to eat the goo while you're running. It's amazing. But all of these factors impact how your blood sugar, how your body produces and handles the blood sugar. It is a very, very challenging thing. So my point to you is your people are struggling, and the best thing we can do is help them. So innovation has come along. These CGMs are absolutely amazing. If you've never worn one, go buy one just for fun. They do cost a little bit of money, but the over-the-counter ones. But you've heard a lot. I was actually going to be talking about and suggesting that, but so many people have actually said to do that. Honestly, the information, if you don't have diabetes, you don't want one for the rest of your life. But it gives you amazing information. One of the things it does, so you can see the chart on the left versus the chart on the right. The chart on the left, the CGM is the same, is giving you this data. What gets measured gets managed or improved. I think somebody had said that before. I like that analogy. You tie the CGM with an advanced insulin delivery system, and you can achieve a much tighter time and range, which is what you're seeing there. I assure you that the quality of life on the right is substantially better than the quality of life on the left. You feel horrible on the left. I've been there yesterday, actually, a little bit. But when you're able to stay time and range, you are much less likely to be in the ER, but you're also a much more productive employee, and you're just overall happier. So this technology is absolutely amazing, and it's really important to get access to it. I also want to say choice in technology is really important. Okay, this is not one size fits all. There's glucose monitoring, these are the CGMs, and the insulin administration, which are the insulin pumps or the insulin pens, et cetera. Even people with type 2 diabetes are often on a pen. It could be a smart pen. Some of them are on pumps now. Let me just say 1 in 3 adults with diabetes takes insulin. So you think about type 1 diabetes is you don't make insulin, it's autoimmune. I've been on insulin for 42 years. In type 2, 1 in 3 are on insulin. You think most people, with type 2 don't get to that point. It is amazing how many, because the goal here is actually to manage your blood sugar, not to stay off insulin. But if you do have insulin and you are on insulin, you darn well better have a CGM. And I would urge you to give them access to an insulin pump if their doctor prescribes it, if they think they need it. But they do act differently. They interface with different pumps. So one CGM will not interface with all pumps. And so if you are talking to your PBM and in their infinite wisdom, they decide to only cover one CGM, you have actually limited and turned off the automated delivery system of some of your employees' pumps. That's a really, really bad idea. And the pumps themselves, you see a patch pump in the palm of the hand down there. You don't really know what that is. There's probably how about that? All right, you see it. That is a pump that gets worn on the arm or anywhere on the body, but it's attached, and the insulin is in there, and there's no tubes. This pump, and it's actually the pump I actually wear, has a tubing attached to it. Some people don't want tubes. I promise you, I know where every knob is in my bathroom because I have a pump with a tube and I can, you're, oh, darn it. And it happens. And people with diabetes, you get that joke, and some of you do, and some of you are like, oh my gosh, he's really weird, and he is. But it's true. But some people don't want tubes. Cover what they want, cover what they'll use, because the best device is the one the patient will use. Patient choice is really, really important. Children strongly prefer, as a group, patch pumps. I'm on the treasurer of a group called Children with Diabetes, a wonderful organization. They do the largest type 1 patient gathering on the planet in Orlando in July. Horrible. Don't go to Orlando in July, but the kids love it. But we track which kids are on pumps, which pumps do they like. They overwhelmingly like patch pumps. Adults tend to like the tube pumps. Doesn't really matter. Give them what they're going to use. Their health outcomes are better, and it will work better for them. It will work better for you. Don't limit this. They all cost about the same. All right, now I am going to, how many of you know the Broadway musical Rent? 525,600 minutes. How do you measure a year? That's all I've got for you. But, so this is actually, I want to spend a moment on this slide. That's a lot of minutes, and your employee, the person living with a chronic disease, is getting precious few of them with a healthcare provider. If you've provided coaches and something like that, other things, you've done a great job because you've expanded that little slice there. And if you expand that little slice and double it, well, that doubles their chances of knowing what they're doing. This is a very difficult disease to live with, as is obesity, because people, I think doctor was saying, they come to me, they're confused. Of course they're confused because they're looking at Google for their information. But the more information you can give a person living with a chronic disease, the better off they are going to be, the better off you are going to be as far as keeping your healthcare costs low and having your employees be more productive. Now let's talk about diabetes education. Diabetes self-management education is really essential. We talked about medical nutritional therapy, and I'm going to come back to that. DSME is really important. Chances are you cover it. Chances are you cover it with a whole bunch of limitations. Well, you're idiots. I'm sorry to say that very nicely. But if you have a limitation on diabetes self-management education, go slap yourself silly and change it, because diabetes is 24/7, 365, and your needs, your experience, your journey changes as you age, as you go. You may now have children and you've got other things going on in your life. I may need to have some counseling on how do I manage my diabetes with these things going on. Maybe I've just switched to a pump. Maybe I've switched from this pump to that pump because my coverage forced me to do so. I need to know how to use this and how to make the best decisions I can. Maybe I've gone from multiple injections to a pump. I need some help on that. Maybe I have type 2 diabetes, which most of your groups do. If you think about it, it's the larger part of your population. They need help. They need medical nutrition therapy. They need diet, lifestyle intervention. They also need to understand how to manage their blood glucose, measuring it, CGM, blood glucose strips. Their lives change. Every time your life changes, I've now gone, I showed you the 42 factors. Now I'm doing something different, and this factor is now changed. They need help. If you put a limitation on their ability to get help, shame on you. It's built into your plans. It's not personal. You didn't do it yourself, but go look and remove that. That is the cheapest therapy you can invest in. It's the cheapest in therapy you can possibly invest in is that. Now I'm going to turn the page backwards because it's the same page, guys, on obesity. Medical nutritional therapy is the cheapest thing you can provide. And we're not providing it. We're not covering it. And why are we not covering it? And I'm going to say the same thing about intensive behavioral therapy. You heard Dr. Singleton talk about IBT. We're not covering IBT. Well, it sounds like bariatric surgery or something, but it's not. It's IBT, it's intensive behavioral therapy. Why aren't we covering it? Well, our health plans are following a playbook that says don't cover anything. You know, the more I cover, the more it costs me. They're not doing an not doing an ROI on it. The second thing is they're also following CMS, which is Medicare and Medicaid services. And many commercial plans start with CMS as their baseline. This is the CMS is covering it, therefore I'm going to cover it too. And this is the baseline for starting it. CMS, we did have a fantastic presentation from the person from the government. I was actually impressed that there was some intelligence in the government. It was really wonderful. And I'm being facetious. It's the end of the day. But CMS does not have infinite wisdom on what should get covered. So IBT at CMS is covered in 15-minute increments. Intensive behavioral therapy done in 15-minute increments. Is that intensive? That's anything but. But that is, in fact, all CMS Medicare will cover. And by the way, it has to be covered in a primary care setting. Now, those therapists don't exist in a primary care setting. So the government has not spent a lot of money on IBT, I assure you, because nobody's getting it. The similar case on MNT, it's just not covered. So I urge you, you are not the government. You are employers that have the ability to take control of your plan. Please take control of your plan and look at these things. Look under the hood at what you're really covering and ask some hard questions to make sure that your people are getting what they want, what they actually need. So how do you make diabetes a little bit more affordable? And I'm going to make sure I'm going to speed through here. Your benefit design structure is really important here. If you are on insulin, you are on blood pressure medicine, you are on some, you want the person to take it. If your plan design has them paying full retail, and that probably happens certainly during their deductible period, not many people can pay $1,200 a month. If you're passing through rebates, maybe they're paying $360. I'm going to talk about that in a second. Or you're going right away to a low predictable copay. The person with $25 copay, they're probably staying on their meds all 12 months of the year. But the person who's doing this and this, you're probably not getting adherence to therapy for 12 months out of the year, I can assure you. And if you think you are, you're wrong. 69% of patients will abandon their prescription at the cash register if it costs more than $250. And we know from an Express Scripts study that if you capped costs at $25, 16% overall reduction in medical costs for diabetes. That's worth it. You know about rebates. I'm not going to spend a lot of time on this, but insulin was the poster child as the rebate caused the list price to go up 143%, but the net cost to your health plans actually cut more than in half. So diabetes became the poster child drug and poster child disease state to talk about rebates and what's happened. And we would all love to get rid of rebates. I'm not going to go through this slide. If you have any questions, you can ask me afterwards. We call this the hairball. And you know that the three PBMs, the top three, are owned by or part of the corporate family of the three insurance companies. So it doesn't matter who's keeping the rebate because it's all staying in the family. My pitch to you is pass those rebates through to your people. Now, I did this for 10 years in my plan, not 25, because I didn't know what they were for 15. Pass these rebates through to your people at point of sale. All of the PBMs will do it. If they turn you down, find a new PBM. I can talk harshly like that, but they will do it. They've all been on record in front of Congress saying they think they should be passed through to patients, and they encourage their employers to ask for it. Now, there's a Milliman study. Some people like Milliman, some people don't, but the study says estimated impact of passing rebates through a point of sale in your health plan is less than 1%. Now, why could that possibly be? Well, you guys are not buying drug insurance, you're buying health insurance. Drugs are a 15% of your health plan, plus or minus. Maybe it's 10, maybe it's 20. If it's closer to 20, it means you've got a lot of specialty drugs and things are going crazy. Specialty drugs are not driving rebates because they take you right past your deductible in a heartbeat. So if you are overcharging your people, and I want to say this, I have had diabetes for 42 years. I have met my deductible for 42 years in a row. I am proud of that string. It's amazing. Hopefully sometimes they applaud when I say that. I just don't know. But if you charge me more for my drug, if you inflate, because the average rebate on a branded drug is 48%. See, if you double charge me for the drug, I'm going to meet my deductible early, and congratulations, you're going to pay another claim that you never would have paid. There's no savings there. There's nothing in it for the plan other than you're training your people to ration their meds. And you don't want to train them to ration their meds. You actually want them to take the meds. So I encourage you strongly to pass rebates through at point of sale. Look at your health plan on generics and biosimilars. The lowest cost drug does not always win. If you've seen the PBM stories, they have an incentive to put the high cost drug on the plan. So if you lower the cost of the drug, sometimes they will put it on a higher tier higher pay tier because they actually want the patient your employee to pay and buy the drug that has the highest rebate because they're taking a cut of that rebate. So I would urge you to look at your plan and make sure the lowest cost drug in every class is included. That requires you to get down into the weeds. You may need to want to hire a consultant for that, but there's money there and your people are getting taken advantage of. High deductible health plans. High deductible health plans increase the risk of diabetes complications. This study was done by JAMA. 11% increased heart attacks risk, stroke risk at 15, hospitalizations, 38% rise in hospitalizations by having a high deductible health plan. Everybody has a high deductible health plan. It's not helping. End-stage renal disease, lower extremity complications, huge percentage increases in the risk. Really look at the affordability for your people because you don't really want them having any of these things because they are so much more expensive than the rebate you failed to pass through. They are so much more expensive than the education you failed to give them because you limit it to at two per year. These are what you don't want to have happen. Very, very quickly, fiduciary responsibility. Somebody said this, we are now fiduciaries. I'm going to just touch on this briefly. ERISA, Consolidated Appropriations Act says now employers are fiduciaries of their health plans. It was always suspected that we were. I always assumed I was. We have a duty to act prudently. We have a duty to comply with plan provisions. We have a duty of loyalty to the plan participants and the beneficiaries. And why do you have this duty? You have that duty because you're taking money pre-tax out of their paycheck. Granted, you're similar to the 401k. The 401k plans are under the same ERISA bill, and you have a fiduciary. You got to make sure you're managing their money correctly. In that instance, you're only matching a little bit of their money. It's all their money. In this case, you're taking a little bit of their money and putting much of yours in, but you still have a fiduciary responsibility. There's been 3 major lawsuits. Johnson & Johnson's has been dismissed, but on a technicality, Wells Fargo, JP Morgan are still being sued by their people on the drug plans. Breach of duty to manage drug costs, charging inflated prices. Sound familiar? Not covering lower cost generics in the plan. They're being pushed out. Generics, ask yourself, how long does it take a generic to actually make it on your health plan formulary? It'll stun you to find out it's not the next day that they're launched. It might be 1 to 2 years before your health plan picks up the generic. I could talk about, there's 2 manufacturers of insulin in this room that, that actually came out with a generic of their own product so they could offer it lower. Who in the world creates a generic of their own product? On what planet does that make sense? It's happening here because they couldn't offer it for a lower price. Steering participants to a more expensive pharmacy specifically for specialty drugs. I'm going to just second on that. There are a lot of pharmacy deserts in this country. And many of you have employees across the country. You know, the ones that are, the pharmacies are closing. It's really hard to get there. Don't be part of the problem. Okay. This is happening because the PBMs are pushing you to their pharmacy and you can't fix this, but they're saying, all right, I'm going to then reimburse my pharmacy at this level and anybody who's not my pharmacy at that level. And that level happens to be below cost. So many pharmacies are closing because the reimbursement that they're getting from the health plans, i.e. you guys, but really through your PBM, is below cost. And that's causing health plans and pharmacies to close. Don't be part of that problem, but be aware of it. So I urge you to look at this. This is out of the 401k playbook. Steps to consider if you're going to have a fiduciary responsibility: form a health plan governance committee. Get formal with this. Take minutes. Confirm fiduciaries are covered under your existing liability policies, indemnified in plan documents, and make sure their agreements with you indemnify you in the process. It probably is in there for most of them, but you should be looking at all of these things and establish a periodic review process of all vendors and fees. In 401k, it is just automatic. It is automatic, and people don't even think twice about it. If you've been with the same PBM, the same vendor process for more than 3 to 5 years, just take it to market. I know it's a pain in the backside to change this. I do get it. It's the same, it's similarly painful in 401k, but you have a duty to do it, and you don't know until you've gone to market and found out. So pass-through rebates at point of sale, ensure the lowest cost options are available, require transparency on all costs. I was thrilled to hear 21% have switched to a transparent PBM. I've been giving this talk since pre-pandemic, and I used to have people throw me out saying, we have rebates and we understand it and they're good and that we're going to keep them all. We've come a long way in understanding what they're doing and what they're doing to the economics of healthcare. Really look at your plans and make sure you're managing that process. They are your vendor. They are lucky to have you, not the other way around. And so treat them that way. Eliminate spread pricing. Don't get taken advantage of. Review mail order requirements. This is one of these weird ones, but mail order requirements say I'm going to ship. Shipping insulin is a horrible idea. Shipping GLP-1s is a horrible idea. It needs to be refrigerated. It needs to be at a certain temperature point. FDA controls of these stop at the shipment from the warehouse to the pharmacy. And that pharmacy is a mail order pharmacy. There is no control of when it leaves the pharmacy, the mail order pharmacy, to your home. If you live in Phoenix in the summer, it could boil. It doesn't work so well when it gets above a certain temperature. If you live in Buffalo in February, it can freeze. It absolutely does not work when it's been frozen. And there's been many, many cases. There was a whole New York Times study on this. In fact, it's referenced in the footnote of people it's not chemotherapy, but anti-rejection drugs, and they've gone through transplants, and they really had massive health problems because they chose and were forced to send these specialty medications through the mail, and bad things happened. And these people had insurance through their employer. So look at these things. I really appreciate your time. So I know we're at the end of the day, but thank you for paying attention. 525,600 minutes. I'll see you next year. I know.
All right, thank you, George. That was awesome. All right, we do have another educational piece on our website. Check that out. It's under the resources tab. We have one last video. So American Diabetes Association.
This year marks our 85th anniversary, a milestone that fuels our commitment even more. For 85 years, we've been fighting to improve lives and end diabetes, and we're not stopping now. Every day, we push forward, knowing that each small win leads to a transformative change. Together, we create hope, support, and progress Let's keep fighting for a future without diabetes. Learn how you can join us in the fight at diabetes.org/get-involved.
All right, and if you do want to learn more about this topic, there is an event coming up here locally at Malcolm X College on November 13th. It's in the morning from 8 to 11, so mark that on your calendar. Here are some of our other upcoming events, which we've already talked about. The evaluation that is on your mobile app is super important to us. So if you go to your mobile app under the polling tab or under the evaluation tab, there is a super short evaluation. If you could give us your feedback in just 1 minute or less, I'm going to give you some time to do that. And then we're going to go on to some prizes before we adjourn.
All right. We are past time. Let's go ahead and wrap this up. We're going to give out some prizes. It's the fun part of the day. Woohoo! Okay. So an Ember temperature controlled smart mug from Moby goes to Victoria Garcia. Okay. A Ninja NutriBlender Pro with Auto IQ from Wonder Health goes to Amy Hutkowski from Fortune Brands. All right, it's a big one. $200 Amazon gift card from Trestle Tree goes to Jenny Hendricks from University of Chicago Medicine. Another Ember temperature controlled smart mug from Verta Health goes to Melissa Dabrowski, Constellation Energy. We have AirPods Pro 3 from Knox Health. That goes to Mandy Clay. This one sounds fun. A Vita Rumple Puffy Blanket from Vita Health. And this is an online attendee. Thanks for being online, Mindy Paulette. She had a lot of comments and questions today. Another online $100 Amazon gift card from Inspira Health goes to Dawn Perlman. All right. A Bordier large cheese and charcuterie board goes from Cardio Diagnostics goes to Paige Han, H-A-H-N-E, another online. And some fun custom Nike sneakers from Karam Health goes to Eric Earhart from Fortune Brands. New tennies. And we just want to thank you all again. We know this is a busy time of year. We appreciate your attendance and participation today, and we look forward to seeing you in January for the Wellbeing Forum. Have a great evening.